has been done. And the maternal cardiovascular hemodynamics is aptly represented or reflected by mean arterial pressure. Now, I'm not going to details of this, just superficial information so that we can all know how the ASPIRE trial was studied. So uterine artery is a principal, it's a principal pillar of the combined multi-marker screening for preeclampsia, and it is done between 11 to 13 plus 6 weeks. But if we use uterine artery alone, we would detect only half of the women who are going to develop maybe early preeclampsia at a false positive rate of 10%. And definitely we need to improve upon this, because as I already said, any screening protocol during pregnancy should have at least a detection rate of 75%. And when we use uterine artery Doppler, we should use a pulsatility index because it reflects the physiology much better than the other markers. Now, the ISCOG has recommended that a pulsatility index of more than 90th centile should be taken as abnormal in the first trimester. And if you are in a peripheral setting without any availability of any resources, you can always use a cutoff of 2.35, which is more than 95th centile for all the gestational ages. Now, there are various factors that can affect uterine pulsatility index, and I'm not going to the details of the same. So biochemical factors, just like your Down syndrome screening, should be assayed in standard platforms. That means you should send a serum sample to standard laboratories that are working on Fetal Medicine Foundation UK approved platforms. Similarly, not just the blood pressure, but we need to take the mean arterial pressure, and there is a very specified technique for the same, as beautifully recommended by the Fetal Medicine Foundation UK, as is shown in this picture that is from our department. Now, just like the other parameters, if you use the mean arterial pressure, if you add this to uterine artery Doppler, it increases the sensitivity from 47 to 52% with slight reduction in the false positive rate. The Fmf algorithm for the preeclampsia is based on taking the 12 aspects from the medical history, combining this biochemical and biophysical factors, and incorporating this into an algorithm that is based on Bayesian model. That is a priori risk of the woman. That is the risk of the woman for developing preeclampsia is multiplied by the likelihood ratios of this individual parameters, and we get a final risk just as in Down syndrome. Accordingly, we classify the woman as low risk and high risk for mostly preterm preeclampsia based on a cutoff of 1 in 100. And women who are low risk receive routine antenatal care pathway, whereas women who are high risk, they are offered aspirin, their calcium dosage is optimized, and serial maternal fetal surveillance is instituted. Now, if you go through the performance of the screening strategy, it has been widely validated in different platforms. And going back to the first study, as I said, the first paper that introduced this concept of combined multi-marker screening in 2013 from the Fetal Medicine Foundation, led by our own Ranjit Akolekar, showed that in a study of around 60,000 women, it could detect more than 96% of early preeclampsia. For the knowledge of the audience, early preeclampsia is the one which develops before 34 weeks of gestation. It could also detect almost half of all the preeclampsia cases in the study. Now, a fantastic aspect of this is when the ASPIRE trial was done, the details of which I'll be sharing later. In a cohort of 1,776 women, the figures were surprisingly similar. So if you see the percentage of the detection rate for preeclampsia before 34 weeks, you would see that almost 95% of women were found, 96% of women were screened by this strategy. So not just in the setting of Fetal Medicine Foundation UK, this study has been validated in various other centers from Europe, led by people who have been trained in Fetal Medicine Foundation UK, and they all found that the figures are surprisingly same. More than 90 to 95% of early preeclampsia and about 70 to 75% of preterm preeclampsia can be screened using this multi-marker approach for preeclampsia screening. And not just in Europe, this study has been also replicated from various other centers across the world, and all of them have written the same figures of performance or validity of this strategy. So the natural question is whether such a study has been done in India. Yes. So under the leadership of Leona Poon et al. And various researchers and fetal medicine specialists in Asia, this study this multi-marker screening for preeclampsia was studied in various countries across Asia. And even in this setting, we found that almost 70 to 75% cases of preeclampsia, the early preeclampsia could be picked up using this multi-marker approach. Now, let us come back to the crux of today's topic, aspirate trial. Now, how has this made a difference in the medical practice regarding the screening and intervention for preeclampsia? Now, aspirate trial was published in the New England Journal of Medicine 2017. This was a randomized controlled trial, a double-blinded study with intention to treat analysis that was performed in 13 hospitals across 6 countries. And it was a placebo-controlled studies. And basically, after applying the exclusion and inclusion criteria, there were about 2,600 women in the study who were randomized in a blinded fashion to aspirin and placebo. Now, what the study found is, in the study, basically, low-dose aspirin was used. For the knowledge of the audience, low-dose aspirin means less than 300 milligram. And in the study, 150 milligram dosage of aspirin was used, and it was initiated before 16 weeks. The dose was administered in the night, and the endpoints for stopping preeclampsia in the study were 36 weeks, development of preeclampsia, or delivery due to aneurysm. The key finding of this study was that it reduced the rate of preterm preeclampsia, that is preeclampsia which requires delivery before 37 weeks of gestation, in a significant fraction. There was almost 62% reduction in the incidence of preterm preeclampsia. Even though there was no significant effect of in the incidence of term preeclampsia, as I would show in a later slide, the occurrence of preeclampsia was delayed because of the usage of aspirin. So this is a pictorial representation of the impact of aspirin in for prevention of preeclampsia in the study, and we see that almost 62% of preeclampsia were prevented, of the preterm preeclampsia were prevented, and the performance was much greater when you consider the early preeclampsia and the very early preeclampsia. Now, Fetal Medicine Foundation, based on this data, did a wonderful study where they compared the NICE guideline for screening of preeclampsia with their own combined multi-marker study. And the results of this study were very interesting. So as shown in this table, women who were screened positive based on the presence of major or minor factors and were also screened positive based on the FMF multi-marker screening had a high incidence of preeclampsia, both in the high-risk group as well as the moderate risk factors. But the most interesting finding of the study, which I want to convey to all the audience and especially the obstetricians, is when one or more of the NICE high-risk factors were present, but the women were low risk in Fetal Medicine Foundation combined screening for preeclampsia, the incidence of preeclampsia was actually less in them in a significant fashion, right? So what the study means is that even if the woman is having one or more risk factors, such as a history of preeclampsia in the previous pregnancy or a history of multiple miscarriages, but if they are low risk in fetal by the combined multi-marker screening as proposed by Fetal Medicine Foundation, the chances of them developing preeclampsia is going to be less. Similarly, the aspirate trial, the data was analyzed in different manners, and they all found that the efficacy of aspirin was actually greater when the woman had one or more risk factors. Just for an example, a woman with BMI more than 25 kg per meter square, the reduction of preeclampsia was much more than in women who had a low BMI. And this was only exclusion for this was the presence of chronic hypertension. Similarly, they found that women who take aspirin in a more compliant fashion have a greater risk of reduction of preeclampsia in them. For example, when there was more than 90% compliance in taking aspirin during the antenatal period, the risk reduction of preeclampsia was much more than when the compliance was less or when compared to the entire population. Similarly, this is a very important thing that most of the obstetricians would be wanting to know, the risk of aspirin and placental abruption. Now, what is this meta-analysis, which was actually performed after the aspirate trial and which has included the aspirate trial, they found that women, when started with the correct dose of aspirin at correct time, that is before 16 weeks, had a greater risk, had a lower incidence of preeclampsia than when aspirin was given in some other dosage after 16 weeks or less than suboptimal doses of aspirin were administered either before or greater than 16 weeks. So essentially, it means that when you offer the combined multi-marker screening and you offer aspirin only to the screen positive woman, rather than giving aspirin to every woman who has one or more major risk factors, the incidence of placental abruption is actually reduced. So this is a very, very important finding, which was reflected in the best research model, that is a meta-analysis, and this had ASPRE data also with this. Now there were several secondary analysis of the ASPRE data, which is also very useful for our clinical practice. Now, not just the incidence of preeclampsia, the judicious use of aspirin in screen positive women reduces the incidence of NICU admissions in a significant fashion. Similarly, the incidence of death and disability at 2 years of age is also significantly reduced by, again, judicious use of aspirin in only the screen positive woman. Not just that. Now, many would have doubt that the preeclampsia multi-markers, the aspirin prevented only 62% of preterm preeclampsia. What about the rest 38%? Now, this was a secondary analysis done by Wright et al. Based on, again, the data from the ASPRE trial, and they found that use of aspirin actually delays the onset of preeclampsia, allowing for a delivery closer to term that prevents many of the fetal and neonatal complications. As is shown by this picture, the use of aspirin, most of the women who developed preeclampsia were very close to term, whereas when women who received placebo had greater incidence of early onset preeclampsia. So therefore, this means that even though aspirin may not prevent the development of preeclampsia in all the women, it delays the development of preeclampsia, allowing for delivery towards a term, thereby reducing several neonatal complications in an effective fashion. Now, as I said, the highest level of evidence is a meta-analysis, and this meta-analysis, which was published in the year 2018 in the American Journal of Obstetrics and Gynecology, which include 45 randomized controlled trials, including the data from ASPRE trial. What this data found that women who were offered aspirin of at least 100 milligram or more before 16 weeks had a greater reduction of the incidence of preeclampsia, severe preeclampsia, and fetal growth restriction. So the important aspect is aspirin, at least 100 milligram initiated before 16 weeks. On the other hand, if aspirin was initiated after 16 weeks, and if the dosage was suboptimal, the reduction you see is more of a flat line here, right, compared to the figures here. So this shows, this meta-analysis itself is a very strong supporter of for the combined multi-marker screening and the use of aspirin in screen positive women. And what it essentially shows is when aspirin is initiated at the correct dose at the correct point, the reduction of preeclampsia, severe preeclampsia, and even fetal growth restriction is much more than women than if it started 16 weeks. So this answers a great number of queries. Can we start aspirin after 16 weeks? Now we of course can start aspirin after 16 weeks because it is a relatively safer drug. But remember that the effect or the beneficial impact of starting aspirin after 16 weeks is either minimal or completely negligible if we see several of these conditions. And not just preeclampsia or NICU admissions, but the usage of aspirin in screen positive women reduces the incidence of fetal growth restriction related to preeclampsia by at least 50%, reduces the preterm birth and perinatal death by at least 60%. Now, as a screening protocol, this has not yet got the approval of ACOG or RCOG or NICE, but this combined multi-marker screening and the use of aspirin based on the research from Fetal Medicine Foundation has now received the approval of ISUOG, which has brought about a consensus statement in 2018 and by Figo in the year 2019. And what both these premier societies in the field of ultrasound in obstetrics and gynecology and in the care of women health say is that all women can be offered aspirin. All women can be offered combined multi-marker screen for preeclampsia, and aspirin can be started in the screen positive woman. And now all this is based on the research from Fetal Medicine Foundation UK, especially the ASPRE trial. So the take to practice messages are: offer preeclampsia screening to all women between 11 to 13 plus 6 weeks. So along with your NT scan, perform uterine artery Doppler, note down the important factors from the maternal medical and demographic history, and depending upon your resources, obtain mean arterial pressure and offer biochemical screening. And just like your Down syndrome screening, this can be offered to all women between 11 to 13 plus 6 weeks. Screen positive is based on a cutoff of 1 in 100 as of now. Most of the labs take this as a cutoff for preterm preeclampsia, that is a preeclampsia requiring delivery before 37 weeks of gestation. In screen positive women, aspirin has to be started at least before 16 weeks of gestation for the full beneficial impact. Now, the dose can be slightly reduced if the woman is having a much lower weight of less than 45 kg. But for all others, one can safely start a dosage of 150 milligram. And rather than in the morning or the afternoon time, which is the most common time aspirin is prescribed, the best time to for the woman to take aspirin is night time. And this is all biologically proven. These are not random statements. Aspirin can be started once 36 weeks has been reached without any maternal or fetal complications, or if preeclampsia has developed or delivery has been required because of some or other reasons. And universal administration of aspirin, which is a widespread practice, especially in hospitals with who have women with high risk factors due to other reasons or infertility conceptions, is actually harmful. Not only the resistance to aspirin develops in 1/3 of cases, it increases many of the maternal and neonatal complications, including bleeding. So Aspire trial validates the combined screening for the preeclampsia and correct usage of aspirin. What if you're working in a limited resource settings? What if the patients cannot afford the biochemical screening? Now that is not an issue. You can always combine a maternal demography with one of the biophysical components. So you can either combine with it with mean arterial pressure, or you can combine maternal demography with uterine artery Doppler, or you can combine maternal demography with both of this. Now, if as more and more factors are added to it, the sensitivity, that is the detection rate, increases, and the need for unnecessary administration of aspirin falls. So with this, I conclude my presentation, and I advise all the audience, including the obstetricians present in this meeting, to offer preeclampsia screening along with Down syndrome screening during the 11 to 13 plus 6 week scan, and to reduce the usage of aspirin only in screen positive women, and to avoid the widespread practice of universal administration for aspirin, as has been shown by my previous slides. Thank you so much.
Thank you so much, Dr. Sunesh, sir, for taking us through the extensive research work that has happened in the field of preeclampsia screening. And a very important take-home message is that there should not be a universal administration of aspirin, but of course there should be implementation of universal preeclampsia screening. Even if there are not multiple markers algorithm available in low resource settings, we can combine the demographic factors with the mean arterial pressure and the uterine artery Dopplers wherever possible. And of course, when aspirin administered in the correct dosage and at the correct time of the gestation, it has shown to improve maternal as well as neonatal outcomes. So thank you so much for an excellent talk, sir. So moving ahead, we would like to introduce.
Sorry, Sassin, sorry to interrupt. Sinesh, please stay until the next session to take the Q&A.
Yes, sir. So it's a request to all the delegates that they can type all their questions and queries in the chat box, and we'll be addressing them after the next session. So I would like to invite our next eminent speaker, Dr. Suresh Shadri, sir, who of course does not require any introduction. He is the pioneer of fetal medicine and fetal therapy in India, and has got a whooping enormous experience of 39 years in ultrasound. He is the director of Mediscan Systems Chennai, honorary secretary at the Voluntary Health Services, and also visiting perinatologist at SRMC and PSU hospitals. He is the Indian ambassador to ISWOG, and he is also a member of the ISWOG VT task force. And he has trained thousands of doctors from across the India and abroad as well in ultrasound and fetal medicine. His main areas of interest include prenatal diagnosis, fetal therapy, and ultrasound education. So as we all know, after preeclampsia, one of the associated complications is fetal growth restriction. And there has been extensive research for the etiopathogenesis and prevention to some extent, and the management protocols have been changing. And it's a very common problem we come across in our day-to-day life as a fetal medicine specialist. And of course, it has got implications in the immediate neonatal period as well as far-reaching in the adult life as well. So I would like to call upon Dr. Suresh sir to enlighten us on the current recommendations from ISWA on the management of fetal growth restriction. Good morning, Dr. Suresh sir.
Good morning. Are you able to hear me? Are you able to hear me?
Yes, sir.
Yes,
Very
you're
well.
audible, sir.
Good morning, sir.
Are you able to see my slides?
Yes, sir.
Yes, sir, your slides are visible, sir.
Good morning. First of all, thank you very much for asking me to participate in FETOMAT 2022. And today the topic is diagnosis and management of small for gestational age and fetal growth restriction as per ISWA guidelines. And as you all know, that both SGA and FGR have been probably thousands of papers are available over a period of time. The advent of Doppler, actually, we thought when Doppler came, we had all the answers for FGR and we know exactly what to do. But over a period of time, we have understood that giving an SGA and FGR management, not only management, but also diagnosis itself has a lot of controversies and different approaches are present. So ISWA in the year 2020 issued these guidelines just as sort of a direction in which we can take, and it serves as a reference document where suddenly if you're stuck with something, it helps you to make some decisions. So the plan is to have a small introduction, then we look for the difference between SGA and FGR. We also look at tools for diagnosis, surveillance, and management of fetal growth restriction, the definition of early onset and late onset growth restriction, and also recommendations of how do you manage early onset, late onset, and SGA. And of course, we will summarize. Now, let's first start by defining two aspects. One is called fetal growth. And we all know that fetal growth is a dynamic process where we assess fetal growth by multiple observations of size over time. We are making various measurements, and these measurements together gives us the overall size of the fetus. And we can look at the individual components of the baby, like the head, the abdomen, and the limbs. And when we do serial scans, we're able to plot them on a growth. So we curve, and then we can get the trend of the growth over a period of time. Now, fetal size itself is estimated by the biometry, BPD, HC, SC, and FL, and the derivation of the estimated fetal weight. Here is where we have a little bit of difficulty because several formulae exist. And at present, of course, the world agrees that Hadlock 2 and 3 formula seems to be the best for estimation of fetal weight, which is closest to the truth. But when the estimated fetal weight goes below 2 kilograms or above 3 kilograms, a lot of errors can come. And that again compounds the factor of diagnosis of growth restriction. Now, what is when the overall picture, when a baby is small in size, we say a baby is small in size when the fetal size falls below a predefined threshold for its gestational age. Because at a gestational age of, let us say, 30 or 31 weeks, we expect the abdominal circumference to be around 235 millimeters. And in this case, if it is 225, then it falls on the less than the 5th centile, and I will call it as a small baby. If you look at the weeks, this AC is corresponding to 26 weeks when her actual gestational age is around 31 weeks. So there is a disparity in the size between the head and the abdomen, and the estimated fetal weight also falls below the 3rd centile. So it's important for us to have a threshold for SGA, and the standard accepted threshold is the 10th centile. So any baby below the 10th centile, we'll call it a small. And when it goes below the 3rd centile, it is not only small, but it is abnormally small. Between the 3rd and 10th centiles, the baby could still be physiologically small. And of course, more recently, Z-scores have taken over. It's nothing but similar to standard deviation. And a Z-score of 2 or more tells you that you've gone on the extreme. Now, what about fetal growth restriction? A fetal growth restriction is more difficult to define because the standard definition is when the fetus fails to reach its genetically predetermined growth potential. Very powerful statement, but who knows that particular baby's genetically growth predetermined potential? So we make some assumption and says if the baby is growing on the 40th centile, we expect it to grow along the 40th centile, but that's completely an assumption. There are difficulties in defining growth potential for each fetus. So if we say a baby is small for gestational age and fetal growth restriction, both are small in size, but the SGA baby is not at increased risk for adverse perinatal outcome, whereas the growth restricted baby is increased risk for adverse perinatal and long-term outcome also. Now, the size of the SGA baby is at or below the threshold, at or below the 10th centile, let's say, whereas in FGR, the size is usually below the threshold. Yeah, sometimes it may be above the 10th centile, but not maintain the centile. We will address this issue as we go along. Now, what are the tools for diagnosis, surveillance, and management of fetal growth restriction we have? The first is fetal growth velocity. When we talk about fetal growth velocity, we say that an abdominal circumference or estimated fetal weight, when it drops more than 2 quartiles, that is, if the baby is growing on the 70th centile, it goes down to the 20th centile, then we know that this baby has crossed 2 quartiles and or more than 50 percentiles, we call it as abnormal growth. The second is the use of customized growth charts. All of us are aware of the customized growth charts where the fetal weight and growth are adjusted for maternal height, weight, age, parity, and ethnicity and fetal sex. Now, this customized growth chart has helped us to reduce the overcalling of growth restriction or missing babies with growth restriction. Now, Doppler Velocimetry is another important tool for FGR, especially to distinguish between SGA and FGR. We do uterine artery, umbilical artery, middle cerebral artery, ductus venosus. We also do the cerebroplacental ratio or the umbilical cerebral ratio, which is the reverse of the CP ratio. Then we have the biophysical profile scoring. A score of less than 4 is associated with the fetal pH of less than 7.2, and a score of less than 2 has a sensitivity of 100% for acidemia. Then we have cardiotocography and short-term variation. Now, more recently, computerized CTG has been introduced, and short-term variation in computerized CTG less than 2.6 milliseconds, less than 3 milliseconds, less than 3.5 or less than 4.5, depending on the gestational age, which we will address shortly. Now, we also have placental biomarkers where we get we can do screening, diagnosis, and also have for therapy. Because if you see a high positive screen, as you just heard Sini tell about it, then we can initiate therapy of aspirin. So PAPE, PLGF, mRNA, SFLT1 to placental growth factor ratio have all been used as biomarkers, but at present we don't have enough evidence to clearly use them except for screening for management of the growth restricted fetus. Now, what if computerized CTG is unavailable, as most centers do not have it? We can use the conventional CTG and the biophysical profile for assessing the fetus. So just to tell you, growth velocity is got by the growth graph, and if the customized growth curve, you can see the prediction of stillbirths and neonatal deaths were much, much higher with the customized growth curve as compared to conventional growth curves. Dopplers of the uterine umbilical artery and the middle cerebral artery in ductus venosus. It's very important to use the absolute correct technique for interpreting the Doppler. This is a picture of the computerized CTG, and a biophysical profile plus Doppler can actually help you to achieve your goals. So what are the ISWAG recommendations here? They have clearly said fetal size alone is not sufficient to identify FGR unless the abdominal circumference or estimated fetal weight is below the 3rd percentile. As I said, when the AC or FE is below the 3rd percentile, then we are absolutely sure this is a growth restricted fetus. A drop in growth velocity, which we already discussed about. Doppler may be used to distinguish between SGA and FGR. A multimodal assessment is always recommended. Computerized CTG or biophysical profile scoring should be used in combination with Doppler Velocimetry. Now, what are the characteristics of clinical characteristics of early versus late FGR? In early FGR, the problem is management because you are identifying the problem early, and the baby quickly can deteriorate very, very early before the time for delivery comes. But in late FGR, it's extremely difficult to detect these. More than 50% of late FGRs will actually be missed on the ultrasound. And the prevalence, of course, in late FGR is much higher, and the gestation age cutoff is less than 32 weeks and more than 32 weeks for early and late. The Doppler abnormalities, that's, as you can see, a spectrum of Doppler alterations in early FGR, but in late FGR, you will only see cerebral blood flow redistribution. The biophysical profile may be abnormal in both, and hypertensive disorders of pregnancy are more common in early versus late onset FGR. And there is clear placental pathology in early onset growth restriction. In late onset growth restriction, there is less placental finding. And perinatal mortality is very high in early onset FGR, whereas the perinatal morbidity is high in late FGR and the mortality is low. So because of a lot of different kinds of opinions came about, the Delphi consensus was sought, and experts around the world brought out this Delphi consensus between early and late FGR. And I don't want to elaborate on this, but the recommendations of the guideline clearly says early and late FGR are different characteristics. The Delphi consensus criteria is recommended to be used. So you can use the Delphi criteria for the classification, which makes it comfortable so that everybody can use it. Then what about the Doppler cutoffs? Again, is a very big problem here. What is the cutoff? Should I use 95th centile? Should I use that dropping centile? Or what is the kind of Doppler? How am I going to interpret the Doppler information? In the Delphi consensus for FGR definition, the CPR below the 5th centile and the umbilical artery PI above the 95th centile are the two criteria which are given. And the cerebroplacental ratio less than 5th centile or umbilicocerebral ratio is also used. So that's a clear opinion here. When the umbilical artery PA is above the 95th centile in a small baby, we'll definitely diagnose it as growth restriction. Just to show you a comparison of CPA values between the 50th between the IUGR and normal babies. You can see how the CPR value is much lower in IUGR babies. So, but there is no universal agreement on which indices, thresholds, or reference ranges. You can see number of Doppler tables which are available. So there is no clear direction of which table to use. So you use a table which is comfortable, but consistently use it across all patients. But they have also said that CPR or UCR is better than the individual components of MCA-PI or umbilical artery PI. Now let's go on to early onset growth restriction. Associated with method is maternal vascular malformation of the placenta, leading to placental insufficiency. There is an abnormal transformation of spiral artery, abnormal placental villi, and a multifocal infarction. In this early FGR, there is elevated Doppler uterine artery PI. It typically precedes a cascade of Doppler alterations like FHR changes, biophysical profile modifications, and end-stage cardiovascular deterioration by severe hypoxemia and acidosis. So the only therapy for early onset fetal growth restriction is delivery. So timely use of steroids and magnesium sulfate helps us to optimize the outcome. So we need to ensure that in early FGR, we are optimizing the time by trying to avoid prematurity. So how to monitor early FGR babies? They are monitored and managed in a tertiary level fetal medicine and neonatal units, multidisciplinary counseling by neonatology and maternal fetal medicine specialists. There is no consensus on monitoring frequency. MCA becomes abnormal first, but not used for delivery timing. Periodic maternal assessment of preeclampsia is to be done. What about corticosteroid prophylaxis? Steroid prophylaxis to prevent RDS if the birth rate is likely to occur before 34 weeks, but the Royal College recommends steroid prophylaxis up to 35 plus 6 weeks. There is no randomized control trial available for providing benefit of corticosteroid in early FGR. Enhanced daily surveillance by Doppler during corticosteroid administration is recommended. What about magnesium sulfate? There is good evidence for efficacy for neuroprotection, but unfortunately, exact timing is unclear. The suggested time of commencement varies between publications, less than 32, 33 weeks, less than 32, less than 30, or less than 59. So the recommendation is to refer to local or national guidelines. So ISWA clearly has washed its hands off over magnesium sulfate prophylaxis. Now, when to deliver early onset FGR? Early GA delivery and low birth weight adversely impact the outcome. And we know that less than 37 weeks and extreme low birth weight of less than 600 grams, each J of prolongation improves neonatal survival by 2%. Greater than 27 weeks, DV parameters emerge as primary predictor of neonatal outcome, and maternal condition, severe preeclampsia, could be an absolute indication for immediate delivery. And of course, planned cesarean section indicated in majority of FGRs, early FGR. Now, what about late onset growth restriction? It's a milder and more A-specific placental lesions, but there is alteration in the oxygen and nutrition diffusion. It's near term, there is low tolerance to hypoxia, and umbilical artery and DV changes are rare and do not predict adverse outcome. CPR and UCR can be used to predict adverse outcome. Biophysical profile, remember, becomes abnormal just before stillbirth and hence cannot be used for monitoring. I can't say we'll monitor the biophysical profile because the moment biophysical profile goes down, there's an immediate risk of stillbirth. Now, how to monitor them? MCA, PI, and CPR are the best parameters. It's important always to remeasure within 24 hours to avoid false positives. Monitoring once or twice a week, biophysical profile of poor value in identifying cause of stillbirth. And regarding prophylaxis, recommended if delivery less than 34 weeks, lack of consensus between 34 and 36 weeks. RCOG, of course, again, I said 35 plus 6 weeks. When to deliver late FGR? There is no international consensus on the timing of delivery. Only randomized control trial is called as a DigiTAT study. The induction of labor, where they have said induction of labor after 38 weeks. If umbilical artery PI is greater than the 95th percentile, deliver by 36 to 37 plus 6 weeks, 37 weeks plus 6 weeks. There is no evidence of how MCA Doppler to be used. If MCA is abnormal, deliver between 38 to 38.6 weeks, which depends on the local experience also. So just to summarize, the recommended management of pregnancies with fetal growth restriction based on computerized and Doppler findings is between 24 weeks to 34 weeks. Absent end-diastolic flow or reverse end-diastolic flow in the umbilical artery, monitor every 2 to 3 days unless delivery is indicated. If it is 24 to 26 weeks, it's a personalized management. We need to talk with the family because of the extreme prematurity. Between 26 to 28 weeks, deliver if ductus venosus shows A-wave absent or at or below the baseline, and short-term variability is less than 2.6 milliseconds. If 29 to 31 weeks, deliver if ductus venosus A-wave at or below the baseline, or short-term variability is less than 3 milliseconds. And if once you cross 32 weeks, you deliver if umbilical artery reverse and diastolic flow or short-term variability less than 3.5. And it's greater than 34 weeks, deliver if reverse and diastolic flow or STV less than 4.5. Again, between 36 to 37 up to 38 weeks, deliver if umbilical artery PA is greater than 90th percentile or AC EFW less than 3rd percentile. 38 to 39 weeks, deliver if signs of cerebral redistribution or any other feature of FGR. So between 26 weeks and 34 weeks, you also deliver if there is spontaneous unprovoked decelerations, altered biophysical profile, and if there is maternal indication. And between 36 and 39 weeks, you deliver with spontaneous unprovoked decelerations, altered biophysical profile, short-term variability less than 4.5, umbilical artery abnormality, and also maternal indication. So finally, a few words about small for gestational age. It's a constitutionally small fetus that's otherwise healthy. Small fetus with normal Doppler findings. Customized growth chart help reduce the false positive STA diagnosis, a very specific area for using customized growth chart here. STA with normal fetoplacental Doppler can be associated with accelerated placental aging, signs of placental underperfusion, lower umbilical vein blood flow volume, altered maternal hemodynamics, and greater incidence of cesarean section for fetal distress. So it's important to understand, even though there is SGA with normal Doppler, some of them can be associated with adverse outcome. So how to monitor? At the diagnosis of SGA, fetal Doppler indices and uterine artery Doppler should be done. Late SGA, no need for serial uterine artery Dopplers after initial evaluation. This again is important because no point in repeatedly doing uterine artery Doppler. Fortnightly assessment of fetal growth is recommended. Late SGA with normal or abnormal uterine artery Doppler can progress to brain sparing, so we keep watching for it. When and how to deliver? For small for gestational age babies, fetal Doppler velocimetry should be performed both at diagnosis and follow-up. In case of late SGA, fortnightly assessment of growth and the Dopplers. When SGA has been identified, delivery should be planned from 38 weeks and the pregnancy should not exceed 39 weeks of gestation. Universal induction of labor at term may be more beneficial than expectant management in terms of reduced pregnancy mortality. Continuous fetal heart rate monitoring during labor is indicated. So I will conclude by saying early diagnosis, close follow-up, and timely delivery for FTR. Two phenotypes of FTR have been identified, early and late. The diagnosis may actually be challenging. Multimodality assessment is also important. Early FTR placental pathology, the risk of adverse outcome is high. And late FTR, the timing of delivery is fairly clear, whereas late FTR, the optimal timing of delivery is not very clear. Some cases of SGA with normal Doppler may have growth restriction. Thank you very much for a patient visit.
Thank you so much, sir, for this excellent deliberation on late onset and early onset FGR. And we are really privileged to have you on this virtual FETOMAT because your presence make any conference a big success. Tasin, over to you for the Q&A session.
Thank you so much, Suresh sir. Really, as ma'am mentioned, it has been a privilege to hear you. And thank you for such clear-cut messages on distinction between FGR, SGA, and use of multimodal modalities for prediction as well as for management of FGR. And now I would like to take the questions. So the first question is, if a patient is already on aspirin, then how do we do the preeclampsia screening for her? This is for Dr. Suresh sir. So can you please take the question?
Yes. So I assume I'm audible here?
Yes, sir, you are audible.
So, yeah, so this is a very common scenario, especially where evidence-based medicine is not practiced. Now, for this, I will quote the meta-analysis from Pia Kamsothong et al., which showed that the initiation of aspirin before 11 weeks has no impact on the prevention of preeclampsia or other abnormal placentation-based disorders. Having and also another point is that the most crucial element of placentation is the second wave that is completed by 16 to 20 weeks, and probably the seeds of the same are sown in the early maybe the early second, maybe around 11 to 16 weeks. And therefore, even if the woman is on aspirin, one can offer combined multi-marker screening for the same.
Okay, sir. So related to that is one more question. If the patient has been started on aspirin because of some high-risk factors associated with the maternal history or the demographic factors, and if then a preeclampsia screening is done, the multi-marker screening, and if that comes out as negative, then should we stop aspirin, sir?
So if a combined multi-marker screening based on all the biophysical, markers, biochemical markers, and mean maternal demography has been conducted in the proper fashion in a standard laboratory, all the parameters have been accurately measured. And if the screen is, the risk comes as low, yes, I think aspirin can be stopped based on this.
Okay, sir. Definitely, it has got a higher sensitivity for predicting the preeclampsia. Now, there's another question. What's the difference between 75 milligrams per day and 81 milligrams per day dose of aspirin, sir? Both of them are dose, yes, sir.
Yeah, first of all these are suboptimal doses as far as the prevention of preeclampsia is considered, because now there is absolutely no dose. 150 milligram is a dose unless a woman is weighing less than 45 kg. But all these doses have come because of use of aspirin in other specialties and the way they were marketed, especially in the UK market. Especially the 81 milligram dosage has come from the UK because of the way it was marketed in those countries. And similarly, 75 milligram is a widespread dose used for the prevention of complications in antiphospholipid syndrome, and therefore it has been, just extended to the prevention of preeclampsia. But coming to prevention of preeclampsia, there is absolutely no doubt 150 milligram is the most effective dose, and it is also safe maternal, fetal, and neonatal point of view.
Of course, sir, and that has been clearly shown by the evidences you had presented, sir. So the next question is, sir, if unilateral uterine artery PI is high, but the mean PI is less than 95th percentile, can it be taken as low risk? So you're muted, sir. Can you please unmute?
Sorry. I think, so the placental perfusion is a summation of the blood that is received from both the uterine arteries.
Yes,
and
sir.
Therefore, what we need to take into consideration is always the mean percentility index. And even if one uterine artery PI is more than 95th, but the mean PI is less than 95, you can take it as low risk. And always combine it with the multi-marker screening so that the effects of this are, minimized.
Of course, sir. So it's the mean PI that we have to take into consideration and not the unilateral. There's one more question, sir. Since EFTS is not yet validated in twin pregnancy, when do we start aspirin?
The same question I had asked to Francis F. Figueras, if you know who Francis F. Figueras is.
Yes,
and
sir.
what he told me is since multifetal pregnancies are already at a very high risk for the onset of preeclampsia and abnormal placentation, it is okay to straight away start aspirin them. Because the multimodality screening is not yet validated in twin gestations. So it might be safe to start aspirin in all twin and triplets pregnancies.
Okay, sir. Thank you so much for taking those questions, sir. Now there's one more question to Dr. Suresh, sir. How do we interpret DV increased resistance after 34 weeks in late onset FGR with other Doppler parameters being normal? Do we consider delivery?
I would be extremely surprised DV alone being abnormal when the other parameters being normal. So in such cases, what I would do is first of all go and redo the DV and make sure that you are getting the correct one. And secondly, we look for other probable causes of DV abnormality, not the growth restriction, not the placental issue. Because of growth restriction. So I wouldn't be, I would really be surprised for that. Look at the heart, look at other possibilities of right atrial pressure increase.
There one more question which was asked and addressed was, is there any difference in protocol management in a woman who is a low risk with FGR and who is really high risk with FGR? Because a woman with significant maternal medical disorders, do we protocolize different?
No. See, it is the same. Only thing is that maybe you might have to alter your surveillance based on both maternal and fetal surveillance would probably have to be much more closer. And because remember, whenever you're having a maternal disorder with a fetal growth restriction, the mother always takes the preference. So you need to monitor the mother very much more closely. But otherwise, the rules of the game are exactly the same. Doppler interpretation, everything is exactly the same.
Thank you, sir.
Thank you, sir. There's one more question. Is there any follow-up of preeclampsia patients and their children? I would request Dr. Sinesh sir to take this question.
Okay, well, I'm not aware of a study with neonatal outcome in mothers who just had preeclampsia, but in complicated by fetal growth restriction and prematurity, yes. And the neurodevelopment scores in such a cohort was definitely less at 2 years of age. But I think it is primarily related to preterm delivery and being small at birth rather than preeclampsia directly, because all these disorders are interconnected. But preeclampsia alone, with a normally growing baby and born after 37 weeks, I'm not aware of a data, but that's a good question. I'll look into it.
Dinesh, if your permission, can I take that?
Sure, ma'am. Sure.
Prasin is actually a big randomized control study which KIMS Health is organizing with the Rajiv Gandhi Institute of Biotechnology. It's a huge study which we are doing now, and the outcome is to release, because we are following up those babies for another 2 years of life to see whether these angiogenic factors have some effect in the fetal and the neonatal period and to their immediate infant life. And they're being followed up. I will definitely release the study reports once it is through. It's a huge study, actually.
Sure, ma'am. We'll be looking forward to the results of that.
Yes.
Same.
Ma'am, I think I've covered all the questions in the chat box. Are there anyone remaining, madam?
No, I think you have asked all those questions. And when these two speakers talk, there is not of much questions to be asked because they cover whatever updated till date. So thank you so much, Dr. Sinesh and Suresh sir, and for all your valuable time on this inaugural. Please stay with our inaugural address, sir. Suresh sir, Dr. Sahadullah is here. So I welcome Dr. M.I. Sahadullah, the chairman and managing director of KIMS Health, whose vision has made this department successful from year 2009. Since inception, Professor Suresh is with us, Dr. John Smallnick, the whole Mediscan team, and I'm so happy that we are virtually conducting the CME today in spite of this COVID pandemic. I welcome you, sir, for this inaugural address.
Hi, good morning to everyone, or good morning or good afternoon, wherever you are. It's a great honor to be part of this program, even though it has nothing to do with my specialty. My specialty is internal medicine. And so when we started out about 18 years ago with this perinatology, that was a little bit novel, at least in many parts of Kerala and probably most parts of India. And but I was so surprised to see that today you are conducting a 2-day feast of this scientific program on feto-maternal medicine, and I'm delighted to be part of it, honestly. And we are coming a long way, and Kerala always boasted on the infant mortality. A very low rate of infant mortality, but we could not boast the same way as of that in maternal mortality, even though we have been the best in India. And I'm sure that a lot of people now doing so much work, and both neonatology as well as perinatology and high-risk pregnancy management have improved the entire spectrum of care in OBGYN and neonatology. I'm very happy to see many speakers. Many of them are personally known to me. I think Dr. Vidyalakshmi giving the leadership, Dr. Nina and the team supporting Dr. Suresh and Dr. Umaram always have been great support to all academic activities in this area. And Dr. John, I don't have to mention, is almost part and parcel of our institution and second opinions, and we always communicate. And Dr. Piley, an old friend, while I worked in Saudi Arabia, and he's doing great work in this area. And so Dr. Suresh. And so I think I'm not going with all the names. And then the faculty of OBGYN, a big list of people are there who is supporting this program. So one of the most interesting thing which I have noticed today is previously it was mostly a doctor's subject, and we talk about it. We ask the pregnancy, the pregnant ladies to go for a special examination and all. But today, I think that the population, or a good part of the patient population or guest population have accepted this, and they demand for a special examination. They want special studies. And so I think it is a very encouraging situation. And I think we will be advancing. And the numbers of pregnancies in our country are big compared to many countries. And therefore, as Vidyalakshmi was saying, we should encourage a lot of basic research and studies with various hospitals and organizations across the country. And I'm sure we are going to achieve much bigger heights in this area as a state, as an institution, as a state, and as a country. We need to go further. I wish all the best for the entire team. And Dr. Vidyalakshmi was very much excited about this conference. And in fact, she reminded me 3 times that I should not miss it. So I will, Orandorf even will come in and listen something and learn about perinatology. I'm so happy that I was invited, and I am extremely delighted to inaugurate this session and wish you all 2 days of excellent scientific feast. I'm very happy to see that the question and answer sessions are dealt with much better. And I think interaction is the most important thing, any conference. And without interaction, it becomes boring. And after that conference, one more thing, there's a lot of theory. We talk about it. We talk about exotic procedures and all. But finally, what matters, how the conference became successful. I think about 200 or 300 people have registered. They should at least take home some messages and start practicing from tomorrow or day after. And that is where our success is. Wish you all the best once again. Thank you.
Thank you so much, sir, for your valuable time. And we are sure that we are going to enlighten all the registrants. They will not be disappointed, because the next 2 days they are going to be really listening to the stalwarts of this area of academics. So thank you so much for your time, sir. And we'll carry on with our conference now.
Please.
Thank you so much, sir. Thank you. So moving ahead with our program, now I would like to call upon our next speaker, Dr. Geeta Kolar ma'am.
Sasin, sorry, it's Indrani ma'am, right? It is genetic sonogram.
Sorry, I would like to call upon sorry, I'm extremely sorry for the change, for the mistake on my side. I would like to call upon Dr. Indrani Suresh. Dr. Indrani ma'am, of course, again, does not require any introduction. She is the director of Mediscan Systems. And apart from her excellence in fetal medicine, she is also very well known for her welfare work, which includes providing complementary ultrasound services at Army personnel at Chennai Military Hospital, and also free ultrasound scans that are being provided under her guidance since more than 25 years at the Mediscan to the underprivileged patients. And also she has been taking care of lots of families of the babies who have been affected with inborn errors of metabolism. She has lots of titles. May I please have Madam's CV displayed again? She has got a lot of titles to her credit, including the Best Doctor Award from the MGR University, Tamil Nadu, the Satyati Icon Award, the Wonder Woman Award, and she has been the organizing secretary of the CUSP since 1988, 1989. So, and of course, she has got lots of papers and published articles in the national as well as international peer-reviewed journals to her credit. So I would like to call upon Dr. Indrani Suresh ma'am to talk about genetic sonogram, which of course forms a very important part of the aneuploidy screening that now we are almost universally doing for all the patients. Dr. Indrani, madam.
I'm just loading the slide.
There has been some issues. Yeah.
Ma'am has joined us.
Good morning, everyone.
Good morning, madam.
Getting the slides loaded. Thank you for the kind words of introduction. Today, the task I have been allotted by Dr. Vidyalakshmi is. Hello.
We can hear you, ma'am. We can hear you well.
The subject I have been allotted being the genetic sonogram, because I was telling her why genetic sonogram in this era of when we are doing first trimester and NFES, but still you find in day-to-day practice in our center as well as in other centers, we get referrals with some soft markers and their relevance to be discussed. So what I have done is I've tried to do look at the soft markers and look at the LR of various soft markers and see how we can apply them and what will be the unique situation where the genetic sonogram will be still useful. And my slides are visible now?
Yes, madam, we can see your slides, ma'am.
Yes, thank you.
Thank you.
So let us see, it is actually what are the concepts we need to take. So looking at the value of soft markers in screening for 21 trisomy, this is what I started when we are doing FTS and NAS. Let us try to simplify it and look with what we have been able to do in our system and what we are following. So genetic sonogram actually is the soft markers, where if you look, we need to understand if a marker is found more often in the Down syndrome population and less in the general population like normal karyotype population, that will have a more robust marker. That is why we will be seeing how some markers are not of great relevance. We have to disregard them. So we will be seeing the important markers and the relevance and its role. So this paper of 2013 of Agatha Claus I'm sure all of you would be familiar. One of the things we can do is it's freely downloadable. You can download it. In this also, he gets given a Excel. So you can feed your data and get the derivatives. If you do not have the software which would calculate it, like if you have a Sonocare, you can have some other softwares also may be offering this. If not, you can download it from the internet. In this, I just want you to look at all this marked in the red, the ventriculomegaly, nuchal fold thickness, and Arsa and absent or hypoplastic nasal bone. Of which I'll be dealing, I will not be dealing with ventriculomegaly because that's the one talk is going to be done by Dr. Suresh. And it also behaves like the other marker, like with other LRs. All right. So let us look, when we looked at all these, which has got an LR of around 1, they are not very robust. If you see this short humerus, short femur, and then mild hydronephrosis, echogenic intracardiac focus, all of them are around 1. So they don't change the a priori risk. One quick example, because time and again, every day we get references, even today we get references as echogenic intracardiac focus, whether it is on one ventricle or both ventricle, that doesn't matter. If you see age risk is 1 in 935, no FT is done. And when you apply this marker, then still it does not change the risk. So it stays there. So it's not a robust marker. Let us go on to another marker, echogenic bowel. It is little more than 1.6. So this, of course, is seen because of the less of microvillus enzymes in Down syndrome population. You will see this. Again, the performance. It is very important. You have to use the proper dynamic range and proper setting, and reduce the gain and make sure in such a way when you are seeing this as bright as the bone. With all this proper performance of the test, you have to look at it. So this, how it would be. Here was one patient where the first trimester HCG mom was higher and Pape was low, and NT was 1.2 mom only. So, but still, the screen test became positive. So this lady was wanting to, didn't want to do the invasive test, and they came for follow-up for 17 weeks. We found an echogenic bowel. Once you add that, it becomes higher screen positive. So once we did the amnio and prenatal bonds, it was turned out to be trisomy 21. Now we will look at the markers of nasal bone, Arsa and NFT. So nuchal fold thickness, again, the performance is very, very important. Time and again, so many times you can give a falsely increased nuchal fold thickness. So the neck position, if it is too flexed, it will be, and also the gestational age, whether to take it as 5 millimeter means it will, how it will perform 6 millimeter. When the gestational age is going more towards 23 weeks, beyond 21, 22 weeks, it becomes irrelevant. And also with the dolichocephalic effect. So all these has to be followed and performed. And also at particular 30-degree angle. So if you see, if you are taking like this in the cerebellar plane with the perpendicular angle, then you find a falsely increased NFT. So these are the practical difficulties. We find lot of errors in the NFT. In fact, in the I will be showing in Mediscan statistics 1 year. I just took in the year 2021 statistics I took. We are not getting isolated increase NFT because probably we are doing more of first trimester. That's one of the reasons, and also most of the time we are associated with other signs of eye drops or symptoms. So looking at the anossified nasal bone, again, it is very, very important. We have to get the proper mid-sagittal plane and the neutral position. Hyperextended head will show an absent nasal bone. We have to demonstrate it in 2 planes. You can see the premaxillary triangle, it's a deficiency of the nasal bone. Of course, the international terminology used is absent nasal bone. use as an ossified nasal bone in our center. We will stick on to an absent nasal bone in the lecture. Coming to aberrant right subclavian artery, it is come a little later. And again, it's important to show, you can see this Arsa going behind the trachea from the descending aorta, the last branch into the right arm, and it is demonstrated both in the transverse and in the long section. One of the important things is when we use low velocity or power angio, we'll see so many colors picking up, many errors being done, because ours is a multi-operator center. We know it is kind of reflection of the population. This is one of the common pitfall, that is the azygous arch. But azygous arch goes from posterior to anterior, and it doesn't reach the arm like that. But still, somebody looking quickly, they will think it is behind the trachea. So it is aberrant right subclavian artery. So now we will go through case scenarios on looking at the relevance of the markers with genetic sonogram. The most important thing is we do a detailed history and also look at the maternal age and the mode of conception. And then if it is IVF or anything, what kind of gametes they have used, whether what is the age of the gamete. So it is very, very important to look at all the papers and see it by yourself and make an audit. If the performance of the test has been both ultrasound and biochemistry has been appropriate, all history, everything properly, then we can use it as a priori risk. Otherwise, the dictum is just discard. We just tell them in a briefly, it is not done appropriately, so we are not going to use that FTS risk. Even though it is, we have to tell gently and firmly. If they they're not done in FTS, we can use age as a priori risk. Most important is we need to talk about all the screening tests, FTS sensitivity. When you are using NT-NP risk, then sensitivity will be about 90 to 95%. Quad test about 70%. And NIPS about 99%. All these are screening. So all the screening tests, risk and the benefits and risk they have tell. And also about your direct testing and the risk and benefit. So a word about NIS is, we have to remember NIS is also a screening test, but high sensitivity. So NIS, if it comes as positive, we have to do an invasive test. And limitation being turnaround time is 2 weeks. So if the gestation age is going more towards 20-21 weeks, we may not have adequate time to get the results and to act. And also the fetal fraction is very important. Whenever you have a growth restricted fetus, you may not have an adequate fetal fraction, or a high BMI lady, we may not take. So in these cases, when there is low fetal fraction, there will be no call at the end of 2 weeks. Again, it is not appropriate to repeat it again, because you have to get into a direct test. So when I just quickly look into Mediscan data in the year January to December 2021, and we put a filter of early target and target scan, 16 to 23 weeks. We hit at a number of 11,011. In this, we just look as only isolated soft markers. If they had soft mark, soft marker, it can be 1 or 2. If there are additional anomalies, those cases were removed. So when we looked only soft marker, the NT, NB, Arsa, and NFT, we got 353, because I'm just looking into this data, only these 3 soft markers, which I will be analyzing in the cases, of which more commonly we were seeing anossified NB compared to aberrant right subclavian arteries is about 1%. And NFT is very small number we looked at. One of the reasons is probably we are doing more and more of FTS, and the other centers also people are doing FTS, so cases get filtered. Ours is a referral center, so the numbers may be little higher. So we will look one by one some cases of these markers. So this particular case, we had a priori risk as 1 in 1,208. Combined screening has been done for her with NT-NB, and the risk came as post-risk is 33,032. At 16 weeks, we found a aberrant right subclavian artery. When we applied this 3.9 LR, modified risk was still only 8,384. After counseling, patient opted for routine follow-up and the outcome is normal. Second case, if you look, age risk is 1 in 1,007, but no FTS has been done. And at 16 weeks with an Arsa, see what has happened. It has become almost close to screen positive range because the cutoff we keep is 1 in 250. 256 is screen negative, but it is very close to the cutoff. So we gave the option of both direct testing and NIS. Patient opted for direct testing. The results were normal. In the third case, if you look, this is a 42 years primey, and she is natural conception. She didn't even know she was pregnant because she was having vomiting. She consulted the doctor, and at that time, age risk is 1 in 52. She had opted for combined, after counseling, she had opted for combined screening. And the combined screening, it has come as 1 in 939. But at 22 weeks, when we did the genetic sonogram, there was aberrant right subclavian artery. So what happened? From here, 939, 4 times it increases. No, the LR for Arsa is 3.9. So almost close to 173. So we gave the option, because the gestational age is 22 weeks, we, even though there is an option of NIPS, by the time you get the results, it will get more delayed. But still, she was worried about the pregnancy loss. She opted for NIPS. Fortunately, after 2 weeks, when we got the result, it was screen negative. So she continued, and then the outcome was good. Coming to the fourth case. This is a 35 years and IVF. Note, it is very important. You have to, when assisted reproductive technique, you have to look at whether it is own gamete or donor, because that age only you have to put. This is own gamete, so 1 in 365. And combined screening, the result came as 1 in 51. The reason that tilted is the absent and nasal bone. So both options were given for invasive and NIS, and they opted for invasive treatment. And while they were waiting, she said, we will do an amnio. While they were waiting, she also interim, she went and did a NIPS. And that came as negative. So on the genetic sonogram also, there were no markers at 17 weeks. Again, when we repeated, so she opted not to do any amniocentesis, and baby was normal on clinical examination after birth. Coming to case 5, this age risk is 1 in 659. And FTS combined screening is 1 in 356. The reason being the absent NB. So we discussed the options of NIPS and direct testing. They opted for amnio. You can see many people, they are aware of all this, and then they go back, contemplate, and in between they come back and then do an NIPS. But to the surprise, we found in NIPS, it was a screen positive for trisomy 30. Because at FTS, we did not find any markers for trisomy 13, but anyway, we did 19 weeks detailed anatomy scan. At that time, there was no marker indicating, no anomaly indicative of trisomy 30. And anyway, because NIPS gave this result, she went for the direct testing and karyotyping is normal. So this again tells the NIS is only a screening test. You must not jump on the results and go for termination. So case 6 is a priori risk is 1 in 1,181. FTS with absent nasal bone also, combined screening result was quite low, 1 in 4,384. She was counseled on genetic sonogram, there were no new markers, so they opted for routine follow-up. But however, see, whenever we say absent nasal bone, they imagine so many things. They think that nose is not there or too tiny or flat like that. So it's very important for us to show pictures and explain what is bone, what is soft tissue, all that. Postnatal clinical examination, baby was normal. Coming to case 7, 1174 is a priori risk. FTS was absent nasal bone. Combined screening came as 1 in 670. Actually, this is the group which has been classified as an intermediate group. In our cutoff, because we have 250 is cutoff, between 250 to 1000, we keep it as an intermediate risk. The reason for bringing this intermediate risk is in this group, we get, when it is screen positive, almost about 90% of them will get picked up. The rest of the 10%, what happens? They will fall, a good number of them, maybe about 7% will fall in this intermediate group, and a very small percentage will fall beyond 1000. So after counseling, she opted for a genetic sonogram. There were no new markers. And finally, she did the NIPS, and it came as screen positive. So again, karyotype was done, and then karyotype was normal. This again to reiterate, even if NIPS comes as screen positive, we have to do the direct test. Coming to case number 8, see, age risk is very high, and FTAs also we found absent nasal bone. So when we did just not biochemistry, NTNB risk itself came as 1 in 70. So patient said, I would like to do NIPS, and it was screen positive. And she came at 16 weeks for amnio. At that time, we found an additional marker of Arsa. So you find when you add more marker of absent NB to Arsa, it almost became 1 in 4, and karyotyping turned out to be pure trisomy 21. So more than one marker, it is very important. We have to counsel them about the importance of doing more towards invasive tests. Even though we tell non-directive counseling, there is some kind of direction given towards the strength of each NIPS and the invasive test. So the genetic sonogram, what is its role in today's practice? This is a paper, meta-analysis paper I took from 2014. In this, when they had analyzed, they had taken absent nasal bone or hypoplastic nasal bone, NFT, but they have not looked into Arsa. They have looked at the other soft markers, hyperechoic bowel pilot cases and humerus. All this is around only similar. In this, Odibo et al., they concluded we have the concept of genetic sonogram over 20 years. Genetic sonogram has a place when you have twin gestation, especially when other twin is gone for an IUD, we can't do a biochemistry. Or if there are twins, then we could, NIS can be done, but still there are not all labs are able to offer. So where in case of twins and especially higher order of multiple gestation, more than twins, there is a place. These are the inferences from the paper. And in countries or places, in our country is also, no, it is like mini Europe. Each state has got different wherewithal and facilities. So we can consider like if the access is not there, still genetic sonogram has a role. So to conclude, what are the things that we have to, you have to use the LR of the marker and modify the risk, whether the FTS risk or age risk, whatever you have the a priori, and then counsel them. And as we have seen in all these illustrations, when we have more than one marker, and also the gestation age is more towards 20 weeks, the first option can be given as direct testing, because we get results if you do a qPCR within few days time. If they are not willing for that, then we can go for NIPS as a second option. And it is very, very important, as we saw in some of the cases, in spite of opting for amniocentesis, they come back and give an IPS. So whatever the patient wishes, we have to respect the client's decision and be supportive throughout pregnancy, which is a very important balancing act of a fetal medicine specialist. And genetic sonogram, when it is performed, it has to be performed in the right manner. With this, I conclude my talk. And thank you very much, Dr. for doing this nice program. If you have any questions, probably I could address them.
Thank you so much, ma'am, for your valuable presence. And it was as elegant as ever. And the most controversial area always discussed in fetal medicine. I request Tasin to take the next talk. Madam, please stay for the Q&A sessions after the next one more session.
Thank you so much, Dr. Indrani, madam, for throwing on light on various case scenarios where we can see that how after incorporating the likelihood ratios, the A5 risk changes, and also guiding where to consider exactly the genetic sonogram or a higher end testing with increased sensitivity. That's a screening, that is an IPS. And also throwing light on intermediate risk. And of course, as you said, if there are more than one markers or the gestational age is near 20 weeks, we should go for a direct testing instead of an IPS. So moving on with the session, before introducing our next eminent speaker, just two important announcements. First of all, since we had already surpassed the number of registrations we could have had, we have provided a live YouTube link that is, and all those who have joined to the live YouTube link, it's a request that there's also an attached feedback form, which you can fill up and send it to the given email ID along with your complete name and contact details. So it will help us facilitate and distribute the certificate of participation. And second, we have got an interesting mixed box of maternal and fetal medicine spotters, which we will be displaying during the break, that is coffee break, as well as the lunch break at the respective time hours as per the brochure. So you can go through them, and of course you can type your answers and send it to the given email ID through the YouTube link. Now I would like to call upon our next eminent speaker, Dr. Geeta Kolar ma'am. Feeta Kolar ma'am is the pioneer of fetal medicine unit at the Fernandez Hospital, and also she is the first FMF certified Indian fetal medicine specialist, and she currently holds the position of Director of Department of Fetal Medicine at Fernandez, Hyderabad. So we have Dr. Geeta Kolar ma'am to discuss with us on morbidly adherent placenta, which we know is in itself is a spectrum of disorders, and if not diagnosed and managed timely, can lead to grave maternal morbidity as well as mortality in certain cases. So we have Dr. Geeta Kolar with us to illumine us on the topic of morbidly adherent placenta as a cause of obstetric morbidity. Over to you, madam. Good morning, ma'am.
Good morning. Thank the organizers, Dr. Vijayalakshmi, Dr. Nina, for organizing this FETOMAT and giving me this opportunity to present my talk on morbidly adherent placenta. Is accreta an organic disease, or is it a man-made iatrogenic condition? If you look at the word accreta, it's a Latin word, which is ac plus crescere. That means it grows from an adhesion or adhered to. In 1937, there was a 20-patient case series by Irving and Hertig, which spoke of abnormal adherence either in whole or in part of the afterbirth to the underlying uterine wall. And they said that there is an absence of decidual layer between the placenta and myometrium with direct attachment of the villi to the myometrium. This is the earliest reported series. But today, the incidence of MAP or morbidly adherent placenta is increasing. They have quadrupled since the 80s. Today, it is increased to about 0.12 to 0.3% of all pregnancies, and the incidence quoted is about 1 in 272 of all pregnancies. What is the histopathogenesis of morbidly adherent placenta? You find this Nitabush layer, which prevents the decidia prevents the trophoblastic invasion into the decidia and the myometrium. And if this Nitabush layer is destroyed or fibrosed, then there is no inhibition and the trophoblastic invasion happens into the myometrium and into the serocell layer. That means there is a deficient decidia basalis which follows a previous injury or infection. Why are we so worried about MAP or PAS, as it's called today? It's because of the massive blood loss, which could amount to even 3,000 to 5,000 ml. The reproductive career of a woman is finished because 90% of them have a cesarean hysterectomy. Apart from these complications, there could be huge other problems like DIC, ICU admissions, bladder injuries, atonic BPH, and even a maternal mortality of about 7%. So it's a potentially life-threatening hemorrhagic condition with 7 to 10% of mortality. And this mortality is because we don't anticipate, we don't prepare, and we are not adequately competent to handle it. So this is what we're going to try to present today, see how we can prevent and manage adherent placenta. So any care bundle is what do you think of a bundle? Where there are few uncontroversial key elements of good practice which should be applied together in one patient to improve the patient care. So it's nothing but a collection of things which are tied or wrapped up together, which need to be followed to prevent mortality or morbidity. So the prevention care bundle for adherent placenta would involve antenatal care, that means anticipation, planning, counseling, and consent, diagnosis with different modalities of imaging, and ultimately preparing for the surgery. So what is anticipation? Anticipation is being aware of which are the patients who are potentially likely to have morbidly adherent placenta. And these women are mothers with previous cesarean section, placenta previa, previous hysterotomy, previous any surgeries like recurrent dilatations and curettages, myomectomies. Apart from that, advanced maternal age, any previous uterine surgeries, multiparity are also other. That means wherever there is myometrial tissue damage, which is followed by a secondary collagen repair, is a potential risk factor. Because if you see all the patients with morbidly adherent placenta, we find that there is at least one risk factor in almost 94% of the mothers. Now, how does previous cesarean lead to, and how many sections? So if you have without previous section, even 5, the chance that she would have is less. But now with previous sections and current previa, the chances that she would have is almost 70%. So 6 and more, the accreta risk with no previa is about 4.7, and it rises to 67 to 70% if the mother has previous multiple cesarean sections and placenta previa. These are the mothers who have almost 60 to 70% probability of having adherent placenta. PAS is not a single disorder. It is a spectrum. If at one edge you have mothers who have spontaneous placental separation, you have the red zone where there is placenta which is invading not only into the serosa, but also into the bladder and surrounding substructures, that is placenta percreta. So we must be aware of this spectrum. And this could be the same accreta and increta and percreta would be found in the same mother also. So we must be aware of the spectrum, and it's not a single disorder. And depending on the depth of invasion of the villi into the myometrium, you have accreta where the villi are just attached to the myometrium. When they extend into the myometrium, it's increta, and when they penetrate the myometrium wall, it's percreta. So what are the diagnostic tools that we have? Having spoken about the risk factors, the second bundle tool is the diagnostic tools, and ultrasound is the most important tool that we have today. Both transvaginal and transabdominal need to be used, and these are complementary. You need to use both grayscale and color Doppler. If you have the facilities, 3D power angio also adds, elastography and MRI other tools. It's very important to diagnose because the maternal outcome is certainly better in women who have had a prenatal diagnosis, because then you're anticipating, you're preparing. So these mothers are known to have less blood loss and shorter hospitalization, because antenatal diagnosis is very, very crucial. And this large study has said that when there is a prenatal identification of invasive placenta using ultrasound, and systematic review and meta-analysis, your detection rates are very high. And you can either exclude and reassure or diagnose and be prepared. And ultrasound definitely is the first modality and the most important modality. Before going to diagnose abnormal placenta, we should know how a normal placenta looks like. Normal placenta is very homogeneous. It could be located on either of the walls, and it is homogeneous. And it's very important to look at this retroplacental zone and the myometrium and the serosa behind. You find that this placenta is very homogeneous. Then you have the good retroplacental zone, which has nothing but decidia and the vessels. Then you have the myometrium and the serosa. And if you put on color Doppler, again, you find that there's a very, very good vascular arch, which is parallel to the basal plate. You don't have chaotic vessel architecture. You have a very good normal vascular arch, and you have myometrium beyond this. So this important message is very clear that, yes, you need to be aware of how a normal placenta looks before you try to diagnose placenta accreta. The ultrasound diagnosis for placenta accreta involves 6 grayscale findings, 4 color Doppler, and 1 3D power. And Figo strongly recommends that ultrasound signs of pars should be described when you're using. So you must say these are the findings rather than say just the diagnosis of abnormally invasive placenta. Because this diagnosis does not just give you a diagnosis, but also tells you about the depth of invasion. So the first sign that we look for is the loss of clear zone. So this we mentioned is the clear zone, and this loss of clear zone is the first sign that we look, and you find that the clear zone is absent, the retroplacental zone is absent, and the second sign is these abnormal placental lacunae. We said a normal placenta is very homogeneous, and this has abnormal placental lacunae. Then the third sign is a bladder wall interruption. If you see the bladder wall, it is very highly echogenic and very smooth. But in this case, you find that this bladder wall is interrupted and you have these irregular vessels, and there is invasion of the uterine serosa and into the bladder, and the bladder flap is elevated, and this means that there is invasion into the bladder cavity. So you find that this echogenic line is absent in this case. Then myometrial thinning. If you see this, myometrium is totally thinned out, and in fact, it is breached here. So the smallest myometrial thickness is measured at the site of placental invasion, and as myometrial thinning of less than 1 millimeter is highly predictive of adherent placenta. Then placental bulge. You can here see that this smooth outline is being interrupted and there is a bulge into the bladder, or there could be a focal exophytic mass. This is another sign that you need to look for. So amongst the 6, we have covered all. Now coming to color Dopplers, you are looking at neovascularity, and this could be utrovesical that means between the uterus and the bladder, subplacental hypervascularity, bridging vessels, and placentae lacunar feeding vessels. So what is utrovesical hypervascularity? You find that there is a striking amount of color Doppler signal seen between the myometrium and the posterior wall of the bladder. And this indicates nothing but numerous closed, packed, tortuous vessels in that region, and indicates that multidirectional flow analyzing artifacts are present. Subplacental vascularity, that means there is a striking amount of color Doppler. We mentioned that normally this should be a parallel arch to the basal plate, but here you find that the whole placental substance has tortuous, closely packed vessels in that region, indicating multidirectional flow. Now, what are bridging vessels? Bridging vessels are vessels which appear to extend from the placenta across the myometrium and beyond the serosa of the bladder. These are described as line dot dot, often running perpendicular to the myometrium. So you find this, and you find these vessels which are running perpendicular to the myometrium into the bladder mucosa. Now, what are placental lacunar feeding vessels? These are vessels with high velocity blood flow, which lead from the myometrium into the placental lacunae, causing turbulence upon entry. Now, there's a recent sign described as the rail sign, which is an ultrasound finding in placenta accreta's spectrum, which not just diagnoses accreta, but also tells us that there is a deep villus invasion and you can anticipate an adverse outcome. Why do we talk about the rail sign? It's like these two tracks and these are the joining lines. So this indicates the flow signals between the placenta and bladder mucosa, and it combines all the vascularities, that is the subplacental, utrovesical, bridging vessels, and neovascularity of the bladder mucosa. So that means 1, 2, 3, 4 signs are involved, and this may indicate deep villus invasion. And this may help the surgeon to anticipate problems and prepare with blood transfusion. So in a study which has compared rail sign plus and rail sign absent, they have found that there is increased odds of deeper villus invasion, hysterectomy, bladder invasion compared to a negative rail sign. So this is a sign worth looking for and seeing the outcomes when you have the positive rail signs. Now, what about power Doppler, 3D power angio? Yes, this is a most significant feature of accreta, where you find abundant neovascularization, and there are numerous coherent vessels, which you can see on a 3D. And this intraplacental vascularity is complex, irregular arrangement of numerous placental vessels exhibiting tortuous calibers, courses and bearing calipers. So you see throughout the placental substance, you have many, many tortuous vessels in varying lumen diameters and tortuosity. So how do these different modalities perform? Grayscale is as good as 95%. Adding 3D, you can even increase the sensitivity to 100%, though it is only 85% specific. Now, is it important to just give each sign? How much does each sign contribute? So this is a very good staging system for placenta accreta spectrum disorders, which was described, and we use it in our hospital, where the history is taken into consideration, and each of these signs are described: loss of clear zone, myometrial thinning, lacunae, and each is said yes or no. So we have to describe these features and ultimately say there is a high probability or an intermediate probability or a low probability. And is the extent focal or diffuse? So it's very important then to describe that there is a focal exophytic mass, then we are worried about accreta. So this forms a very good checklist for us, because it not only tells you the staging, but each feature is described for us to look at the ultrasound feature and say, is it yes or no? So there is another scoring system where you look at the history, the lacunae, the number of lacunae and location, and then give a score about low, moderate, or high. How early can we diagnose placenta accreta? It has been described as early as 9 weeks by the presence of low implantation and these multiple lacunae and increased vascularity. So you can anticipate, especially if there is a previous cesarean section and you have a low implantation, you can anticipate. So this was one of our early cases where we diagnosed it very early. We had this low implantation, and as we followed her up, we started looking at the lacunar spaces, the hypervascularity, 3D power angio, and this was a confirmed case of morbidly adherent placenta. So why are we insisting on ultrasound diagnosis? And how accurate can be? This depends on, again, the awareness of clinical risk factors, how much time you have spent, how much experience do you have had, gestational age at which you've looked, what are the imaging modalities have you used, and ultimately even an adequate bladder filling is very important. Again, Figo strongly recommends that the ultrasound signs should be described using a standard protocol. And what is an optimal reporting when you've done a scan? This should be an optimal reporting so that we guide the surgical team regarding the depth of invasion, because if there's a high risk, there is an evidence of extensive vascularity, and the surgeon again is prepared with a lot of blood. So there's a staging system now which has come, an ultrasound based on the presence of ultrasound signs. Pass 0 is placenta previa, but everything is normal. There is no evidence of abnormal uterus-bladder interface. That means there is no loss of clear zone and or bladder wall interruption. So this is described as pass 0. Pass 1 is presence of at least 2 of the placental lacunae, loss of clear zone, and bladder wall interruption. So if these features are there, you describe it as pass 1. Pass 2, pass 1 plus utrovesical hypervascularity. Pass 3 is pass 1 or 2 with evidence of increased vascularity in the inferior part of the lower segment extending into the parametrial region. We will see how this pass correlates with the clinical findings. So this is the standard terminology of pass, which is now recommended by ACOG, Society of Fetal Metal Medicine, Royal College. So this was proposed by Figo, and all other societies have endorsed it. So why is it important to stage? Because this staging system tells us the increasing severity is associated with a significant increased estimated blood loss, operating time, length of hospital stay, and surgical complication. So it includes the depth of invasion, and we know that pass 2 or 3 are exclusively placenta percreta. So this proposed ultrasound system is showing a good correlation with the clinical grading system, which is also suggested by. So we need now to diagnose pass with each feature being described, because each feature is now going to tell us about the invasion, about neovascularity, about the vanishing thin myometrium, and the parametrial involvement. So let us get into this habit of describing our ultrasound features with pass. What is the role of MRI? I would say it is not an essential tool. Its use is limited by cost and availability of radiology experts. MRI is but very important in diagnosing posterior placenta percreta, imaging morbidly obese patient, because MRI will tell us about the depth of invasion and also its invasion into the bladder wall or parametrial invasion. What are the MRI features? Similar to our ultrasound, you have uterine bulging, you have heterogeneous signal intensity, you have dark intraplacental bands, focal interruptions into the bladder wall, and again, thinning and tenting. So if you look at ultrasound signs and MRI signs, ultrasound is about 77% sensitive with each finding. Maximum is color Doppler abnormalities, whereas focal interruption of myometrium becomes the most sensitive finding in the MRI. Elastography is also being used. Now, many of our machines have elastography. There are studies which are coming about the use of elastography. Now, once you have diagnosed, what are our next steps? We must be sure that we have a pre-delivery discussion of the possibility of the need for hysterectomy to control bleeding, optimize this mother's hemoglobin to above level, need be give her parenteral iron, but she must be cared by a multidisciplinary team who have an expertise in complex pelvic surgery. It could be an oncosurgeon, it could be a urologist, it could be anybody who is dealing with complex pelvic surgery. It should be done in a specialist center where there is immediate access to blood and blood products, and there are good anesthetist services who can provide a good adult and neonatal intensive care facilities. When do you time their delivery? There are various recommendations, but the whole premise is that you want to provide the best balance between fetal maturity and risk of an unscheduled delivery. What if she starts bleeding in the middle of the night? This is what is on everybody's mind. Will we be prepared with the blood? So this has to be balanced. And then it should be tailored to each unique set of circumstances. If you have had a mother who had a history of recurrent previous preterms, she's had multiple episodes of small amounts of bleeding, or there's been a large amount of vaginal bleeding, or she has premature rupture, 34 weeks after a dose of steroids is a good gestational age to manage. This is a recent article which speaks about evidence-based guidelines for the management of abnormally invasive placenta, and they have recommendations from the International Society. And there are so many controversies, and each of them have been there. Where, when, do we need steroids? Do we need to improve hemoglobin? When to admit? So we could go through this article because we know that there's a paucity of appropriate evidence for the optimal management. And this article is trying to highlight, look at evidence for each of these. So the treatment is surgical. It could be cesarean hysterectomy or a delayed secondary hysterectomy. And this should be, again, individualized after balancing the potential benefits and risks. And once you have done the surgery, you need to do the Figo classification. It's because this is now grade 1, 2, and 3, and they're trying to correlate it with PAS. So you have grade 1, where you have abnormally adherent placenta, where the villi are just directly adherent but not invasive. And this would come as PAS 1. PAS 1. PAS 0 is, yes, where the placenta comes out. Grade 2 is an abnormal invasive placentation, where the villi invade. So we have PAS 2 and 3. Grade 3 is again A, B, or C, where it is limited to uterine serosa, bladder invasion, or invasion into pelvic tissues or other organs. Always, always send the hysterectomy specimen for histopathology, because the histopathology is the only tool which will assess the depth of invasion. So it's very important to correlate your PAS ultrasound staging to your Figo staging to your histology staging and see where do we stand between ultrasound. So we need to correlate the findings of ultrasound with surgery with histopathology. Now, what is the conservative management, where the placenta and uterus are left in situ? You may even do a partial myometrial resection. And this is considered in 2 circumstances, where you feel that the hysterectomy may be complicated with a high risk of hemorrhage, or the woman is very, very desirous of further childbearing. But we must be aware that the bleeding, DIC, and infection is very high. The chances are very high in these conservative. So are there any intrapartum adjuvant measures which can improve the maternal and fetal outcome? Yes, ureteric stent cystoscopy have been described, prophylactic endovascular balloon catheters, and you could do internal iliac artery ligation, aortic clamping, uterine balloon, uterine compression, or pelvic tamponade. To conclude, wherever there's a previous cesarean, certainly locate the placenta, and if placenta previa, anticipate, detect, diagnose adherent placenta. Ultrasound is the first modality. Color Doppler use improves the detection rate. MRI gives a good predictive accuracy. Any suspicion of Acreta then should be managed with a multidisciplinary care at a tertiary care center with access to an intensive care facilities and access to blood and blood product. There should be a meticulous preoperative preparation and definitive extirpate surgery. To reduce the chances, let us all vow to attempt to reduce the first cesarean, because this increasing cesarean section is a very disturbing trend. Let us all strive to save our mother's life, and we must aim to prevent any woman from dying during pregnancy and childbirth. Thank you.
Thank you so much, madam, for such an elaborate discussion on the placenta accreta spectrum, its various grayscale and color Doppler findings, the newly proposed rail track sign, the role of MRI and elastography, and also the management options. And of course, as you said, it's very important, apart from the detailed evaluation of the fetal anatomy, we do need to evaluate the placenta also in detail, especially in the presence of risk factors like previous cesarean section. And since the count is on rise, we need to check our primary cesarean section rates to decrease this obstetric morbidity of placenta accreta spectrum. So I would like to invite our our speakers of the previous two sessions, that is Dr. Indrani ma'am and Dr. Geeta Palar ma'am, so that we can take up the questions. So we have Indrani ma'am, we have a question. Ma'am, if a patient missed the FTS and came for routine quad test and we find one soft marker with low likelihood ratio, should we reassure her based on second trimester markers or proceed for quad test for which she actually came?
Can you just repeat the question?
Yes, ma'am.
FTS missed?
So if a patient has missed the FTS and she has come for a routine quadruple testing, and on doing the genetic sonogram, we find a soft marker, but it has got a low likelihood ratio. So should we reassure her based on the genetic sonogram, based on the second trimester marker, or should we proceed with the quadruple testing for which she had actually come to us now?
Yes. See, when if you look at genetic sonogram and quadruple, both of them have got a similar sensitivity, around 65 to 70% sensitivity. And you said the marker which has got a low LR. What we need to do is you put it in that LR calculator. So you feed, if there is one marker, as I showed in the echogenic intracardiac focus,
yes,
age risk is 936, and then you click. Then age risk is not changed. So age risk is same, it is around same 930 or 1000 it would be coming. If it is like that, you just have to tell them that this is in the low risk category.
Okay, ma'am.
Here, when we are looking, it is very important. You have to look at the a priori risk of the mother. That is why you have to select the a priori mother's risk. That is whether the conception is a natural conception and date of birth, or with any assisted reproductive technique, and then what kind of gamete, that has to be selected. And then you have to modify the risk. If the modified risk is in the low risk, we can reassure. Explaining once again, it is only a screening test. What happens sometimes, people get referred for second opinion to higher centers when already they have been worked up. All the more you have to counsel them in detail about the screening test so that they understand and they choose the option. We don't tell them do this, do that. If they are, especially already somebody has spoken about quite a few times the CA focus, pilot cases, they get referred like that. So we start once for all from the beginning. What is Down syndrome? What is age risk? What is the screening test? What is the sensitivity? When you're doing a genetic sonogram, it is not a similar risk only as quad.
Okay, ma'am. So since the sensitivity of both these screening methods is same, and if there's and if the soft marker with a low likelihood ratio does not alter the a priori risk to a greater extent, we can reassure her, right, madam?
So if the a priori risk itself is 1 in 500, it wouldn't alter much. It will stay the same like that.
Okay, ma'am. Sure, ma'am.
And can I interrupt for a second? The whole problem comes when people are referred for intermediate risk, ma'am. That is another headache. They are referred for 1 in 400 risk, and then there is a marker seen in the anomaly scan.
Yes. You see, when you are here again, you have to go back and explain them about the what is high risk, what is intermediate risk, what is low risk. because when you say low risk beyond 1 in 1,000, in that the percentage of Down syndrome missed is very, very small, hardly 1 to 2%. So if you take a cutoff of FMF tells 1 in 50 or 1 in 100, you will get about 90% picked up. In the intermediate group, you will get about 7% or 8%. If you have a cutoff of 250, then the intermediate risk group will pick up 5 to 6% of Down syndrome. So that has to be explained. That again tells us, you have to tell them the screening test is not an yes or no test. The probability of picking up Down syndrome in the intermediate group is little higher. That is why you are putting that another filter. So you have to do a little more counseling and explain them this is only a filter, and then help them to make an option. Suppose the intermediate risk, I showed one intermediate risk with 1 in 600. And then when Arsa came, it became 1 in 170 like that.
Yes,
In that case, it is important depending upon the gestational age. If they are closer to 16, 18, we can offer NIS. If they are closer to 20 weeks, we can give between NIS and invasive. You can play it around depending upon the gestational age. Because nowadays patients are, I'm happy to say that the referring doctors have somewhere they have listened in the conference and then they will write, they will round it. I'm very happy they are looking at the report and reading, not just saying positive or negative. They are looking into the numbers and looking into the biochemical values, and they round it and then send. We have to take the importance, and we have to explain a little more.
True, ma'am. Thank you so much, ma'am, for such an elaborate answer, ma'am. For those who have asked for a YouTube link, the functional YouTube link has been shared in the chat box. Kindly join through that. And the next question is, how does the risk assessment vary with the gestational age for NIPS? Indrani, ma'am, will you please take this question?
The risk assessment for NIPS doesn't vary much because we are looking at the fetal fraction of the DNA, because we are testing the fetal fraction.
Okay, ma'am. Next is, as a lot of sex chromosomal aneuploidies are mentioned in early NIPS, ma'am. So this is part of the previous question only, ma'am. So
no, actually, sex chromosomal abnormalities, especially Turner, Expo and all, yes, we do get frequently in NIS, but we have to do a direct test. Quite a few times we have done this sex chromosomal aneuploidies, Expo and all. We get a normal report when we do a karyotype, but we have to tell them it is only a screening test.
Yes, ma'am. It has its limitations.
Yes, yes, yes. Because when you are asking for 21, other things also pop up.
True, ma'am. Thank you, madam. Next question is, isolated ECFLV is very common finding. Should we disclose it to the patient?
See, actually, that is why I showed in my first case as isolated intracardiac vocals. We don't put it in the impression and then highlight it. If it is, there is a spec, we may report it or we need not report it. But what happens when gets referred from elsewhere, we have to explain them. Choroid plexus cyst, echogenic intracardiac focus. When they get referred from elsewhere, we have to explain them.
True, ma'am. We have to explain the finding, but also explain its association with the
yes, yes.
And the low
no, actually, you can say it is echogenic intracardiac focus for practical purposes. You need not highlight it to bring it in the soft marker. That is why I showed only the 4 soft markers. Which is what 3 plus and 6.
Like it shows as isolated.
Yeah. Even echogenic and bowel, I did not highlight because in echogenic bowel, again, I find lot of fallacies. Whenever the stringency is not there in performance, that the quality control difficult to maintain. Nasal bone reasonable. Aberrant right subclavian artery also properly done reasonable. NFT also again, lot of variations will be there.
Yeah, ma'am. You had said about the oligocephalic head and all, which may give to an erroneous measurement. Thank you so much, madam. Next question. In case of placenta accreta spectrum, how early can MRI be asked for confirmation? Dr. Geeta, madam, will you please take this question, madam?
If an ultrasound has been done well and there is a suspicion, I think she can be followed up, and later when you want to look at the depth of invasion, you could look at it. But if there's a doubt initially and there is a suspicion and you want it to clear, that is the time. It could be late second trimester or third trimester, because that's when the preparation, the anticipation, explaining it to the patient would start. So whenever you want to confirm it, you can ask for it.
Is there any lower gestation cutoff like 24 weeks and all? Because we may have some suspicion signs at around 18 weeks also, ma'am. So
yeah, I know. See, because if it's Percreta, we've had invasives into the bladder and she's had bleeding, hematuria. At that time, you don't really need an MRI.
Yes, ma'am.
In very early cases, where a good ultrasound should be able to pick it up. It is only in suspicious cases, then you will ask for an MRI. I would still insist on late second or third trimester.
Late second and third trimester. Sure. Thank you, madam. Next question is isolated markers like Arsa or prominent K1 vertex. How to counsel in such cases? Dr. Indrani, madam.
This echogenic intracardiac focus I have already addressed.
Yes, ma'am.
Counseling is, you just say it is a changing finding in the fetus which has got no relevance in the function. Structure of the heart is normal, function of the heart is normal. This is a passing phase. Like I don't know how this K1 case, that is not relevant to the soft marker. Anyway, whenever you have K1 vergae or K1 septum delusion, you have to do extended neurosonography and go by the findings.
Yeah, ma'am. And if no significant findings, then we can reassure the patient it to be a normal reading. Thank you, madam. Next question. Anything can be done during primary cesarean section to prevent placenta accreta spectrum during next pregnancy? Dr. Geeta, madam. Geeta, ma'am. Can you please take this question, ma'am? Ma'am, you're muted. Geeta, ma'am, you're muted, madam.
Can I get the question again? Sorry.
Yeah, sure, madam. Anything can be done during the primary cesarean section to prevent the placenta accreta spectrum during the next pregnancy?
That's really, we're not really trying to find out, because a section done in an institute, we rarely get them. So is it the suture material? Is it doing a section properly, resuturing? Certainly they have found that single layer closure probably leads to a higher chance. Presence of infection after the section again may increase the probability. But suture material, suturing of the peritoneum, none of those have been associated still with a higher probability of abnormally invasive placenta. But I would say try to see if the section is justified. Try to do a good section with good hemostasis, prevent infection. Double layer closure may be useful in preventing adherent placenta.
Sure, ma'am. Thank you so much, madam. Does uterine artery embolization have a role in placenta accreta spectrum, ma'am?
If you've retained the placenta, not sure, but uterine balloon inflation is more useful than embolization. Embolization, if you've retained the placenta and she's bleeding, maybe, but no, not aware of that. But yes, inserting balloons and inflating it once the baby is delivered to see that you reduce the hemorrhage. We've had a good series of about 20 cases at our hospital.
Nice to know, madam. Next question is, if XXX reported on the NIPS, ma'am, should we go about it, and as it has varied spectrum, and how to counsel the couple for any further testing?
As we said, when you come across the sex chromosomal abnormalities, we need to do direct testing first and foremost. And then that also tells triple X means we have to counsel according to the usually when there is extra X, there could be some disability like, but whereas when you have extra Y, it may not. So we have to go into the recent literature and then counsel. First to do the direct testing.
Ma'am, there is one more question in the same line. If in the combined test, biochemical risk for T21 is 1 in 180, but the overall risk is low. PAPA is 0.8, beta HCG is 0.5 mom, and target scan at 21 weeks detected Arsa. Do we offer direct testing now?
Here I would like to say, when they have done biochemistry and NT-NB, please take only one risk, combined risk.
Yes.
Don't go by, if they have not done NT-NB, ultrasound markers are not included in that. Only biochemistry means it has got only again 65% sensitivity. Only biochemistry in the first trimester is only 65% sensitivity. So if you take that, and then it will be overall, if you mean that NT-NB risk has been added and then it is given one risk, take that only. Don't this again I find many reports they give biochemistry risk and then age risk and then NT risk, NB risk. We should not be confusing ourselves with that. We have to tell the lab, give only one risk. This is where audit and standardization of laboratory, like FMF, how they are standardizing all the ultrasound markers and put stringent guidelines. Similarly, laboratory also. That is why some only the labs also should be audited and certified.
True, ma'am. So as to avoid unnecessary confusion.
Yes, you have to call up the lab and tell them, do it this way. Because then we are, as a caregiver, we are sending for some blood test. And then the other end, the lab is doing, means you have to talk to the lab head. Several times we have done that.
True, ma'am. Ma'am, in the case if target scan at 21 weeks shows Arsa, do we offer direct testing now? Again,
you apply the LR. Combined screening, what is the LR? If it is suppose, for example, I'm telling combined screening is 1 in 4,000. You apply close, LR will be 4, it will become 1,000. So if combined screening, the LR is, the risk is 1,000, it will become 250. So you have both the risk on hand and then talk to them.
True, ma'am. Thank you so much, madam. Next question is, ma'am, if suspicious of abnormally invasive placenta in first trimester and patient wants termination, should we take this indication for termination or otherwise for follow-up scans? Dr. Geeta, madam.
Very, very interesting and very appropriate question, which we are trying to find answers. Yes, if it's a cesarean scar pregnancy and it's growing towards the bladder, certainly, yes, she should be explained and given the option. Even if it's growing towards the uterine cavity, we explain the risks to her and give her the choice. But even if you're doing a termination, what is the appropriate method today? Will she not bleed even this at this time is what has to be explained. Certainly, it's a good option. If she's desirous of this, we should be agreeing to that. Yes, I agree. But certainly the method, and if she bleeds, what are our methods to control the bleeding should be in place before we offer that termination is what I would say.
Complications should also be anticipated.
Yes.
Thank you so much. Vidya madam, I cannot see any more questions in the chat box, ma'am.
No, I think
we have covered all the questions, ma'am.
We have covered all the questions, and thank you, Indrani ma'am and Dr. Geeta, for such an enlightening session. And we will definitely look forward for further sessions in the coming days. Thank you, ma'am.
Thank you so much, madam. Thank you so much, Indrani madam. Thank you so much, Geeta madam.
Thank you, Vidya. Others, I will sign off. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you, Dr. Geeta.
Thank you, Geeta, madam. So
Cecile, you can take it.
we have already crossed the limit of 11 o'clock, which we had assigned for the previous session. So we will cut short the upcoming break for 5 minutes only, and we'll see you back after 5 minutes with the next interesting session with Dr. John sir and Dr. Vivek sir. Please stay tuned, and you will have the spotters displayed during the break time. Thank you.
Taseen, you are muted. Taseen, you are muted. Hi, John. Yeah, we are starting. Yeah. Taseen? Hello, Taseen?
Am I audible now?
No, now yes. Now yes. Go ahead.
Okay. So, sorry, I was unmuted and I was unaware of it. I welcome you all again. And now we have got a very distinguished dignitary with us, and I've got the privilege to introduce Dr. John Smallnick. May I have his CV, please? Sir is the Stream Director of Obstetrics and Gynecology. Am I audible?
Yes.
Sir is the Stream Director of Obstetrics and Gynecology at South West Sydney, and he is active clinically in the subspecialty of the maternal fetal medicine. He is a member and fellow of the Royal College of UK as well as Australia and New Zealand. He has done his fellowship of maternal fetal medicine at St. Michel's Hospital, England. He is right now at the Liverpool Hospital, where he had joined earlier as a staff specialist and now is leading the unit and is the director. And his areas of special research include fetal therapy, hemolytic diseases of the fetus and the newborn, and monochorionic twin pregnancies and their neurodevelopmental outcomes. He has got hundreds of doctors trained from all over the world and has got many clinical trials and studies and audits to his credit. And to speak more about Sir, we have got his favorite student, Dr. Vidalakshmi R. Over to you, madam.
Good morning, Dr. Smallnick. It's a real privilege to welcome you again for Kim's Fair. You've been with us twice before on live, and which John CV doesn't mention about. He started his career as an engineer, which was a surprise to me. He did his BTech on mechanical engineering and later decided that is not my way. And I can't count his degrees. He has done his RCOG, has done his MFM from the UK, then came to Australia, then done his MFM from Australia, Ramscock, and endless there. And more than anything, I find a good human being in him, a passionate doctor who will stay with the patient, hold her hand anytime she wants. The stage is all yours, John. I don't have any more words to represent you for this congress. And I'm really happy that you are here with us again. Thank you.
Thank you for the invitation. It's always a pleasure. Usually better if I'm in India and enjoying the environment. But obviously with COVID taking over the world, that's a bit of a challenge. So let me just cut to my speech, lecture. Can you see that?
Yes, sir. Your slides are visible, sir.
Okay. Okay. Hear me?
Yes, sir. Please
Good.
go on.
So what I intend to do with your meeting is go through current therapy for rhesus disease and any hemolytic disease. And then tomorrow introduce you to an exciting new research which could change the management for those who can access to maternal-centric treatment. So without any more ado, let's get going. So reminding you all it's an immune disease called alloimmune rather than autoimmune. IgG mediated like many others, and that'll be very relevant to the future maternal centric management. It's associated, as you know, with fetal morbidity and mortality. It increases often the severity with subsequent pregnancies. It's preventable for those who have access to anti-D, significant difference in incidence and deaths, and I'll show you later, and there's an example of the significant reduction if you use prophylactic anti-D and if you have it for any risk event in pregnancy. But the prevalence varies with populations, and that's important. So not everyone will have the same demand on their service. It depends on the population and that gene frequency which is causing hemolytic disease. And I gave you an example there of the difference from China to, let's say, Caucasians, and to the Basques. The Spanish Basque have a 40% rate of rhesus negative. And the most important thing to all of you interested in maternal-fetal medicine especially is that the treatment is the most successful in the world of all the fetal therapies. Think of all your shunts. Think of if you're into laser for twin. Think of even if you're into putting the plug for CDH, which is a rarer, spina bifida surgery, obviously much more common in developed countries, but nothing comes near usually good fetal transfusion therapy, which falls under fetal surgery. Just an example of the perinatal mortality. So where we've come with the management from the 40s, you can see the terrible figures that you'd find, gosh, how could that be possible? Then the 70s, the prophylaxis started coming in 68, and it halved, let's say, the death rate. And then the 90s, look at it, way down to, 1.3 compared to your 32 back in the 40s. And that's with ultrasound therapy, but prevention, people education must be more important. And in good centers who have enough cases, it's over 90%, obviously, if they have to transfuse, and the hydropics are less, and it depends on when they get it. And usually getting them hydropic is maybe a failure of good screening or awareness. So just reminding you of the simple pathophysiology. You've got baby, fetus, mother, you've got the interface, which is the placenta, you've got feto-maternal hemorrhage. This represents a reticular endothelial system, the immune system seeing this foreign antigen come through, reminding you in the different trimesters that this happens, the frequency of this hemorrhage, big difference from third to first. And that affects, obviously, if you really know first trimester, what the gestation is, whether you give anti-D or not. And then the response of the mother seeing these cells is obviously antibodies going back, get on the fetal cells. And interestingly, the fetal reticular endothelial system, then shown here, causes the hemolysis. So the maturity of that was always fascinating to people. We thought that you would only have a mature fetal immune system at about 22 to 24 weeks. Some people thought it was a bit later. We now know there are a few cases, it's thank goodness a small percentage, who it can be under 20 weeks, which are the real challenges. And really looking at how do you manage these? So you've got mother, placenta, fetus, and obviously preventing the immune response is your anti-D here. Over on this side is the treating the fetus with transfusions, which I call fetal centric. And over here is what some of you will know, maybe have used, which is trying to immunomodulate with IgG plasmapheresis. When I was in Bristol, they relied massively on plasmapheresis because they had nothing else at the time. Fetal transfusions were only coming. So the mothers were getting sort of their IgG washed out sometimes 3 times a week and trying to get them to a viable gestation. And here's just a summary of slide just showing you again fetus, positive cells going over, then basically antibody coming back to attack. Here's a little cartoon showing you the antibodies coming across the percentage, which will be relevant to therapy, which we'll touch on tomorrow. And then the stepwise, the red cells that cause the most common in developed countries, D, Cal, and little c, are most aggressive. You get your fetal maternal hemorrhage, we've done that. You get what's called other immunization, not quite auto, because it's a combination between mother and the father. The IgG antibodies cross the placenta and then start causing, they get hemolyzed, progressive anemia, heart failure, hydrops, death. This is what used to be in developed countries, rare to see it, but if you get new immigrants in that, it's possible that you'll see it. And then the bilirubinemia, and if it crosses the blood-brain barrier, then you get kernicterus and cerebral palsy. So not a significant disease. So the management is simple. It's like everything else. Education, this is the base of the pyramid. You've got to get your education to alert people to know about it, and it's rare, so that has to be worked at. You have to use your blood banks to alert you to an antibody that could cause things. Then it's up to you to organize your screening. In most cases, you can't have that all done by the tertiary center, so you have to have your other centers aware and kept aware all the time. So not only the people doing the transfusion should be aware, but more importantly is most of the others. And then you won't need to do transfusion. Surveillance, diagnosis of anemia, and treatment, which should be really done by those who get enough to keep their skills, their team skills, etc., up, which is a challenge with the frequency in developed countries. Blood transfusion center expertise is a massive, massive influence on getting this done. If you have a center that does a large area, you must have the tertiary hospital, it's obligatory to have meetings, close liaison with these people, and they should copy you into every antibody they think could cause hemolysis, as well as copying it to the referring doctor, the referring hospital. And you should have a system where you can maybe phone that center and say, I see you've got an antibody, and if necessary and politely see that they're doing the proper screening. Can they do the surveillance? Do you need to advise them on that? Do you need to see the patient once and set out a plan? So your blood transfusion service, the serology, you must get to know like hand in glove. If you don't do that, you are not doing your job as a tertiary center. And basically, out of sight is out of mind. In other words, these cases, I can tell you, in developed countries like in Sydney, New South Wales, we have 7 fetal-maternal centers with about 4 MFMs in each. And not surprisingly, they're not going to keep across what all the antibodies are. So our blood bank serology are alerting those centers, and they discuss it in meetings and keep sharing it, educating themselves. And as I said, alerts on the antibody results. We have that set up. I encourage you, if you haven't got it, to get to know, phone them up and let them know. And they love it. They love to know the implications. They don't like just sending out reports saying this could be cause hemolytic disease. They like to know the outcome. So they usually love the meetings. I just want to emphasize part of the phenotype. When I started doing OMG, there was a mentality that you couldn't trust who the father was. And I basically said, I find that hard to believe. I would always talk to the mother alone and say, you know how important it is to know who the father is when we're looking at the paternal phenotype and the risk of a fetus, let's say, having an antigen that the antibodies that you found in the mother might attack. And I felt that you just had to trust her and that should go on. And unfortunately, when you live long enough like me, you come across cases, even people who on the outside are very educated, who this actually doesn't work. And I've got some very good examples. And basically now I would say is that we've got a new technology which we can complement. Now, most people will tell you the truth and they do know who it is, but there's some that get into complex situations and can end up not knowing who it is. And you can use, therefore, in Big D especially, and now in Kel, you can do your cell-free DNA and tell what the fetus is. And in one of the cases we had the woman on IVIG because she had a very bad history. And we'd already started it when we found out that the fetus was negative. And I had to go back to her in confidentiality and say, look, the present partner that we have typed is not the father of this child. Is that possible? And then she said, yes, it is possible. So amazing that we've gone round in a circle. So cell-free DNA is now, can be helpful, but remember, you don't get it in all the antigens. And here I've just mentioned, but CALS now, we don't have it in Australia. We're just going through work. Remember, the cases are low, validating it, but Europe do have it. And just reminding you of the surveillance for those of you who scan, the New Zealanders, this is a liver, and they became, before the use of the velocity, they found that this was very useful adjunct to, before hydrops or ascites, to picking up the erythropoiesis increase extramedullary that you find in the spleen and the liver. And they became very good, published a lot on that. And, you know, you might say you don't need it anymore. Well, it's interesting. I was doing a case, in fact, this week, and I suspected it would break through. It was one of our immunomodulator cases. The middle cerebral was creeping up, hadn't crossed the threshold. And I thought, oh, I'll do the good old liver and spleen, and they were up. And in fact, we have a thing here where we do a dequant, which is a very objective way of looking at teters. Teters can be very variable depending who does them. And we found a dramatic increase in them despite the medication we were giving had initially decreased it, and the baby ended up being very anemic. And this is what is, you know, is going to be very anemic once you start seeing the fluid around the bowel, that's ascites, and you know, the hemoglobin's going to be, you know, down in the 3s, 4s. Not always, interestingly, depending on how gestation, the early gestations won't show it, and yet they'll have a low hemoglobin. This is what you all know now, is using velocity. And just a warning, when you do it a lot, you'll see the variability and you'll realize how important it is, obviously, to do it with the baby ideally quiet. It must not be breathing. You'll get any value you can like if it's breathing. You cannot use that, and it's tedious. You have to send them away or out the room, start another one, get them back in and hope they're not. So early on, under 20 weeks, I find, and late in pregnancy, the middle cerebral Doppler has a very high false positive. And obviously later on, you definitely don't want to miss anemia in, let's say, a first pregnancy. And early on, you don't want to go in unnecessarily and maybe aggravate an anemia or a life because of the middle cerebral. And I'll give you an example. That's where expertise in centralizing, et cetera, is very important. So those requiring that we see day to day, with the majority of cases anemic, they obviously get treated. And most of them are beyond 27 weeks. So this is a big study done by the Dutch here. One center does the whole of their country. So they do the best quality research publication in hemolytic disease and show that 75% are going to be over 27. What that means to most of us is they have much bigger pipes to access for transfusion. These, unfortunately, are becoming the challenge, the under 20 weeks. For those in developed countries with good prevention anti-D, we're seeing a greater percentage of those rather than these late ones. And here's an example of a high-risk early onset doing middle cerebrals. What we've got here is the velocity on this axis, the gestation here, that's 16 weeks starting. And this is your 1.5 mom line. And this is doing values on the baby at 16 weeks. So I'm doing it, I'm getting some coinciding, but some later. I look at the history as well. Has she had a loss earlier? Decide, am I going to intervene or not? In this case, didn't. Went further, look at how it's widening, look at the range of velocity. So if I want to intervene and do an IPT, let's say, I've got enough justification. But on history and that, I just thought, no, I don't think it is that. I got to 18 weeks, and again, let's start. Look at this ridiculous range I'm getting. So I decided I'd use quinine and do an OD450, avoiding the placenta, please, otherwise you can make it worse. And use that, and only when that went up and this went up did I go and sample, and it was anemic. But really, I had justification to most probably start from here, definitely here, and at these gestations, putting the needle in, you're asking the trouble, so you've got IPT. And it may not have needed it. You don't know what the hemoglobin is. So there's a high false positive around here. aware. So the management of types, I told you, the ones that never had a history of antibodies, they developed from preterm hemorrhage and pregnancy. As you know, most of that you'll get away with because more likely it's going to happen late, and you might end up with maybe preterm delivery at most. And in some people, they transfuse up to 35 weeks. A lot of developed countries won't anymore. You might find the baby anemic to transfuse it at 34, maybe 33 if it's big enough, maybe earlier if they're very unlucky. Especially if they've had if they're rhesus negative and they had an invasive procedure, let's say like a CVS sometimes can sensitize them with high if antibody is not given. Or someone didn't know they were rhesus negative. Postnatally, if you really wanted to catch all your rhesus negative, you do a postpartum screen at 6 months. That's hard to, unless you've got a very good system and a small population to screen. You'll find a lot of people who are rhesus negative where it's failed around the delivery phase, and you'll only see the antibodies at 6 months. So you only find in the next pregnancy already when they're there, that they were there most probably from the last. And pre-pregnancy counseling in the severe cases is very important, depending on their previous history. So obviously history is important, and some people say to classify, we'll put them into the group that had a transfusion and didn't, and that's even full of holes, because as you know, some people do preterm delivery rather than a transfusion, and others might do a transfusion and find that it was for actually the hemoglobin wasn't that bad, especially if you use 2 standard deviations, that's lower normal range. Obviously, if they've had a transfusion, intraperitoneal, IVIG, plasmapheresis, they're usually the very severe group, you'd like to think. And neonatal, you can learn a lot about whether they needed exchange or not. And why I say that is we once had anti-E is very rare to cause prenatal hemolysis, and yet we got a woman back who said, I had an exchange transfusion. We watched her closely, and she started intravascular transfusion for big E at 26 weeks. So history, everything. These are a few things. For those of you who do it, you'll know them well. The intrahepatic vein, maybe using the free, almost near the cord, but I'm just showing the small values, how easy it is to be in and out. You can get a fetal blood sample maybe easily. You go to transfuse and you're in the wall, you can kill them. Here's doing it at the cord insertion. And just reminding you that the small group are the real challenge now. So immunomodulation, you all know about it now. IVIG is thrown at you. Plasmapheresis, I told you, was much, we used to do it before. The Americans quite liked doing it early on and then throwing in IVIG. And then in some of the really bad cases, they throw in an IPT as well. And remember that IPT was something that was done before ultrasound was any good. So are we going forward or backward? Yeah. So what are the challenges? The challenges are experience, learning curves. You know, you can see someone else do it, you go back, you'll go through the learning curve. What's a learning curve? It's not just your skill with an ultrasound and a needle. It's your team. Your team, someone joining, attaching a syringe to your needle can displace if you're not careful, if they get very nervous. The sampling to know what is the first hemoglobin attaching, starting to give the transfusion, you can get a contraction. I had someone helping me when I was in Bristol, and they got confused with the three-way tap, and I was keeping an eye on them, suddenly realized that they thought they were sucking blood up from the sac and they were taking it out of the baby. So you can never rest with this. And the other thing I find very useful is you need to monitor, because you're giving them very viscous stuff. And if they're borderline, they don't like viscous stuff quickly. Whereas some of the the original guys, you say, I just bang it in as quickly as possible. Don't. You'll see end-diastolic disappear if you do that, because the viscosity goes up if you put your Dopplers on as you're doing it. And I would encourage you to use color Doppler and measure heart rates continually. As you start overloading, the heart rate will come down. And also you'll see if you're occluding the cord that you've actually, the needle has moved just a little bit. In the early ones, it's in the wall, and if you transfuse, you're going to obstruct, unfortunately. How do you maintain it? You have to be talking about it. You have labs, you share it with your colleagues. So even it's like an operation. you do an operation, you can be a great surgeon, but if you've got a useless assistant, it really makes it difficult. So your assistants are as important as the person putting the needle in. Caseload, we found, we started in Bristol, we had 40,000 feeding in Caucasians, so it was 15%, and we were getting 1 per month new case. And I would argue that if you said, what is ideal to be a center of expertise, 1 new case a month, your team builds up, your people who can do it build up, and you maintain a really high standard and you teach well. As I said, the technical skills have been changed. You've got ultrasound, you can do all that, but remember what NIPS is now doing to invasive procedures, because NIPS is decreasing the number of amniotes, decreasing the number of CVSs, which is in fact, I would argue, a very good learning ground for doing good fetal blood sample, good intravascular transfusions. And really what does that mean? That in the future, you might have to give invasives to people who are very good with their fingers and hands. They've got nice, light touch. They never tense up. Some people can be academically very good, but are not very good with their hands. And maybe they're the ones who can aware and advise what's best. And you can get someone almost like a really good technician who can do the needling and even the team assistant attaching to those needles, just screwing it in, not pushing and pulling, with you trying to prevent it being pushed through the wall of your sampling site or not. Prematurity is important because in some centers, developed worlds, the NICUs are really good. And what's happening is rather than to do even sometimes easy transfusions, the patients are a bit afraid and they ask, well, what's the outcome? And it's almost 100%, but there's significant prematurity if you deliver it at 32 weeks. And we had a very good center, a very good person who trained in the UK, was an expert there, did a transfusion at 32 weeks, straightforward, sent them home, the baby was dead 2 days later. And that shocked them so much that that hospital now will not let anyone go beyond 32 weeks who gets transfused. On the other hand, there's someone who's a world expert somewhere else who will transfuse up to 35 weeks. So prematurity associated with varies depending on those services around your NICU, etc. The NICU expertise is massive, and the pediatric, otherwise you send these transfused babies to them and they keep topping them up and the bone marrow never kicks in and the mother then gets worried. The immunomodulation problem you have to worry about is that it is expensive. So if it's through you have to pay for it, it is very, very expensive. And if you're battling to get anti-D, this is going to be a challenge to get. Plasmapheresis also can be expensive. This is an example for New South Wales of how we've been challenged. I got this from Red Cross recently, data on transfusions in New South Wales. New South Wales have about 100,000 deliveries a year. And this is over 2.5 years approximately. 2.5 years. We've got 7 centers. Each center has, as I said, anything from 2 to 4 fetal medicine specialists. And how many cases in 2.5 years? 8. And all of them are offering it. Now, is that the way to maintain expertise? No. And that's acknowledging the data from them. So what are the challenges? You pick that up. The treatable cause of anemia have reduced, and now we're seeing a lot more of the more serious cases, but you have to do that. You have to have good education at the ground level. So don't forget that. You've got in the centralized areas, ideally, you've got to centralize it and maintain those skills so that you can do the procedure, don't have the problems. You need a team, remember? And the implication is, as I said, medical education to all, if you're going to minimize the number of late referrals and high drops. Solutions, you must decrease the number of centers. Let me tell you, fetal medicine people, especially new graduates, do not like it to be centralized. They all want to transfuse. They all want to stick needles in. I'll tell you an example. We do subspecialty training with me. And what do these new trainees want to do? They can't even scan, and they keep telling me, when can I do an amnio? When can I do a CVS? And, you know, I have to say never unless you get your scan skills up. And now it's even been more challenged that we might have to say only some we will allow to do because there's too few invasive procedures. Centralization, you want to see the best literature on hemolytic disease, read Leiden. They centralized way back in, I think, 1990 or even before when CanI was there. It came from the government, and they've got the best system in the world. They train their people well, everything. So they're the best. Continuing medical education for all the time. If you're a tertiary center doing it, you've got an obligation to run courses for everyone seeing a pregnant woman and reminding them over and over again. Immunomodulation may be the future to eliminate the challenge of these technical challenges and losses associated. And this is the old way of doing it, I'd argue. And tomorrow I'll talk about maybe the new way. Thank you.
Thank you so much, Dr. John, for such a detailed discussion on the fetal hemolytic disease, starting from the pathophysiology, covering up the diagnosis and management, and also the limitations that we are facing right now. So thank you so much, sir. Moving on with our next presenter, we have another esteemed, reputed, and a dynamic fetal medicine person, Dr. Vivek Krishnan, sir, with us. Can I have his CV, please?
John, please stay until the end of the session for the Q&A also, until Vivek finishes his talk.
Sure.
Thank you.
Dr. Vivek Krishnan has done his fellowship in fetal medicine from the Mediscan Systems, Chennai. He is currently the clinical associate professor and head of the division of fetal medicine and perinatology at the Amrita Institute. He is also an adjunct faculty member of the KMC Manipal, has authored the book Obstetric Trial Long Cases, and has got certified training in fetal therapy from Berlin and fetal neurosonography from Israel. His special areas of interest include prenatal screening, fetal medicine and obstetrics, fetal neurology, and fetal therapy. And he's also a board member of the maternal fetal medicine examinations conducted by NBE. And after a detailed and elaborate explanation by Dr. John, Dr. Vivek will throw some light on the scope and the limitations of fetal therapy in the Indian scenario. Over to you, sir.
Thank you. Thanks to Vidya ma'am and to the KIMS team for this wonderful opportunity. But technically, I'm still part of the KIMS team, and I hope it stays that way for long. Can I share my screen? Yes. Can you see my screen?
Yes, Vivek, we can see.
Okay. So I will speak elaborately on the scope of fetal therapy and perhaps a few words on the limitations of fetal therapy in our setting. You heard Professor John give you a very vivid description of the limitations and the complications associated with fetal therapy in the setting of fetal anemia. So I will briefly touch upon that as well. Well, with the kind of advancements that we have made today with ultrasound, virtually every fetal problem that you can think of is getting diagnosed increasingly in the antenatal period. And you can broadly probably classify these anomalies or problems into three types. One, for example, is a condition like anencephaly, where you have absolutely nothing to offer in terms of prenatal treatment. Then there are some other conditions where you do not really need to do anything before birth because you know that the outcomes are going to be excellent with just postnatal therapy. A classical example is, let's say, a transposition of the great arteries. You do an arterial switch on day 1 or day 2 of life and the baby goes home absolutely fine. Then there's a third group wherein you know the natural history. You know that if you do not intervene in time, this baby may not live to see the light of the day because either you do not have a very effective postnatal therapy, or because if you wait till postnatal therapy takes effect, the baby could have irreversible damage. And you also know from data that there have been animal studies that have said there is a scope for an intervention in this case, and there have been studies that have proven that interventions could be beneficial in such cases. And these are the cases that would actually benefit from fetal therapy. So for every single case, it is a question of benefits versus risks. So if you decide that the benefits are going to outweigh the risks of fetal therapy, then that is the ideal case for fetal intervention. And this is essentially what forms the crux of the guidelines for fetal therapy laid down by the International Fetal Medicine and Surgery Society. So the remainder of this lecture, I'll be basically looking at those fetal conditions that can really benefit from fetal therapy, those conditions where, as I said, the benefits outweigh the risks. And we will look at the rationale as to why fetal therapy is beneficial in these cases. And I'll also give you a glimpse of the fetal therapies that we offer in these situations. The first, of course, as you heard Professor John very categorically state, the most beneficial of all fetal therapies known to mankind is the treatment that you give for severe fetal anemia. You heard him say there's more than 90% success rate there. Now, the etiology of severe anemia is not always alloimmunization, but of course that remains the most common cause. But of course, you could have rare causes like a parvovirus B19 infection, some cases of severe fetomaternal hemorrhage, some blood-stealing tumors in the fetus, and of course, as part of complications that you get with monochorionic twins. Now, irrespective of what causes the anemia, the treatment of choice is intrauterine transfusion, because if you do not correct anemia in time, it could progress to lead on to cardiac failure and eventually high drops, from which point bringing this baby back is going to be really, really difficult. So what you want to do is to identify anemia very early in the timeline and break this timeline as early as possible so that you prevent high drops and fatal death. So how do you suspect anemia early? Is to ask the mother for a history of sudden reduction in fetal movements. Remember, when there is severe anemia, there is hypoxia. The brainstem senses this hypoxia, it reduces its fetal movements, and a hypoxic baby tries to conserve all the oxygen that it has by reducing its movements as well. So a sudden reduction in fetal movements could be a very important clue to as a warning sign. But of course, you would want to objectively diagnose that by looking at the MCA PSVs, as you heard Professor John say. If the middle cerebral artery PSV is above 1.5 moms, that is suggestive of fetal anemia. But as you said, mind you, there are false positives. There is around a 12 to 14% false positive rate for MCA PSVs, especially at the extremes of gestation, somewhere before 35 weeks. So sorry, before 18 weeks and beyond 35 weeks, there could be false positives, which is why it is important not to look at just one value on one day. You call them back after 12 hours or 24 hours, take a series of values, and then decide on the trend to see if there is actually a fetal anemia or not. You could also look for other signs that Professor John was alluding to. This could include extramedullary hematopoietic signs of an enlarged liver and spleen. You could find a thickened placenta because of high drops. You could find polyhydramnios. You could also find severe signs of high drops, particularly first in the abdominal cavity, because ascites is the first sign of high drops in a fetus with anemia. Now, how do you manage once the MCA PSV goes above 1.5 moms? You look at the gestational age. If it's below 35 weeks, those are the candidates for intrauterine fetal transfusion. Now, the second indication for fetal therapy would be space-occupying fluid collections in the chest. Now, what happens here is that, for example, in this case, you have large volume of pleural effusion there. You can see that the heart and the lungs are squeezed to one side. This could lead to pulmonary hyperplasia. It could also lead to cardiac compression, mediastinal compression, and high drops, both of which are something that does not do well once the baby is born. So you would want to offer fetal therapy. You would want to let out this fluid collection in the thorax so the baby can breathe better, and the cardiac function could be a lot better at birth than it would be otherwise. You could also have other conditions like a large type 1 CPAM with a huge dominant cyst causing the same effects. It could also be pericardial effusion that is there because of, as in this case, we saw a pericardial teratoma there. So irrespective of what the fluid collection is, the treatment is to drain out the fluid into the amniotic cavity by putting in what we call as a shunt, what we call as a thoraco-amniotic shunt. So you're compressing, you're relieving the compression in the chest by draining this fluid out into the amniotic fluid. And we know for a fact that the amniotic cavity is all encompassing. It can accommodate as much of fluid as it wants. So there are different types of shunt available. Harrison's Roddick double basket stent that has come on recently. Now, principle is the same. You introduce the stent or the shunt through an incision on the, so through a needle, through a deployer apparatus onto the maternal abdomen, and through that into the thorax. One end of the shunt goes into the fetal thorax, the other end comes out there into the amniotic fluid. This is a case of pleural effusion that we shunted. This is Dr. Vijay's case. This is a case of a large type 1 CPAM that they shunted as well. Now you could see that after the procedure, there's hardly any fluid that is left in the chest. It gives you decent survivals, not as high as with fetal transfusion, but at least you get a success rate in excess of 75%, which is good enough. Now, in case you do not have the wherewithal to do a fetal shunt, the next best option is to do serial thoracocentesis, where you just put in the needle, aspirate out the fluid. You might want to repeat this as and when the fluid reaccumulates. The problem with this is you would need repeated interventions. Probably if you start doing it 20 weeks, you might need 7 or 8 aspirations before you can take the baby to a reasonably salvageable gestational age. That is the advantage of a thoracoamniotic shunt, which, if the shunt stays in place, is a one-time procedure. You put in the shunt, and that takes care of the fluid till the baby is born. But of course, there are problems like shunt migration. The baby can just blow out the shunt, in which case, again, you might have to either repeat the procedure or then revert to serial thoracocentesis, as is shown here. Now, the third situation where fetal therapy really offers benefit is when you have complications related to monochorionic twins. And we know that all the problems that happen with monochorionic twins happen because they share one placenta. And when you have a placenta that is being shared, there could be two kinds of problems. One, problems that happen due to unbalanced or abnormal vascular anastomosis within the placenta. And the other kind of problems that you have when this placenta gets shared unequally, with one fetus getting a larger share than the other. Now, abnormal anastomosis we know leads to the syndromes, TTTS, TAPS, and TRAP, whereas the unequal sharing is what leads to selective fetal growth restriction. Now, the treatment of TTTS is definitely offered from stage 2 and beyond if you go by the Quintero staging. Stage 1 is still controversial. 50% will resolve even without treatment. So you have to weigh the benefits, as I said, vis-a-vis the risks. But with stage 2 and beyond, I think there is definitely an indication for fetal therapy because the outcomes are not too good, with as high as 90 to 100% mortality of both the twins if you do not intervene in time. So the treatment of choice, tried and tested, is the fetoscopic laser, where you go into the recipient sac, you find out all the anastomosis and non-selectively burn them, and then join the dots to effectively dichorionize this placenta and make them dichorionic twins, or functionally dichorionic twins that share a common placenta with no connections in between them anymore. Now, this is the laser equipment that we use. This is a diode laser from Dornier Labs. And this is how the procedure is done. The mother is painted in drape. Your fetoscope goes in through a trocar. It goes into the recipient sac. You identify the placenta and you map the placenta to identify all the fetal vessels that are crossing and communicating with each other. You do a non-selective coagulation of these anastomotic vessels. There are different methods to do it. Either you trace across the membrane or you trace from the recipient cord downwards. Either which way, what you need to do is to identify all the anastomosis and then burn them or coagulate them with 30 or 40 watts of laser so that you effectively dichorionize the placenta. Now, SFGR is a completely different proposition altogether. You have unequal placental sharing. So one baby that gets a smaller share of the placenta ends up growing smaller. And there could be extremes of SFGR where this baby has a very high chance of dying in utero. And if this baby dies in utero, because there are connections between the two cords, this baby could also land in trouble with up to around 50 to 25% risks of either neurological morbidity or co-twin demise, which is why when you're sure that this baby is not going to make it to salvageability, you would rather be justified. For example, in this case, there's a discordance of more than 35%. There's severe oligohydramnios in the smaller twin sac. The smaller twin has already started to show ductus venosus abnormalities, and you look at the gestation age, it's around 22 weeks, far from the time that you can salvage this baby. In such cases, if you do not intervene, this baby is going to die in utero. That could expose a normally growing twin to the risks of co-twin demise and neurological morbidity, as I said. Therefore, it makes sense to actually reduce this fetus by occluding its cord so that this baby dies in utero, and this does not exsanguinate because the cord here is blocked. So that is cord occlusion as a method of doing a selective feticide in these cases. But there are different techniques by which you can do a cord occlusion, basically 3 different energy sources. One is radio frequency, the other is intrafetal laser or interstitial laser, as it is called. The third option is to do a bipolar cord occlusion, just as you would do with laparoscopic surgeries. Now, again, more than 90% survival of the normal fetus in a carefully selected case, you could effectively push this pregnancy till around 36 weeks, as good as a term pregnancy. So there is definitely a role for fetal therapy, fetal interventions in very severe cases, particularly if you look at the Grata-Costas classification, particularly the type 2 SFGRs, where there is hardly any kind of protective anastomosis in the placenta, and where the placental discordance is very severe, these are the ones that could effectively merit from a fetal therapy. The next condition that we know is trap sequence. Trap sequence is a condition where you have one fetus that is growing normally. This other fetus is being fed by impure blood from this fetus coming through an artery to artery anastomosis. So this feeds on impure blood and therefore does not grow normally, never viable. And because this pump twin has to pump for both these circulations, it is going to end up with cardiac failure and hydrops if this circulation is large enough. So there are risks to both these babies. The baby is anyway not going to make it. If you let that continue to grow, the other one could get into trouble. So therefore, it again makes sense to do a cord occlusion for the non-viable trap or the acardiac twin. Here again, the same three methods of cord occlusion is feasible: intrafetal laser, radiofrequency ablation, or a bipolar cord occlusion. Now, this is one case where we did an intrafetal laser, slightly advanced gestation, close to 26 weeks. Today, we would have probably preferred an RFA, but because we got a very good angle here, your laser fiber is coming perpendicular to the vessels. Remember, 70% of your trap fetuses will have only one umbilical artery. So you get the artery and the vein very close to each other. And then you shoot laser, couple of cycles of laser, and this vessel is completely occluded. And you can see at the end of the procedure, this fetus has become completely avascular. This was the same case at birth. This is a normal twin. This is a cardiac twin. This is, in fact, 1/10 of what it was before we did the procedure. This was, in fact, the largest acardiac twin that we had come across. This was a baby, the survivor at 1 year, and this is a baby at 4 years follow-up. Now, the fourth condition that you can really offer treatment is lower urinary tract obstruction, or bladder outlet obstructions, as we call it. Now, the problem here is if there's an obstruction to the bladder outlet, you could have the bladder being over-distended with urine. That could affect the bladder compliance postnatally. The bladder resistance could go up. The bladder walls could be hypertrophied and trabeculated. You could also have the urine refluxing back into the kidneys and causing damage to the function of the kidney. So it is not just that, you could also have problems because of the anhydramnios. If there's a severe bladder obstruction, urine does not come out into the amniotic fluid. So you have severe oligo, if not anhydramnios, and this can result in severe pulmonary hyperplasia because you need the lungs to breathe out and breathe in fluid if they have to be ready to take in air at birth. So severe anhydramnios, severe oligo or anhydramnios can cause hyperplasia of the lungs, and that again is not something that you could tolerate till the baby is born. So therefore, it makes sense to go in and relieve this obstruction either by doing cystoscopic ablation with a fetal cystoscopic procedure where you create a small hole in the posterior urethral valve under cystoscopic guidance with laser. Now, this is the other option, is to do a vesico-amniotic shunting. The former, of course, is considered to be more physiological because it gives you the natural route of urine intake. The bladder function is much better. And this helps both the kidneys as well as the lungs. Whereas a vesico-amniotic shunt is not thought to help the lungs, is not thought to help the kidneys much because it does not really decompress the KUV system because the pressures get equalized on both sides pretty soon. But of course, this can save the lungs. So this is generally done a little later in gestation where you just need to buy some time for lung maturity and for prematurity to be avoided. Whereas if you're going in pretty early, this is rather a period of the treatment of choice because you create a natural voiding process for the fetus, which is always better than putting in a shunt. Here's a case, you could see that there's a classical keyhole sign suggestive of a posterior urethral valve. And you could see that the kidneys, this was a case on follow-up, the kidneys were just beginning to look a little echogenic, a little less comfortable than what you would want to see with. So we decided to go in after testing for the urine samples and finding out that the kidneys were not doing too bad. What we did is a cystoscopic fulguration. You could see that the local anesthetic is being injected. You're creating a small nick, and you have a very small 1 mm or 1.3 mm curved scope that goes into the bladder. This is a diagnostic cystoscopy being performed first. You identify the cause because some of these cases you could get caught with a urethral atresia where there's nothing that you can do to relieve the obstruction. So you make sure that this is a PUV by looking at the urethra, the posterior urethra. You find a very pale membrane-like posterior urethral valve. You thread your laser through the fetoscope, create a small hole there, and you can see bubbles coming out, and then the entire assembly is taken out together. 3 days later, this is what happened. There was absolutely no LICA before the procedure, but now you see normal LICA in the sac, and the bladder is completely collapsed. And you could see how thick the bladder was because of all the obstruction that it was pressing against. This is a baby at 6 months. This baby is now 1.5 years of age. Then comes diaphragmatic hernia. Here again, there is a double hit mechanism because of the severe compression to the lungs. There could be lung hypoplasia, and these compressed lungs serve as substrate for developing pulmonary hypertension later in age. And therefore, for the extremely severe cases where the outcomes are not too promising, it makes sense to actually try and go in and relieve the compression by blocking the trachea. Now, the principle here is to induce a high airway obstruction. You apply a balloon to the trachea so that whatever fluid that is formed in the lungs collects within the lungs itself. It does not come out. So you are inducing a hyperinflated lungs, or you're creating a hyperinflated lungs, which is believed to actually push out some of the contents of the hernia back into the abdomen. So this is the balloon that is used, and I can show you how small the balloon looks, but this is a really powerful tool in babies with severe diaphragmatic hernia. So this is a balloon that is inserted into the trachea of the fetus. Now, this is one of the cases that we attempted recently. We did everything right, but just could not deploy the balloon in the end because of a malfunction with the equipment, with the fetoscope. We could not just deploy it beyond the small kink that was there in the fetoscope. So you could see that the scope is going into the trachea. You can identify that with the carina there, the bifurcation there. And then this part of the video is from the internet, where you can actually see the deployment of the balloon. Now, the total trial laid to rest a lot of speculation and complications that were there, or confusions that were there about the deployment of the balloon. The total trial very categorically said that in cases with severe diaphragmatic hernia, wherein the lung head ratio, the observed to expected lung head ratio is less than 25% of normal, or less than 25%, there is a definite survival advantage, and the benefits clearly outweigh the risks. But it is not the case when the O/LHR is in the moderate group, does not really offer a significant survival advantage. So when you compare the benefits versus risks, it is just so-so. Whereas in severe CDH, there is a very clear case to actually go in. The next condition would be the exit procedures that we do. Now, exit essentially refers to ex utero intrapartum treatment. If you think that this baby is not going to be able to breathe if it comes out of the maternal circulation circuit, then you do not get the baby out entirely. You get the head out of the baby, or the head out of the placenta of the uterus. You make sure that the baby is going to be able to breathe either by putting in an airway, or by putting in a tracheostomy, or by doing a resection of whatever is obstructing the airways. And then only after that is done, you disconnect the baby from the placental circuit, so the baby does not die of hypoxia at any cost. Now, this is a huge affair. You need a lot of specialists being participated. The operating room is always going to be crowded. You can see us, the fetal medicine team. You can see the pediatric surgeons here, the neonatologist standing by, the anesthetic team, the ENT surgeon. So this requires a lot of expertise. You need a scrub nurse. So this is a team that goes into performing an exit procedure. Here is a case for demonstration's sake. This was a case that we had the 18 weeks and 4 days with severe high airway obstruction. Now, this is what you induce in diaphragmatic hernia as part of treatment, but this is not a diaphragmatic hernia case. This is a case of high airway obstruction because of laryngeal atresia. And this baby, once it comes out, is not going to be able to breathe because the trachea is completely, or the larynx is completely stenosed or atretic. You could see that fluid is there till this point, but this is where we presume the obstruction was. So this baby was delivered by an exit procedure. You can see that the head of the baby is brought out. The placenta is still giving it enough oxygen as was required. The neonatologist attempts to put in the endotracheal tube, but it does not go in because of the obstruction. So immediately a decision is taken that, okay, this is not going to work. So the next step is to resort to a tracheostomy. So that the neonatology team moves out, the pediatric surgery team steps in, and they're doing a tracheostomy there right in place. And you can see that the tracheostomy is being done, and the tracheostomy tube is secured, connected to the airway. You make sure that the breathing is in place, secure the tracheostomy, and only after this is done, the baby is taken out of the placental circuit and back there. You can see the cord is being cut only after the airway has been secured. So this is the exit procedure in brief. This is the same fetus postnatally. You can see a CT image here. The tracheostomy has gone distal to the obstruction. This is the atretic segment of the larynx. Same picture on a coronal section. You can see that the tracheostomy is in place. And this procedure was life-saving for this fetus. The baby is now 1.5 to 2 years old and is awaiting primary repair once the baby is around 3 or 4 years of age. The next indication would be severe cardiac valvular stenosis, for example, aortic stenosis or pulmonary stenosis. We know as far as the heart is concerned, if there is no blood flow into a chamber or a vessel, that vessel or chamber is going to shrink in size and you cannot bring it back. So if you identify a case right in time, this is a 29-week, slightly late for an intervention, but because the doctor, it was a doctor couple and they agreed for the intervention, you could see this is a 4-chamber heart with inflow only into one side of the heart. This side of the heart, there's hardly any blood flowing. So this is kind of a hyperplastic left heart syndrome because of severe aortic stenosis. So the idea here is to put in a needle through which you could stent this aortic valve here with a balloon, and that could induce blood flow through the aorta. So here again, this is a huge team effort with the fetal medicine and the pediatric cardiology team getting involved. This is similar to the balloon that we used for the Feto procedure. This is the cardiac valvuloplasty balloons that they use, and this before the procedure, and this is after the procedure. You could see that the biventricular circulation has been restored because of the relief of the aortic obstruction. Now, this is not a standalone procedure. This baby, of course, would need major surgeries after birth, sometimes even a major procedure like a Roscoe surgery where you're required to shave off all the fibroelastosis that happens to the left ventricle. So anyway, this baby survived, and if you offer good postnatal therapy, this baby could actually do well. You could also have treatments being offered for severe or highly vascular tumors, because these vascular tumors could steal blood from the baby. That could lead to severe fetal anemia and again high drops. The other thing that this could do is, for example, if you have a large bronchopulmonary sequestration, it could also cause severe compression to the lungs and the heart. As we saw in the case of severe pleural effusion, this could also cause high drops and cardiac failure. So this is one of the cases we had. This was what we call as a hybrid lesion of the lung. This was a bronchopulmonary sequestration with features of cystic malformation as well. This baby had high drops by the time it presented to us, and you could identify a single large feeder coming from the descending aorta. So what we did was to occlude this feeder artery from the aorta by laser. You could see that the laser is being applied to the feeder from the aorta. So that shrunk the mass significantly, and you could see that in 1 week's time that the high drops has completely disappeared. And you could see this is the aorta. This was a feeder that was going from here that has been completely occluded. This, of course, was a case that we published recently. Now then comes amniotic bands. What amniotic bands can do is they're essentially formed by disruption of the amnion. These are very sticky bands that can stick to different fetal parts and can cause vascular disruptions, amputations, and so on and so forth. So if you identify these amniotic bands in time before they've caused vascular disruption, you could probably go in with a fetoscope and then sever these bands so that it does not encircle fetal parts and cause auto amputation or vascular amputation. So this is again not a very clear video. You can see that the amniotic band is stuck to the fetal finger there. We're trying to sever it with the laser fiber in place. Last but not the least, there is also this option of open fetal surgery for very select cases. For example, a large sacrococcygeal tumor that was bleeding the fetus, a large type 3 CPAM causing severe cardiac compression and high drops, or maybe large meningomyelocele, particularly when you have lesions that are open. So this is an example of a large sacrococcygeal teratoma that was subject to fetal therapy. This, of course, is not our video. This is borrowed with permission from Cincinnati. You can see that there is an incision that is placed on the uterus. So you expose that part of the fetus that needs to be operated. You put in staplers to prevent leakage of amniotic fluid. You take out the part of the baby with the problem. You operate, you suture, and then put the fetus back and then close the uterus. And this baby, of course, would be required to be delivered by a cesarean section somewhere around 6 to 8 weeks later. So that is open fetal surgery. Very, very rarely performed these days because of the advent of minimally invasive surgery. But of course, in select cases, this might still be the only option available. So what we've seen so far is that there is a treatment for every complication that you can think of, for most complications that you can think of. But what is most important to understand is that the appropriate treatment is not always an intervention, because we know that interventions is not without risks, and therefore watchful expectancy and master lean activity could be the best option in a lot of these situations. As we said, fetal surgery is not without limitations. There are lots of complications associated, particularly what we have still not been able to address appropriately is the risk of preterm labor or PPROM, the rupture of membranes part of it. We still haven't found solutions good enough. There is also reluctance from the part of the patients, practitioners, as far as our population is concerned. We do not have randomized trials because you certainly cannot have randomized trials when it comes to situations like these. So we do not know about these long-term outcomes. The classical example would be with a cystoscopic fulguration that you do for PUVs. You really do not know what can happen to these babies 5 years, 10 years down the line. Now, with open fetal surgery, there's also an added morbidity of to the mother, which could be at times significant in nature. Even though there are studies, there is data from the MOMS trial that said maternal morbidity is not as high as we thought it could be. The other problem that you heard Professor John alluding to is that there's no centralization of care. Everybody, as he said, wants to put in a needle. So you would have fetoscopy centers starting up within 2 kilometers, 3 kilometers radius of each other. So which is not the right way to go about because nobody gets enough expertise in that case. Again, in our country, unavailability of services is a major problem. You might have very select centers offering extensive fetal therapeutic options. And as bad as the problem with over-enthusiastic people, as you heard Professor John said, even when they're not very sure of how to do good scans, they really want to start out doing CVSs and amnios, which is not the right way to do it, as he very carefully, very rightfully pointed out. And again, fetal surgery is not without complications. As I said, you could have risks of miscarriage, preterm labor, PPROM, chorioamnionitis, and so on and so forth. And of course, the problems with open surgery are still more complicated. So the bottom line is it is not about knowing how to operate. It is more important to know when not to operate. As I said, a lot of these conditions could take care of themselves. You might actually end up doing more harm with a fetal intervention than good. So you remember the first principle, of course, is always primal non nocere, which means first do no harm. So be very careful with your case selection. Make sure they've been done by the right people at the right centers with expertise for fetal surgery and all the associated specialists available in place, so that you do not harm the fetus, if not you do, even if you don't do too much of good. Thank you very much for your patient listening.
Thank you so much, sir, for such an extensive coverage of the variety of the fetal interventions that are available, starting from the shunting to ablations to dilation and of course feto and exit. But as you rightly pointed out, the limitations of the availability, lack of centralization, long-term outcomes, and the associated complications. So with this, I would like to take the question and answer session. The first question is, how frequently do we need to repeat the ICT titers with the MCA PSV monitoring? Dr. John, sir, will you please take this question?
Yeah, hi, look, some people, and there's an eminent character in India who I've met who thinks that, you know, basically once you've got to a certain level, you have to understand what levels are likely to cause hemolysis. So Cal, it's low, anti-D, you can choose what you like, but we use a D-quant and we use 15, it works quite well. Whereas a titer of 32, I think is too low, but you know, with experience, you can sort that out. I personally do like titers. I have found that in cases that I've been watching who had risk, that I use, you know, and I use the middle cerebral, that titers, and especially if they're done properly, you can't have them done by various labs. You have to be done by your lab, and the people involved know why you're doing it. And we use a 2-tube jump to say which is significant. And I have found that in general, you'll get a movement in your anti-D 2 to 3 weeks before you'll have see anemia. And so I find it's quite good to alert people. But would I rely on it alone? No, not a chance. You've got to look at the whole history and etc. But I do find it useful, and it's a bit like the more irons I've got in the fire, the more variable ways of watching something. I find different ones work better in some cases. But very high values sometimes will not move, and your baby can be anemic. And I think that's the danger for the inexperienced person saying, "Oh, I was watching, and it didn't move," and the baby, you know, got hydropic. So it's just another tool, and the more you use and the more you appreciate, it's a bit like I was showing you how we seem to go around in circles some way, was plasmapheresis coming back, IPTs coming back, whereas before it was done out of necessity.
Thank you so much, sir. Very well explained, sir. Next question. Any role of fetal interventions in megacystis? Dr. Vivek, sir, would you like to take this question?
Right. I presume that the question is about first trimester megacystis. Now, megacystis in the first trimester could be obstructive, or it could be because of aneuploidies like trisomy 18. So the first step would be to rule out a chromosomal problem in such fetuses. You watch these babies till they reach around 18-20 weeks. If you're sure that it is a bladder outlet obstruction, of course, you need to look at all the other parameters, the light around the baby, the appearance of the kidneys, are they becoming echogenic? And you would probably also want to do a vesicocentesis and sample the urine and find out if the kidney function is still okay before you decide to go in and do a procedure in such cases. So a lot of these megacystis in the first trimester may not be posterior urethral valves, they could still be urethral atresias, and some of them could be linked to chromosomal abnormalities, particularly if the dilatation is less than 15, it is more likely to be related to chromosomal abnormalities than when it goes above 15, in which case the cause is likely to be an obstructive. So you need to discern what the cause exactly is, and then wait till around the baby gets to 18-20 weeks before you decide on further management for such cases.
True, sir. Thank you so much, sir.
Thank you, Tahsil. I know there are lots of questions in the chat box, but the next speakers are waiting, Tahsil. So I know there are lots of questions to be answered, but let us take during the lunchtime and get back to them.
Sure, madam.
Thank you, Vivek, and thank you, John, for such a wonderful talk. And we are having lots of comments in the chat box. So let us welcome Suresh sir again for his most interesting session, which we ponder on every day on ventricles. So Tahsil, you can introduce Suresh sir and then take the session.
Thank you so much, Vivek sir. Thank you so much, John sir. I invite again our eminent fetal medicine specialist, Dr. Suresh sir. So the 10 millimeter diameter cutoff is very established, but sir will throw more light on the relevance of borderline ventriculomegaly. Suresh sir, over to you, sir. Sir, you're muted, sir.
Are you able to see my slide now?
Yes, sir, we are able to see your slide, sir.
Okay. Okay, good afternoon. We will quickly go as we are running.
Good afternoon, sir.
Yeah. We'll quickly run to the topic straight away, which is borderline fetal ventriculomegaly. This is a problem which we face very, very frequently. As we know that the fetal lateral ventricles, which can be seen quite early from 11 to 14 weeks onwards, but it's little later during the targeted scan when we actually start measuring the ventricles. And then, of course, as it grows, as the baby grows bigger, the ventricles are slightly smaller in size, but most of the time it should be not more than 10 millimeters, which is that we have gestation age-specific measurement for the lateral ventricles, but overall it has been said 10 millimeters is almost like 3 to 4 times the normal, and hence it's always abnormal. Now, this is at 12 weeks, this is at 20 weeks, and it's at 30 weeks, which we can see. Now, the most important thing about the ventriculomegaly is to assess the ventricles or the ventricular size, for which we need to have precise anatomical landmarks to do. So once you see the far side ventricle is always better seen than the near side ventricle. And when you see the occipital horn, the glomus of the choroid plexus is one of the landmarks we need to look at. And right at that point, of course, at the level of the, this is the atrium of the lateral ventricle, the glomus almost fills the entire cavity. The atrium is visible from 14 weeks till term. The measurement here is probably very important because wrong measurements can lead to false diagnosis. At the level of the parieto-occipital fissure, at this point. You draw, you measure from inner to inner, which is perpendicular to the ventricular wall. And when there's severe ventriculomegaly, of course, there is no doubt. You can make a measurement, but it is obvious that there's ventriculomegaly. But then the other aspect which we need to look at is sometimes the ventricle looks dilated, but if you actually measure, it is not. It's not more than 10 millimeters. At that point, when you look at the choroid plexus and the separation of the medial wall to the choroid plexus, normally is less than 3 to 4 millimeters. If it's more than that, then that raises a suspicion. And the choroidal angle, which is also being shown should be 16 to 22 degrees, is not something which we routinely measure. But obviously, when there is a big dilatation, the choroid would be damaged. But there are some pitfalls in the diagnosis where you can see a hypoechoic brain, especially in the second trimester, which can be mistaken. Or there's a very, very large choroid plexus cyst, which looks like a dilated ventricle. Now, once you have a dilated ventricle, we can classify the ventriculomegaly depending on the size. It is called mild when it's 10 to 12 millimeters, moderate when it's 12.1 to 15 millimeters, and severe when it is more than 15 millimeters. Whatever be the grade, a detailed search for associated CNS and non-CNS malformations is mandatory, because other malformations can be present as almost 50%, aneuploidy in about 3 to 15%, and infections in mild to moderate cases in about 1 to 5%. So this becomes absolutely mandatory to rule out infection and aneuploidy. But what we need to do is the natural history. The natural history of mild ventriculomegaly, let's say 10 millimeters, 11 millimeters, it may progress further, it may regress or remain static. And our entire challenge in prognosticating depends on whether it's progressing, regressing, and remain static. Needless to say, ventricles which are regressing in size or remaining static have a favorable prognosis, whereas those which may progress, the prognosis may be variable. So let me show you a few case studies, and then we'll come back and try to analyze what we done. Here's a primary natural conception target scan at 20 weeks. It was about, the lateral ventricle was about 9.5. It was initially measured at 8.8, and obviously this was not measured at the level of the glomus. So a correct measurement gives you a 9.5. Even though it is less than 10, you can see the medial wall separation. Separation of the medial wall from the choroid plexus is quite significant. So it could still be classified as, we would try to take notice, even though we may not raise an alarm. We will do an extended neurosonography, which was normal. There was no other anomaly present. So we've said no investigations now, follow-up scan in 2 weeks. The patient came back in 2 weeks' time at 22 weeks. It progressed to about 10.9 or 11 millimeters. So obviously there's been a progression at this point. So at this point, we will definitely call it as minimal ventriculomegaly. The plan, of course, is to do an infection screen, exclude aneuploidy and other anomalies. Now, the whole question is, could we have done the whole thing 2 weeks earlier? Yes, it is possible a decision could be taken to make do an aggressive investigation when it looks abnormal and it's borderline, but that's a matter of choice for each center. But then the patient, the investigations where rubella IgG was positive and IgM was negative, and both CMV and rubella IgG was positive but high avidity. And amnio was done, a PCR was normal, and then the patient was reassured. A repeat scan was done 2 weeks' time. And finally, when the patient came at 35 weeks, the normal lateral ventricle, baby delivered at term, normal milestones at 1 year. So here is one which did not progress, and in fact regressed a little bit later. So this was a case which remained static from 19 weeks to 24 weeks. It remained static, but we definitely need to do a third trimester scan because progression can happen at any time. Ultimately, this turned out to be good. But let us look at case 3, which is that the lateral ventricle at 23 weeks was 11 millimeters. So what would be the plan of action? When we did the investigations of aneuploidy screening and also infection screening at 25 millimeters, there was progression from 11 to 14, and this is worrisome because even though this still falls under the category of minimal ventriculomegaly, a progression from 11 to 14 millimeters tells us that there's a possibility of further progression in this case. And this is another case where there is bilateral minimal ventriculomegaly, but the baby also had early onset growth restriction. So once you see an associated problem, then we need to very aggressively investigate, make sure we probably need a microarray to know whether there are additional problems which are there. But the other thing we need to do when we see minimal ventriculomegaly is to look for possible calcifications, especially periventricular calcification. So she was a 27-year-old preemie, maternal toxo, rubella, CMV, all of them were positive. And that's interesting because all IgMs are positive here, and the patient was actually treated with pyramycin. And but the etiology is questionable, whether the food infection is questionable, where we can do an amnio for identifying the PCR for the viral DNA, but the PCR for viral DNA was negative in this case. And to say that all infections are positive at the same time says that this is something which a little bit hard to take. So the perinatal pathology report finally came down as pseudotox syndrome. So you can have mild ventriculomegaly calcification. It could point towards infection, but ultimately we also have to mind because the importance of pseudotox syndrome is that this is an autosomal recessive condition and it may recur in the next pregnancy. But on the other hand, here's another minimal ventriculomegaly with periventricular calcification. You can see thick ventricular walls. And there was also skin edema. And the neonatal evaluation also showed ventriculomegaly with periventricular calcifications, and CMV infection was proved. In the last case, at 31 weeks, you can see ventriculomegaly, but there are also irregular borders of the ventricle showing that there are multiple periventricular nodules that protrude into the ventricular lumen, and this is called as nodular heterotropia. We have to look for associated agents of corpus callosum and mesencephaly. So the big challenge now is how do you counsel? And I think this article actually puts everything in perspective. So I've given you some extracts from this. We need to ask a series of questions and answer those questions in patients who are coming for isolated ventriculomegaly. First question is, should IMVM be sent to a referral center? So you have seen ventriculomegaly of 11 millimeters or 12 millimeters. Remember, the word isolated is the key word here. And isolated minimal ventriculomegaly is a process of exclusion, which means a thorough search for all other anomalies have to be made, and hence a referral to a higher center may be warranted. Should a TV scan be done to evaluate the brain? So because definitely transvaginal ultrasound gives you a much higher resolution and you'll be able to pick up anatomy much better. But most of the time depends on where the fetal head is, whether it's accessible to the transvaginal probe. So a detailed evaluation of CNS on transabdominal scans. Today we have a higher frequency probe like 2 to 9 megahertz probe which can be used. And wherever there is an opportunity, a transvaginal ultrasound should be performed if it is technically feasible because it can provide additional information. And is an MRI essential? A good ultrasound provides actually excellent information, especially when you do high resolution ultrasound. But MRI may provide an additional information in about 6 to 10% of cases. But most important is MRI can be done only when there is good expertise and the timing of the MRI, because if you are diagnosing at 20 weeks and MRI may not be appropriate at that time, maybe we need to do it a little later. What has been shown is the timing of the MRI is not very clear as per literature, but approximately 30 to 32 weeks may be appropriate. With maybe higher technologies, this gestational age might be brought down. Now, associated anomalies in our own series, here you can say 24% associated with other multi-system, 18% of other with other CNS anomalies, and associated with other single system anomalies in a series of around 70 cases. So this shows that any other system may be involved and a thorough search must be made for all the other anomalies. Now the question is when to do serial scans in IMVF. The risk of progression is about 15%, evolving anomalies in 13%, and depending on the gestational diagnosis, another scan between 28 to 34 weeks may be appropriate, and at that time you can decide whether an associated another MRI will also be required. Now, in our own series, when we followed up cases of around 69 cases, it was reduced in about 28%, increased in about 9%. So, in mild ventriculomegaly, a quarter of them may actually reduce as it goes along. Now, should infection screen be done for all IMVF? Because once you have infection, there is a guarded prognosis for the affected children. Considering the fact that the infection screen does not cost a lot, it could be worthwhile when you see ventriculomegaly to do a TOT screen. Maternal CMV and toxoplasma studies and should be considered in all cases of IMVF. But should a prenatal karyotyping be offered, the rate of chromosomal anomalies in IMVF is about 2.8%. So karyotyping is offered even in the first trimester screening is low risk, because this is often a question which is asked that FTS has come as 1 in 2,000, but there is ventriculomegaly. Should I do? Because when you did the FTS, the presence of the the ventriculomegaly was not considered, and you can call a ventriculomegaly as isolated only when you rule out chromosomal abnormality. So it makes sense to do a karyotype. Now, what is the risk that a mild ventriculomegaly is not truly isolated? Very good question, because there are limitations of ultrasound in detecting occult malformations. It has been shown 13% of anomalies may evolve or may be missed on the ultrasound. And that's one of the reasons why sometimes an MRI can pick up some of the anomalies which ultrasound is not able to provide. Now, what is the neurological outcome of children with prenatal diagnosis of mild ventriculomegaly? The neurodevelopmental delay seen in about 11% of the cases, but there's a wide variation reported in the degrees of neurodevelopmental delay. But with many of the studies have not used objective assessment. So the assessment also has varied. So it's extremely difficult now to provide a sort of a figure, but maybe around 10% is what we could do. 10% seems to be quite a large number. But here is a study which showed about 81 cases where the ventriculomegaly was between 10 and 15 millimeters, out of which 62 cases was between 10 and 12 millimeters. Out of the 62 cases, one was a trisomy 21, one was a corpuscular agenesis. So we had 60 cases between 10 to 12 euploid, no associated anomaly in the first scan. When they went on, there was a reduction of the atrial width in 18 cases, 9 of them normalized, and it was stable in 42 cases. So in all the 60 cases between 10 to 12 millimeters, either it reduced or it was stable. And when the postnatal follow-up, a retrospective follow-up for 38 children, abnormal development was not seen in any of them, and prospective follow-up for 18 months in 22 children, none of them were abnormal. So this shows that if it is between 10 to 12 millimeters, the chances that this baby, if you rule out all other anomalies, the chances that the outcome will be good are very, very high. And here's our own series of 113 cases, out of which 84 were isolated cases. In utero progression of LV diameter was seen in stable in 64, progression in 10%, and regression in 26%. And our neurodevelopmental outcome on our follow-up was normal outcome was seen in unilateral cases, all the 28, and in about 32 cases of bilateral ventriculomegaly, which is about 89%. So again, we have reproduced what the literature has said, that when there's mild ventriculomegaly which is non-progressive, the outcome is said to be very favorable. So we can give some reassurance for sizes between 10 to 12 millimeters and 12.1 to 15 millimeters, more investigations. And maybe we need to be more cautious and look for progression. So I'll conclude by saying isolated minimal ventriculomegaly, non-progressive variety has a favorable prognosis in most cases. Decision on the diagnosis of isolated must be made after excluding aneuploidy, infection, and other anomalies. MRI may provide additional information about 6 to 10%, but timing and expertise is important. Thank you very much for the patience.
Thank you so much, sir, for such useful information and relevant points regarding the association of infections and aneuploidies and the role of screening and direct testing, and of course the neurodevelopmental outcomes in cases of isolated mild ventriculomegaly. Moving on to, we would like to have you back, sir, for the question and answer session. Thank you so much, sir. Now I would like to introduce our next eminent speaker, Dr. Sujata ma'am. May I have a CV, please? Dr. Sujata ma'am is the head of the Department of Clinical Genetics at Mediscan Systems. She is a clinical consultant associated with PerkinElmer as well. She is a co-investigator of the ICMR project on NBS and had been the past president of Genetics Chapter of IAP. And she's recently inaugurated One-Stop Care for the Rare, that's a care center for excellence at VHS. Also an eminent teacher and guest speaker at various national and international conferences. So we have covered the aspects of anatomical evaluation of the fetus, the placenta, the various fetal interventions associated. Another important aspect to be considered in any structural anatomical abnormality is the genetical association. So to throw light on that, we have got Dr. Sujata Jagdish with us. Over to you, madam.
Sure. A very good afternoon to all of you, and thanks for the nice introduction, and thanks Dr. Vidya for this nice opportunity and a well-planned conference. Is my slide visible?
Yes, ma'am. The slides are visible.
So let us move on to the topic straight away. So what is the purpose of fetal testing? So before planning testing, we should understand what is the purpose of testing. The first and foremost reason is to ensure normalcy of the fetus. And if there is any structural abnormality, to identify if there is any etiological factors, and to give a prognostic information, and also to make decisions in pregnancy, as well as offering reproductive choices in the future pregnancy. For all this, we need genetic testing. And certain questions need to be answered. First of all, is it required? And will it give clarity more than what we have seen in ultrasound? And after doing this test, will further tests be needed? And is it pocket friendly? Because in our country where there is no insurance and patients have to spend from their pocket. So we need to consider all these factors. And who are all the stakeholders in decision making? Primarily the patient, and then the family, of course, here, and the obstetrician, the fetal medicine specialist, and the geneticist. So all should have the idea in sync, and they should all discuss and then come to a conclusion before doing a fetal testing. And what is the process? We have to understand the problem. There has to be an effective communication between all the stakeholders, and a plan of testing strategy has to be made. Sufficient time has to be given for planning the testing and for the family to make a decision. And it is executed with minimal possible risks. And an accurate result interpretation is very, very crucial. And what are the general indications for prenatal testing? When a woman comes with a positive screening test, or when there is an ongoing pregnancy with an abnormality, either it can be a late pregnancy or an early pregnancy, and there can be a previous child with a genetic disease, or there can be a family history of a genetic problem. So in the last two scenarios, we start working in the pre-pregnancy period, which is the most ideal time. And when you look at the genome, so there are different tests based on what you want to see. So karyotype will look at 100 million base pairs, whereas chromosomal microarray will look at 3 million base pairs. And next generation sequencing will require look at 3,000 base pairs, whereas your Sanger sequencing or MLPA will look at only one base. So the testing planning will depend on what you want to look at. And based on that, we have to order for higher test, the nature of test. And what are the techniques available for identifying of chromosomal problems? There is karyotype with high resolution banding. And for molecular cytogenetics, we have FISH, we have prenatal bobs, we have karyolate bobs or microarray. And for single gene disorders, we have molecular sequencing techniques, Sanger for a single gene. And then for multiple genes, there are disease-specific panels, clinical exome, whole genome, and mitochondrial genome sequencing. So these are the various test options that are available. So genetic counseling is a very, very important step in prenatal procedure decision making, because we need to decide about the choice of procedure, the methodology, when are we going to do, what is the cost, and what is the turnaround time. So apart from this, we also need to answer certain questions like reliability and need for repeat testing, possibility of ambiguous results, need for further testing, and what is the plan after the results. So all these questions have to be discussed in depth before even planning a fetal testing. So now I will take you through few case scenarios so that it is easy for a beginner to understand how to plan a genetic testing in a fetal medicine setup. So I will first go through ongoing pregnancy situations. So the most common indication is a positive screening test. So if a patient is screened positive, definitely a definitive testing is needed. So choice of testing will depend upon the gestational age and patient preference. And between CVS and amnio, both are technically the same in trained hands and loss rates are the same. But confined placental mosaicism is a problem in CVS and culture failure is a problem in both. So how do we go about? We first do a rapid aneuploidy screening, either FISH for 21 alone or unused screen or prenatal bobs or Cure PCR, which is also another cheap modality of quick screening, followed by karyotype is usually done. So why do we go for these quick methods? Is early results and to circumvent problems of culture failure. So suppose we do only karyotype and the culture fails, then we don't have any answer to give to the patient. So aneuploidy screening, rapid tests for quick results, because in 3-4 days we can give an answer to the couple. And karyotype usually takes about 2 weeks, but then this is a confirmation test. And for intermediate risk, the result is explained and options are given to the patient. They can either take a non-invasive prenatal testing or go for direct testing or opt out of testing. And this is entirely the patient's decision. And if you want to do a testing, sample choice and test ordered are the same like a screen positive patient. Suppose a patient is screen positive and presents herself only beyond 24 weeks. The only option is direct testing. But if the results are negative, we may reassure her. But if positive, we may not be able to act upon the result. So here the choice of test will be amnio or fetal blood sampling. And test ordered again will be rapid aneuploid screening followed by karyotype. If patient presents with 11 to 12 weeks with increased nuchal translucency, so this is a very, very common scenario. And for example, in this case, she was a primee and pedigree, 3-generation pedigree is usually taken as a part of history taking. Here, there was no additional inputs. There was no other structural abnormality. So the choice of procedure will be CVS or amnio depending upon the gestational age. And test ordered will be rapid aneuploidy test and karyotype or DNA store and maternal contamination studies for microarray. And if microarray becomes negative, then we have to go for whole exome sequencing or clinical exome sequencing. Again, cost considerations have to be kept in mind. So if rapid tests are abnormal, we confirm the karyotype and there the testing process ends. If rapid tests are normal, then we can straight away proceed with microarray. And if microarray is negative, we can proceed with next generation sequencing. So these are all the test options that are available. And some centers prefer to do microarray as the first step. It can be done, but then if it is just a Down syndrome or Turner, we make the patient spend unnecessarily for microarray because that is a costlier test. And to detect Downs, there are simpler and cheaper tests. So rapid aneuploidy screening followed by microarray will be a good choice of testing plan. So this is that fetus who had that increased NP, and we found that the chromosome 1 had a very big deletion. And we also looked at number of genes that are involved in the deletion, and also the qualification of the CNV, whether it is pathogenic or whether it is benign or what. We have to look at all these pointers before coming to a conclusion. And especially fetus presenting with multiple structural abnormalities, microarray throws a lot of value. So in anomaly of in an ongoing pregnancy, I am just showing two scenarios. Here you see a fetus with fetal acrania. And we all know it is multifactorial, so there is no need for any genetic testing, and the recurrence is 3 to 5%. Whereas here, if you see, there is a fetus with sepocephaly, a proboscis, and a holoprosencephaly. Here we have to definitely do a definitive testing. We can do a KT and then store DNA. If karyotype is abnormal, no further testing is required. But if karyotype is normal, we need to examine parents for autosomal dominant inheritance or proceed with the sequence of testing. And here another common anomaly is the conotruncal anomaly, which we commonly see among the cardiac anomalies. Here again, testing is definitely required. We need to rule out 22q microdeletion. Here in this lower segment, you see, this is a normal fish. You have 2 green and 2 red signals. Whereas here you have 2 green, but only 1 red signal, which indicates that there is a 22q microdeletion. And if 22q microdeletion is normal, then we proceed with microarray. So how to detect microdeletions? To just see for one microdeletion, we use fish probes. But if there are some few common microdeletions you want to see, you can use prenatal box. Or you want to see any microdeletion across the genome, we use microarray. So these are all the techniques to detect microdeletions. And if a child or a fetus with microdeletion is seen, we need to check the parents. If parents are normal, the recurrence is less than 1%. But if parent is a carrier, they can be symptomatic or asymptomatic, and recurrence is up to 50%. And the situations where microarray is recommended, again, just a summing up, increased NP with hydrops after ruling out karyotypic problems, multisystem anomalies, CNS anomalies, especially posterior fossa, agenesis of corpus callosum, unexplained IUGR, cardiac anomalies, except cardiomyopathies, we use microarray because there is a 6 to 7% overall increased yield and karyotyping in structural abnormalities. But in our setting, as the patient has to pay and aneuploidies are more common, still we consider microarray as the second tier after QFPCR in regular patients. So the microdeletion report will come as pathogenic, likely pathogenic, uncertain significance, likely benign or benign. So these are the ways it is reported. We can take into cognizance if it is reported as pathogenic and likely pathogenic, but the remaining have no significance to the patient's condition. And now moving on to single gene disorders, there can be point mutations or deletions. So if there are point mutations, then the test of choice will be a Sanger sequencing for sequencing one gene, or for multiple genes, it will be an extension sequencing. But for deletions, we use a technique called MLPA, or CNV detection analysis can be done. So a disorder may be caused by either point mutation or deletion. So 2-level testing may be required. So this is another anomaly. So common scenario, skeletal dysplasia. So there are 3 options fetal medicine specialists can choose. Option 1 is, because it's a lethal anomaly, terminate and do only autopsy. And if a single gene is suspected, do parental testing. Option 2 is store DNA, do an autopsy. And if single gene is suspected, next generation sequencing in the sample which is stored. And if positive, do a parental testing. And option 3, doing direct next generation sequencing from fetal sample. But by chance it is a thanatophoric dysplasia, which is a non-recurrent problem. Here testing becomes only an academic exercise. Here in our country, because of cost considerations, we have to choose an ideal option for maximum gains and minimal expenditure. So option 2 in this situation will be the best bet. And in skeletal dysplasias, there is no need for KT or microarray. So this is a fetus who presented microcephaly in the 3rd trimester, but unfortunately there was a previous child with microcephaly, and this child was not worked up, and there is no etiology identified. So we cannot help this pregnancy, and we have to allow the baby to be born and only examine postnatally and do some investigations. So here the fetus was diagnosed with rhabdomyoma, and we in this situation definitely examine the parents. And here the mother was examined and she was found to have classical adenoma sebaceum and hypoplastic hypopigmented macules, and the CT showed classical tubers. So we stored the fetal DNA and went ahead and did the tuberous sclerosis gene mutation sequencing for the mother and found the TSC2 gene mutation, and then we confirmed it in the fetal DNA which was stored. So examining the parents is also very, very essential. So when you see an anomaly in the USG, if you are suspecting chromosomal problems, there are different techniques like FISH, BOBS, qPCR for rapid aneuploidy detection, or you can go for CMA depending upon the situation. And if the rapid aneuploidy is negative, we can proceed with chromosomal microarray. But if you are suspecting a single gene disorder like osteogenesis imperfecta, like that, family mutation, if known, we can do a Sanger sequencing. And if there is no information about the family mutation, we have to go for broader based panels and depending upon the gene coverage. Store DNA, if you are not able to decide whether it is chromosomal or single gene. So in those situations where phenotypic characterization is not clear, please store the DNA, because after autopsy or postnatal examination, we can decide on the phenotype and then decide what we want to do, whether we want to do a microarray or a WS on the stored DNA. So if there is a recurrent anomaly and if it is single gene, if you know the genetic diagnosis, for example, if it is a Meckel-Gruber syndrome, it presents very early in pregnancy. So there is no need for genetic testing unless the parents want to go for a PGD or want to go for alternative reproductive options. But if ultrasound diagnosis is coming on late only, like osteogenesis imperfecta, then molecular testing becomes imperative in the 1st trimester of pregnancy. And if the diagnosis is unknown and there is no DNA from the affected child, we test the parents. If carriers, then we plan fetal invasive testing. If not a carrier, then expected management, and we have to see the baby postnatally and plan genetic testing. So now moving on to a few pre-pregnancy situations. Here, when the index child is available, this is a very, very ideal situation. There is a previous child with a problem, and the mother has come with the early ongoing pregnancy. We have enough time to test the baby. So when we, this is a child with the fractures, bowed limbs, and a ptosis and peg-like teeth, and not fitting into the classical osteogenesis imperfecta picture. But then when we did the sequencing, there was a mutation in the WNT1 gene, and usually in normal osteogenesis imperfecta, we get a mutation in the collagen gene. But here, this is a different type of osteogenesis. It is type 15 OI, and it is recessive. And the parents were found to be carriers, and then we did a prenatal, and unfortunately the fetus was affected. So here, when there is an index case, please work up the case and then test the parents and then do a prenatal diagnosis. So this will be a stepwise method, and we need enough time to do all this. And here you see case 2, a non-consanguineous couple delivered an alive female baby and had delayed milestones and regression, and the provisional diagnosis was infantile epileptic encephalopathy. But then we found that the child has a compound heterozygous mutation which causes pontocerebellar hypoplasia. But the MRI of this child doesn't have those phenotypic features, and it is a VUS. So though the parents had a segregation that both of them are carrying one mutation, because it's a VUS and phenotype is not matching, we cannot proceed with the prenatal testing in this pregnancy. So in index case, if there is suspected chromosomal problem, the step is to do a karyotype and then a microarray if needed. And in suspected single gene disorder, Sanger sequencing of or next generation based on the diagnosis. So this step is a must, maybe time consuming, but then we cannot escape this step. And if the index child is not available and only parents are available, there can be a situation like this. This is a 2nd degree consanguineous couple. First child ill from day 25, recurrent respiratory infection and died. And then was a blighted ovum. And then the 4th pregnancy, there was failure to thrive. and had some clay-colored stools. So we could not have a proper diagnosis. We had a differential diagnosis of could it be cystic fibrosis, could it be immunodeficiency. So we did the sequencing of the parents, and then we found that both of them are carriers of a cystic fibrosis mutation. So we could do a prenatal in the next pregnancy. See, sometimes surprises come. This is a family. The mother came with a balanced translocation carrier 14 and 18. But when you examine the child had some different features, and we suspected could it be Kabuki syndrome because the increased fetal finger pads and the phenotypic features. So when we did the sequencing, we found that the child carried a mutation in a X chromosome which caused Kabuki syndrome, and mother was a carrier for that too. So mother is a carrier, balanced carrier translocation for a chromosomal problem as well as for an X-linked gene problem. So there can be more than one problem in the family, and we have to have our eyes and ears opened wide to look at all the problems without missing anything. Now, value of stored DNA, this is a non-consanguineous couple. First pregnancy was terminated. We got a history that there was a hand and foot deformity, some irregular spine, but no autopsy and no pictures were available. Second pregnancy came with similar findings, but then the pregnancy was terminated, but DNA was stored and an autopsy was done. And then had features like this. And this is a very rare type of Robinow syndrome, and whole exome sequencing, we could pick up that there was a pathogenic homozygous mutation in the fetus and parents were carriers, and we could offer them prenatal diagnosis or other reproductive options in the subsequent pregnancy. If there is no index, there are no reports, there are no stored samples, testing parents may or may not help because there are different genetic mechanisms. It's not only the next generation sequencing or karyotyping. There are other mechanisms like imprinting, like triplet repeats. So we do not know. Just doing these tests may or may not help. And microarray will not show balanced rearrangement. So these are all factors we have to keep in mind. And when you do fetal sampling, maternal cell contamination is a must because the placenta has the fetal surface and the maternal surface, and we do not know where we are sampling. So if it is a maternal contamination is done, we will know whether it is a pure fetal sample or if there is a maternal mix-up. Because if there is a maternal mix-up, there will be challenges in the interpretation of the results. Now, going through a few pitfalls and challenges which we went through in our center, so that I thought I will share because nothing is foolproof. So this is case one, a consanguineous marriage. First child succumbed with a suspicion of propionic acidemia, and there was a child sample on the filter paper, and then an exome was done, and we got two mutations. One is homozygous likely pathogenic in the propionic acid gene, and the other was a homozygous variant of unknown significance in the propionic acid gene. So these genetic information are coming on only now. And really, we do not know whether this unknown significance causes disease or doesn't cause disease. And the parents were found to be heterozygous for both these mutations. So now when we test, we can get two types of results. If it is homozygous for the likely pathogenic, we can clearly say the baby is affected. But if it is homozygous for mutation B, we do not know whether the baby will be affected or it is just a VUS. And parents have to take a call. Usually after a test, there will be clear positive, negative, and easy decisions can be made. But in this situation, neither can we keep quiet without doing a test, and nor can we make a decision on the parents' behalf for this type of a result. But lucky for the parents, it was a twin pregnancy. On top of it, it was a twin pregnancy. So we had to test both the fetuses, and we found that the fetus A was like a parent, and fetus B was absolutely normal without any mutations. So the situation became easy, but then there could have been a challenge if the results were otherwise. This is a second case, third degree consanguineous couple, and there was the sibling of epiphysis, and this is again a twin pregnancy. The first one twin had a neonatal demise and given for autopsy, and the second baby was born and succumbed in 2 months. And the diagnosis was idiopathic arterial calcification. You can see the calcification across the aorta also here. So, but then the first lab had done a sequencing, a clinical exome sequencing, and they have reported a benign variant in the ENPP1 gene, which is responsible for idiopathic arterial calcification. Because it's a benign variant, we cannot attribute any significance. So again, we did the whole exome sequencing, and we found a very deep intronic mutation. but then this appears significant, but it has not been reported so far. So again, this is classified as VUS. So even though we have a clinical suspicion and a correlation, we need to do further RNA studies on this mutation to find out the significance. And PND, prenatal testing with the disclaimer that we will be seeing this mutation, but whether it will be affected or not is again a very big ethical question. This is case 3, a non-consanguineous couple delivered a female baby, mild delay in milestones, and the provisional diagnosis was developmental delay and seizure disorder. So this is what the original case which I showed you earlier also in my lecture. So there is a mutation which is a VUS. Parents are also segregating, but then there is no phenotype-genotype correlation. There is no pontocerebellar hypoplasia in this child. So we cannot offer a prenatal diagnosis in this family. So even after a diagnosis, sometimes we will not be able to predict the severity. This is a fetus with an increased nuclear translucency, and the QF-PCR was normal, and the CM genome showed a pathogenic gain, that is a 7q duplication. And then when we tested the parents, the father also had a 7q duplication, but on examination, he was asymptomatic. So these microdeletions can be autosomal dominant with 50%, up to 50% recurrence risk, but then there can be variable penetrance and variable expressivity. So even though you offer a test, you cannot say whether the next fetus will be like the father or will have autism, speech, motor delay, seizures. So all this also is reported in 7q deletion. So we cannot distinguish between these two if you find the microdeletion. So this is a very big dilemma. And this is another case, very, very interesting and very, very challenging. And this is what is called an allele dropout. Allele dropout is the failure of amplification in the PCR next generation sequencing technique. So this is an inherent error that can happen in the sequencing technique. There was a first child with methemoglobinemia, and we found that homozygous mutation, and there was methemoglobin level was 36%. So there was perfect clinical correlation, but the patient landed up to us only at 19 weeks. So we could not sequence the parents and wait for a prenatal. So we proceeded to test the parents and the fetus simultaneously because we thought there was a perfect match between the clinical phenotype and the mutation. But when we did the mutation, we found they reported that the fetus is homozygous, the father is homozygous, and the mother is heterozygous. The father is absolutely asymptomatic. So how can that be? So the lab was repeating the test again and again. There was so much delay in reporting. And then we requested the lab to send it to some other lab and use some other technique and primers, new set of primers, and repeat the test. And then finally, we found that the father and fetus were heterozygous. So this is a mechanism called allele dropout, which can produce some erroneous results. So if only the father was not there and the father was not showing homozygous mutation, we would not have gone and repeated this test again. So this is a very big challenge. So all results are not foolproof. So we have to be very, very careful in giving out the results. And that's why we say there is an 1% lab error that can happen in all our test results. We have to be very cautious about this. And this is a case. This is a very pathetic situation. A child with developmental delay, non-consanguineous parents, had undergone a very big whole exome sequencing, and they found so many mutations in that whole exome sequencing. And they screened the parents also for both. And because it is non-consanguineous, they did whole exam for mother, father, everybody, and then none of the mutations were matching. And when we examined the child, we found that there was dysmorphism. And we did only a karyotype with high resolution banding. We found that there was a partial trisomy 11, and father was a carrier of chromosome 11 and 12. So we need to understand the phenotype and order the right test. Otherwise, it becomes a very big challenge and unnecessary anxiety and expenditure to this family. This is another presentation, a recent case of ours. Child presented with spasticity. Child was being treated as cerebral palsy with developmental delay. The MRI showed cerebellar atrophy and hyperintensity of both lamina, which is not very common in cerebral palsy. So we did a whole exome sequencing and we found a mutation in SARS2 gene. And there was this SARS2 gene only produces hyperuricemia and renal failure and alkalosis. But then phenotype was not matching, but the mutation is reported as pathogenic. So we went and did an extensive literature search And we found there was only one case recently reported in Finland with exactly the same mutation as this child, and that child also presented with spastic tetraparesis. And this is an autosomal recessive disorder. And later we learned that SARS2 gene mutation can not only present with this syndrome, but also as spastic tetraparesis. And also there is one more presentation where it can present as sideroblastic anemia. So new information is coming on, and we have to be very, very careful in interpreting these results. So this is to determine the nature of variant. Again, very high level of expertise is needed. A child with autism, dysmorphism, developmental delay, hyperactivity came to us, and not all the time there need to be a genetic reason which can be identified. Sometimes we may not identify a genetic reason, especially in a child with autism. So they came with a low resolution array report, and they had been advised prenatal diagnosis based on this report. And they had planned a pregnancy after 5 years and came to us with an ongoing pregnancy. But then because this report was a low resolution report, we ordered for a proper CNV and then the CNV array. And then we found that these changes that were reported were only benign. And there were 2 other variants which are of uncertain significance. So finally, there is no answer for the cause of autism in this patient, and we cannot offer a PNT. So high level of expertise is needed to interpret the results, and we have to be very, very careful in counseling the patients. So choosing the right test is very important. Most of the situations it is possible, and we have to judiciously use the latest technology, because at times we may need to do further testing. Sometimes we don't have answers. Sometimes we get extra information. Sometimes we get unwanted information, and sometimes there is no clarity. So very careful planning and pre-test counseling is the key. And if you avoid this stepwise approach, it becomes a disaster. So I will end with these take-home pearls. So first time anomaly in pregnancy, we cannot reach endpoint all the time by 24 weeks. So this has to be kept in mind. An index case diagnosis with genetic confirmation is a must. Lab interpretation is very crucial. So select a lab which does data mining and is frequently so that they are updated. And NGS is not a one-stop solution. Different genetic mechanisms exist, which are illustrated with case scenarios. And there are inherent challenges in the testing technique. So clinical correlation is a must. I hope I have done justice to the topic, and thank you all for this wonderful opportunity. And I'm ready to answer any questions.
Thank you so much, madam, for extensively covering through various case scenarios and showing us crisp and very important testing pathways in the various conditions. Now, moving ahead with the question and answer session, we have Dr. Suresh sir with us. So, Dr. Suresh sir, this question is for you. Is NIPT of all chromosomes adequate for ventriculomegaly workup? Suresh sir? Sir, you're muted, sir. Please unmute.
Hello, sir.
Yeah. Sorry. Can I PT for?
Sir, Shanti has joined and she has asked that beautiful question. Is NIPT adequate for, if you do for all chromosomes, is it adequate? Shanti, we are happy to have you here, and Suresh sir is ready to answer you.
At this point of time, I don't think it's adequate because NIPT has not been validated for all other chromosomes, and it may take time. At present, I would not recommend.
Okay, sir. Thank you, sir. We have next question. If we go stepwise, karyotyping and then microarray and further testing, limitation is time frame to act, ma'am. Dr. Sujata, madam, would you take?
Yeah, so that's what I'm saying. So we have to acknowledge that fact that genetic testing takes time, and we have to approach stepwise, because even when the phenotype is glaring at us, there can be errors in diagnosis. So in a fetus where the phenotype is not very clear, we just plan investigations with whatever findings we are able to see, which may not be repeating the true picture. So we have to be a little careful and judicious in planning testing, and it is time consuming, and we have to be patient, and we ourselves have to be patient in the first place to convince patients to be patient. So I think that's very crucial.
Actually, the issue is related to gestational age. and the action that can be taken on once you get a result. Get an abnormal result at a certain period of time, what kind of action you can take on that. So far, the limitations were 20 weeks. Now it has gone to 24. And there are select cases where late terminations are also allowed if you appeal to the court. So this is one. Second thing, of course, is when we're doing the investigations, we are not only looking at it like finding out an answer for what went wrong. And most of the time, this is going to be useful for future pregnancies. So the family will get a direction of what to do further. And that's why it becomes important.
Very well explained, sir. Vidya madam, are there any more questions, ma'am? We have covered, ma'am.
No, I'm not seeing any more questions.
So again, a heartfelt thanks to all the speakers, all the respected faculty members who have been through us in the first session of the FETOMAT. Thank you so much, Dr. Suresh, sir. Thank you so much.
Thank you.
Sujata madam, for being with us. And we look forward to more sessions with you. Thank you, sir. So taking the program forward, we will take a short working lunch break of around
15 minutes. 15 minutes.
Okay. We'll be back sharp by 1:45 p.m. So in the meantime, we'll have the spotters displayed, and I request all the delegates to participate and to send the answers, not in the chat box, but in the mail ID that has been provided in the chat box, along with your contact details and complete name, so that we can announce the winners tomorrow, and exciting prizes are awaiting the winners. So thank you so much. We will resume back sharp at 1:45 p.m. Thank you. 1:45 p.m. Thank you.
1:45. Thank you, Tasin, for the wonderful morning session. Very well organized by your team. And we'll come back after 15 minutes working lunch. Thank you.
Thank you, madam.
These are the spotters. So please send the. These are the spotters. So please send the answers to email ID highrisk@kimsglobal.com. 35-year-old lady at 22 weeks of gestation on hydroxychloroquine. So what are the findings? What are the scan findings? What is the diagnosis? Play the slide once again. 34-year-old lady at 22 weeks of gestation on HCQ. What are the findings? What are the two causes? (23-year-old lady with acute chest pain at 33 weeks of gestation. History of similar episode in the past. Hemoglobin is 8. What is the peripheral smear finding? Diagnosis, management. 23-year-old lady, 31 weeks of pregnancy, uncomplicated low-risk pregnancy. What are the findings? 2 differential diagnoses. A 26-year-old lady came for ND scan. This is a scan picture. What are the differential diagnoses? What further workup will do? 2 associated syndromes. A 22-year-old lady, irregular heartbeat on auscultation. What are the scan findings? Diagnosis, prognosis of the condition. A 33-year-old lady came for ND scan. Describe the ultrasound findings and diagnosis. A 20-year-old lady, FTS low-risk, anomaly scan showed. Findings, differential diagnosis, associated genetic syndrome. Okay. The 23-year-old school teacher at 24 weeks of gestation. What are the NST findings? Fetal Doppler findings, diagnosis, treatment. A 32-year-old lady with secondary PPH, failed initial management. What is the procedure? Diagnosis, monitoring in next pregnancy. A 38-year-old lady,
twin pregnancy, preeclampsia at 34 weeks of gestation, presented with tachycardia and dyspnea at rest. What is the maternal imaging finding? Diagnosis, treatment. So please send the answers to high-risk@kimsnovel.com.
Doesn't just show me how to.
This is the notes. So we will repeat the spotters once more. Please send the answers to high-risk@kimsglobal.com. A 34-year-old lady, 22 weeks of gestation on hydroxychloroquine. What are the findings? What are the two causes? Twenty-two-year-old lady with acute chest pain at 33 weeks of gestation. History of similar episode in the past. Hemoglobin is 8. What is the peripheral smear finding? What is the diagnosis? What is the management? The 23-year-old primate, FTS low risk, uncomplicated, 31 weeks of pregnancy. What is the finding? What are the two differential diagnoses? Twenty-year-old lady came for NG scan. This is the scan picture. Differential diagnosis, further workup, to associated syndromes. Twenty-two-year-old lady, 33 weeks of gestation, irregular heart rate on auscultation. What are the scan findings, diagnosis, and prognosis of the condition? Thirty-year-old lady came for ND scan. Describe the ultrasound findings and what is the diagnosis. Twenty-year-old lady, FGS low risk. Anomaly scan show. What is the finding? Differential diagnosis, associated genetic syndrome. Show once more. Twenty-three-year-old school teacher at 24 weeks of gestation. What is the NST finding? Fetal Doppler finding, diagnosis, treatment. Thirty-two-year-old lady with secondary PPH failed initial management. What is the procedure? Diagnosis, monitoring in next pregnancy. How would you monitor in next pregnancy? Thirty-two-year-old lady, teen pregnancy, preeclampsia at 34 weeks of pregnancy, presented with tachycardia and dyspnea at rest. So what is the maternal imaging finding? Diagnosis, what is the treatment? Okay, thank you.
Good afternoon, everyone. Good afternoon, everyone. As we all know, COVID pandemic had devastating effect globally, but one good thing which happened was digital transformation, which paved the way for people from different parts of the world to participate and share their practical wisdom. On this positive note, I'll continue with the further session. I'm Dr. Sinu, working as consultant in Kims Hospital. It's my pleasure on behalf of Department of High-Risk Pregnancy and Perinatology to welcome you all for the afternoon session. Before we start, there are a few announcements. There have been some minor changes in the program schedule. The session starts with a case discussion of 15 minutes with Dr. Tazeen, followed by panel discussion for an hour by Dr. Umaram. Second half of the session will be academic feast with 4 talks of 20 minutes duration, followed by Q&A session for 10 minutes. I request all the delegates to kindly submit your queries in the chat box and we'll take up at the end of the Q&A session. And I humbly request all the speakers to be with us till the end of the Q&A session. To begin with the session, we have case discussion by Dr. Taseen Khan. Taseen is a fellow in Department of High-Risk Pregnancy. She will talk on spectrum of prenatal talk. And now over to you, Dr. Taseen.
Thank you, madam. Are my slides visible?
Yes, yes, yeah. Yes, Taseen.
So moving ahead, myself, Dr. Taseen Khan. Today I'll be discussing on tetralogy of Fallot. So we all know that it's the most common form of cyanotic congenital heart disease, contributing to 3 to 7% of the cases. And the classical TOF, which is seen in 80% of the cases, involves a tetrad of subaortic or malaligned ventricular septal defect, over which there's an overriding of aortic root. There is an infundibular pulmonary stenosis, and the right ventricular hypertrophy is not very much evident in the prenatal ultrasound. TOF in itself is a spectrum of disorders where it can range from pulmonary stenosis, where the pulmonary arteries can be narrowed down, to pulmonary atresia, where there can be extreme narrowing or even absence of the pulmonary arteries, and it can be present with a dysplastic pulmonary wall and dysplastic or an absent pulmonary wall, where there will be a massive dilatation of the pulmonary arteries. So I'll be taking 3 scenarios where we had diagnosed the spectrum of the TOF with case 1 presenting as 38-year-old primary gravida in a non-consanguineous marriage, and she was referred at 20 weeks. Medically, she was diagnosed with diabetes mellitus, which was overt, and the periconceptional HbA1c was 7.4. She was on insulin with moderately controlled sugars and no aneuploidy screening done. My second case is a 24-year-old primary gravida in a non-consanguineous marriage and referred at 18 weeks for second opinion on fetal heart. Her combined first trimester screening showed low risk for common aneuploidies. And the third case where APVS was diagnosed, she's a 33-year-old third gravida with para1 and L0 because the previous baby also had pulmonary stenosis and had succumbed on day 30 of life, but no acid genetic workup was done for the index case or for the parents. She was also in the non-consanguineous marriage and was referred to us at 26 weeks, and no aneuploidy screening was done in the early gestation. So when we start screening a heart in the 4-chamber view in a TOF with pulmonary stenosis or pulmonary atresia, we can have a normal looking appearance unless the ventricular septum is very much large to be evident on the 4-chamber view or to show the flow across the interventricular septal defect. Whereas in case of absent pulmonary valve syndrome, we can have a right ventricular dilatation, but that also in the initial period we can have a normal appearance, but the chamber asymmetry can be more evident as the gestation advances. In the 5-chamber view, ventricular septal defect is the catching line where we see an aorta overriding it, and it is common in all the 3 forms of the TOF, and it is said that the aortic root dilation can be more prominent. Aortic root dilation can be more prominent in cases with pulmonary atresia. And the same is evident even on color flow imaging. Now, the aortic dilation, as I mentioned, is more prominent in case of pulmonary atresia, whereas it can be even normal sized aortic root in cases of absent pulmonary wall syndrome. Now, the pulmonary artery, in cases of stenosis, we can have narrow pulmonary arteries, and this narrowing can even progress with the advancing gestation. In case of atresia, we can have very narrowed pulmonary artery with a minimal flow, or even there can be absence. And in case of absent pulmonary valve syndrome, because of the dysplastic pulmonary valves, we can have a massively dilated pulmonary artery as well as the right and the left pulmonary arteries. And if we put our Doppler gate across the dysplastic pulmonary wall, it will show a typical to and fro appearance. In the three vessel view, of course, the aorta will be prominent, and the pulmonary artery being very much narrowed down is less evident. So we can have only two vessels, whereas this view in case of absent pulmonary valve syndrome will have a massively dilated pulmonary artery. When it comes to ductus arteriosus, it can either be present, it is usually present and can have either antegrade or retrograde flow in case of pulmonary stenosis, and MAPCAs are not very much typical, that is major aortopulmonary collateral arteries. But they are of importance and are seen in more than 20% of the cases of pulmonary atresia where they supply the pulmonary circulature. And when it comes to ductus arteriosus, it can be tortuous with a retrograde perfusion. Whereas ductus arteriosus as well as MAPCAs, they are typically absent in absent pulmonary valve syndrome. So what happens to our cases? First case where it was a TOF with pulmonary stenosis. She decided to continue with the pregnancy but denied any genetic workup despite extensive non-directive counseling. She gave birth to a female of 2.3 kg. Baby in the immediate postnatal period required supports, but later on was soon weaned off. The postnatal findings confirmed, echo findings were similar to that of the antenatal period. The baby did not have any cyanotic spells and is now 11 months having normal cross development, and is planned for surgical repair at 12 months of the age. So in case of TOF, it is usually like around 1 year of the age where the corrective surgeries they are being planned. The other one where it was diagnosed with pulmonary atresia, she underwent termination of the pregnancy. And the third one with the absent pulmonary valve syndrome, she underwent LSCS at 38 weeks in view of fetal distress. The postnatal findings, they confirmed the diagnosis of absent pulmonary valve syndrome. Initially, the baby did not require acute care, but on the lab investigation, there was hypocalcemia and hypoparathyroidism. So a CMA was done to rule out the velocardiofacial syndrome, and it did show 22q11.2 deletion. Later on day 15, baby had acute respiratory failure. An intracardiac repair was done with conduit and a right pulmonary artery reduction plasty, which was massively, which was actually compressed because of the massive, which was actually compressing and causing bronchomalacia. But unfortunately, the baby succumbed on day 25 because of the post-operative morbidity and an added on sepsis. So in case of pulmonary stenosis, we can appreciate extracardiac anomalies in 25% of the cases as right aortic arch. Atrial septal defect or atrioventricular septal defect can also be noted. In case of absent pulmonary valve syndrome, aortic extracardiac anomalies are less, cardiac anomalies are less common. When it comes to association with 22q11.2 deletion, it is seen in approximately 20% cases of pulmonary atresia, and in much higher percentage in cases of absent pulmonary valve syndrome, as it was also present in our case. Now, the differential diagnosis is with common arterial trunk or double outlet right ventricle, which may present with pulmonary stenosis or atresia. In case for the TOF with pulmonary atresia stenosis, in case of absent pulmonary valve syndrome, usually the diagnosis is evident because of the aneurysmal dilation aneurysmal dilation of the pulmonary artery, which confers the diagnosis. So when it comes to prognosis, TOF with pulmonary stenosis has got a better prognosis, and the survival rates have been shown to be more than 90%. Of course, it is dependent on the adequacy of the pulmonary circulation and the associated abnormalities. But if there's a presence of MAPCAs and if there's a prenatal diagnosis of TOF and if there are associated anomalies, they all contribute to bad prognosis. Same is the scenario with pulmonary atresia, with the presence of MAPCAs, prenatal diagnosis, and associated anomalies are bad prognostic indicators. But overall, also the prognosis is guarded. And same is the case with absent pulmonary wall syndrome, where we usually counsel about the guarded prognosis despite corrective surgeries, which can be performed later. And also there is high association of the genetic abnormalities, 22q11 to be specific. And the survival has been seen, intact survival at 1 year, it has been seen in less than 25% of the cases. So when we diagnose a tetralogy of Fallow in the antenatal period, we need to do the sequential segmental analysis to rule out any other associated cardiac anomalies. We also need to rule out any extra cardiac anomalies. Karyotyping is definitely mandatory, and a CMA should also be done if it is possible. Delivery at a tertiary care center with a multidisciplinary team involvement is definitely required. So this was a long-term study that was done from seeing the cases where the first repair was done in 1954. So they had taken cases from 1975 and seen them till 2018. And they saw that as the years post-surgery, they increase, there are very less complications and intact survival has been noted. So if there are complications, there are more to occur in the immediate post-surgical period, and later on, good prognosis and survival have been documented. So just to summarize, the diagnosis and typing of TOF has got prognostic implications and also helps in the prenatal counseling. Treatment of classical TOF has resulted in excellent long-term survivals, where the 30-year survival has been seen to be ranging from 70 to even 90%. Though there can be some residual problems of right ventricular outflow tract obstruction, and it may require reinterventions, and some arrhythmias can also occur. So multidisciplinary team involvement and a tertiary care center delivery is definitely required. Long-term outcomes that depend upon the severity of the obstruction and the adequacy of the pulmonary circulation that is established after the corrective surgeries. And since there is a long-term outcome seen and 30-year survival is there, we are also seeing women who had a corrective TOF done during their early childhood period. So we need to now answer the question that what is the chance of a recurrence of such defect in their babies. So it has been found to be 3 to 5%, which is somewhat more than 0.8% for the general population. With this, I would like to end my presentation. Thank you so much for your patient listening.
Thank you, Taseen, for that detailed description of your 3 spectrum of how TOF can behave. So one quick question. Dr. John, can you just unmute and join me for a minute? John? Are you there?
Yeah, hi there.
Yeah, John, one question, what will you like to ask her in a setting like India, where she has diagnosed 3 variants of TOF in different time frame of pregnancy, which is a purely correctable condition. And you have seen the outcome here. What would be your take on this?
I didn't see the full chat, so it's difficult for me to comment on those 3.
But she had, Taseen just put that one single slide where you showed all the variants.
Yeah, ma'am. So this was the initial case scenario, sir. Yeah. Are my slides visible?
Yeah. Now go to the 5th slide where you showed all the 3. Yes. John, the first one was with the pulmonary stenosis, and second was with the pulmonary atresia, and the third was with an absent pulmonary valve.
That's fine then. Look, we have 2, obviously where we are, and Vidya will know that, we have 2 kids' hospitals, one that most probably would do more of the cardiac surgery, Westmead. So yeah, I mean, for these cases, if they haven't got significant, I think one of them had a 22q, which as you know is, involves lots of things, but a lot of them can pass as normal. So they'd all be offered, pediatric surgery post-delivery.
So finally, to put together, Taseen, the days are over when we say termination of pregnancy for mothers once diagnosed of, that you're honest with them, tell them the outcome measures, rule out aneuploidy, especially when, as John was mentioning, rule out specific aneuploidy markers, aneuploidy things, and then give them a proper counseling with the multidisciplinary care, including the pediatric cardiologist, pediatric cardiac surgeon, and with the level, high-end level NICU, so that the family takes the call of how to go forward. And the decision is not ours anymore, it is a family decision. Wonderful presentation, Tasin, it's a very good case series. Thank you. Sinu, can we take, yeah, thank you. Thank you, Tasin.
Dr. Sinu Madam now.
Thank you, Dr. Tasin, for your wonderful presentation. So moving further with the discussion, next we have a panel discussion on preterm birth, recent updates in management. Preterm labor, as we know, is globally the leading cause of perinatal morbidity and mortality. So this topic will be of utmost importance for all of us. So it's my honor to welcome Dr. Uma Ram to moderate the session. As we all know, Dr. Uma, can you have the CV of Dr. Uma, please? CV of Dr. Uma.
As you share the CV, I won't waste time. She's my role model. I will just mention my mentor from year 2002 of whatever I think I act upon and how I take my career through. Wonderful clinician, a good human being, a passionate academician. I don't have more words to talk about Dr. Umara. The stage is all yours.
Dr. Uma, consultant of Chennai.
Share the CV, Sinu. That was my own words, but you can put the CV.
That's fine, Vidya. We can go ahead. Thank you very much. Thank you very much for those kind words and also for the opportunity to be a part of the program. So in the next 1 hour, we will hope to go through some more a case-based discussion to highlight some of the challenges and solutions that we have in the management of preterm labor, and to help me with this panel and actually do the bulk of the work, because it's quite easy to ask the question. The people who are going to be answering and giving the messages are Dr. John Smallnick, Dr. Shamla Devi, Dr. Rafika, and Dr. Naveen. All with many, years and decades of experience. So we have 3 obstetricians and a neonatologist. And yes, so as was mentioned in the introduction, preterm birth is about 5 to 18% of all births, but it also accounts for about 57% of all costs. So there is morbidity, there's mortality, and there's also expense involved in the care of these newborns. Depending on which part of the world you are, the expense may be borne by the couple, as it is in India, and where in other health systems, the cost is still there. It's borne by the system and not necessarily by the individual. So we have spontaneous preterm births forming nearly 50%. In a third of these, there is preterm rupture of membranes, and iatrogenic prematurity is something that is what we contribute to when there are conditions like growth restriction and preeclampsia. We know that there are many reasons and 4 possible underlying causes that result in preterm birth. But for the purpose of this panel, we're going to just focus on how do we make the diagnosis, how do we look at interventions for treatment, how effective is screening, and can we actually prevent it? So I begin with a 30-year-old primate who's come in with an uncomplicated pregnancy so far, who comes in complaining of some lower abdominal discomfort. She's 30 weeks pregnant. Dr. Shamla Devi, how would you rule out preterm labor? Because obviously that's one diagnosis that is there in the back of our heads. You need to unmute, madam.
Good afternoon, everybody. First of all, I would like to thank Dr. Vidya for making me a part of this wonderful academic program. Okay, moving on to the discussion proper, madam. Try me 30 years with uncomplicated pregnancy, abdominal discomfort. And how will you proceed with this? I think I would try to get more details about the abdominal discomfort she is having, whether it is associated with any urinary symptoms like dysuria, because there can be so many causes. So dysuria or any frequency of the menstruation, any loose motion, whether she has any change in her food habit recently, or whether this is associated with the menstrual cramps like pain that only roots of preterm labor. Usually they will be referred to the low backache, lower abdominal pain, some vaginal pelvic pain, vaginal discomfort. Is there any associated vaginal discharge, so the serosanguinous discharge or any fluid coming? All this we have to get inquire as the patient complains of this. Then go through the previous reports if anything is available to make sure there's the exact gestational age you have to come.
Yeah, that's
it. And whether she had an FTS or a target anomalies, can anything like that, any other associated medical problems like that. Just go through all these things, then the examination of the patient. And when you're palpating the patient, whether it corresponds to the period of amenorrhea, 30 weeks, whether there is some small size or lesser size, all these things, fetal parts, everything we have to make sure. In between, we can know whether the uterus is contracting or not, whether she is complaining of pain, any contractions we can feel. And then proceed with the sterile speculum examination. And can look at the cervix. Sometimes we can see the cervix. We can length of the cervix also. We can make out the external lobes, whether there is any discharge, any fluid coming, all these things. And you can want what you can take a vaginal swab. Is it a routine practice? You can take a swab also at that time. And suppose you do a speculum examination, you cannot make out the length of the cervix or you cannot see it like that. Are we going to do a vaginal examination? That is debatable. A sterile precautions and without no leaking, I think we can do. Otherwise, we have to proceed with a vaginal TVS to know the exact length of the cervix and whether the nose is open and what about the internal loss. That is more important. When you do a perspective examination, we cannot say any change in the internal loss. If there is a funneling of the internal loss, what is the total length of the cervix, what is the length of the funnel, all these will the management.
Okay, ma'am, you mentioned we'll come back. I mean, you emphasized the need to take a good history and the need to do a clinical examination. You said you would want to do a swab. Now, routinely, is that swab taken and sent for what? For culture? What is the purpose of the swab?
It depends upon the nature of the discharge, madam. If it is a very if you think that is a vaginitis, like months vaginitis, will just be a droplet in the examination. Or we can say before culture. Usually we don't take GBS as a routine. Only as a part of the study, we took it for last 1 year. No, we are not doing it as a routine.
Okay. So, so basically, I think the focus is that we want to rule out other causes of possible abdominal pain and then rule in whether the woman is in preterm labor. John, in your practice, is a swab routinely done or?
Yes, we are doing it in case.
Yeah, no problem.
Hi, thanks for the question. So what the way it would be approached is exactly as described. Basics, is she really in labor, isn't she? And depending where she is, which hospital, what's her setting? So we divide our area, we've got 5 different hospitals, different settings, and some of them, obviously, if this was a real preterm labor, we would want to find a diagnosis pretty quickly that she doesn't drop out there. So they're in the area, there are only 2 hospitals that could take a 30-weeker. In fact, one can take just 32 weeks. So to us, it's important they do the assessment and we use fibronectin to decide if there's no other obvious cause, is this real or imaginary? Now that's presuming she hasn't got polyhydramnios, she hasn't got a fever, a UTI, whatever, because it's the transfer that's critical to us. So basics, and then we use fibronectin objectively with obviously what you've seen in the cervix, see if you think it's short or whatever. Yeah.
Okay, thank you. So in India, fibronectin is not available, and so it's not something that we use, and we'll come back to that a little bit in the discussion. So the points that have been emphasized are the need to make a diagnosis, and one of the needs is to decide whether we want to initiate treatment if she is in preterm labor, and to do in utero transfer to a facility that will be able to manage this 30-weeker if the woman does progress in labor. So let's say the uterus seems relaxed when you've examined cervix, you've done a vaginal exam, cervix is 2 centimeters long, os is closed, presenting part is high, there's minimal vaginal discharge, nothing worrying, and there's no draining. Rafika, would you, be happy with this? Would you still want to do a vaginal scan?
Ma'am, you are mentioning about the 26-weeker or a 36-weeker with 30-weeker with.
She's 30 weeks.
30 weeks, clinically, there is no features of preterm labor, like uterus is relaxed, and her other clinical features are nothing to suggestive of preterm labor. And if the cervix is 2 centimeters long and os is closed, presenting part is high, I don't go for a transvaginal sonography to confirm the cervical length.
So you want to do other things to find out if there's a urinary infection, etc.
Yes, other causes of discomfort.
Okay, fair enough. Now let's say when you examine her, the uterus is irritable, cervix is 2 centimeters long, but is 1 to 2 centimeters dilated, and there is no draining.
Yes, uterus is irritable and the cervix is short and os dilated, means she is
same length, 2 centimeters long, but
1 to 2 centimeters dilated.
It is dilated, yeah.
That means she is going for preterm labor. So you should consult the lady and the family regarding the risk of spontaneous preterm labor and chances of preterm delivery also. So just irritable uterus and with this much dilated cervix, you can have a hospitalization and continuous monitoring, CTG monitoring also. If the contractions are increasing, you have to go for management of preterm labor.
Okay, fair enough. So both Dr. Shyamala Devi and John mentioned that you would do a vaginal assessment also with ultrasound. And the reason for that is that sometimes you do not realize whether the cervix is short or not. The digital examination may not be as good as an ultrasound examination. And this is from the NICE guidance that if you have a woman who's in suspected preterm labor, you would consider doing a transvaginal ultrasound. And if the length is more than 15 millimeters, preterm labor is unlikely. But if it's less than 15 millimeters, then you would diagnose preterm labor and offer treatment. So and obviously we would do a vaginal exam, and you could have either of these two situations where you can see that here the length is pretty good, os is closed, and here you can see a very short cervix with a dilated os, and this obviously will decide how we are going to manage. So let's assume she goes, you have somebody who is in the second category where the os is 2 centimeters dilated. Then what are the treatment options that we will consider here?
Os is 2 centimeters dilated, uterus is irritable, isn't it?
Yes.
That means she is going for preterm labor, and we should consider tocolysis along with corticosteroid coverage.
Okay.
Antenatal corticosteroid and tocolysis for steroid coverage. But by the time, meanwhile, we have to rule out any evidence of clinical or lab evidence of chorioamnionitis.
Fair enough. Fair enough. So in terms of the tocolytic agent of choice, Dr. Shyamala Devi, what is the agent that you use for tocolysis in this woman?
Before we start all these things, I would like to discuss with the patient, counsel the patient regarding the NH2 care. We would like to refer the patient to our neonatologist, what are the facilities there, and how much. So that is very, very important before we start the treatment, and we should plan, as we said, in utero transfer also as early as possible. So
Right.
counseling and neonatology consultation very, very important before we decide upon giving this. Or we can start tocolysis and send the patient, but this is very important. So she may progress very closely. So neonatology has to be involved in the decision making. And we have to discuss with the patient the roundabout expense, the duration, whether they can stand it. All this has to be
very, very valid point. Very
before
valid.
we start the treatment. Treatment, as Rafika said, it is steroid and tocolysis. Tocolysis only for the to cover the steroid period, not more
Correct.
than 48 hours.
So what is the agent that you use, ma'am?
Usually we use Nicardia, madam.
Nifedipine. Okay.
So nifedipine we use 30 milligram depending upon the body weight of the patient, 20 to 30 milligram, then followed by 10 to 20 milligram.
Okay.
48 hours.
John, in your part of the world, what is the tocolysis that you would use?
Nifedipine.
Same nifedipine. Is there any experience with oxytocin antagonists?
Yeah, they're coming in, but in terms of for years now, we found that nifedipine orally works quite quickly, but yes, the antagonists are being looked at more and more, yeah.
Okay. So we'll, so nifedipine is the universal choice, and we'll come to steroids and the other agents in a minute, steroids, antibiotics, and magnesium sulfate. So just to say that nifedipine you would give, and the reason to give tocolysis is because even those few days gained are beneficial for the neonatologist, and we'll come back to Dr. Naveen at a moment. So generally it's a 20 milligram start dose, and then you give 10 to 20 milligrams, so 3 to 4 times a day, and you try not to go, I mean, you have to be cautious when you hit more than 60 because there can be adverse effects. Atosiban is not readily available in India. It is expensive, and nifedipine is not, I mean, it is not superior to nifedipine in the studies. So I think we'll just stick to nifedipine for the moment. And so the duration of tocolysis essentially is to just buy time for steroid cover. And everybody agreed on the steroid dosage at this point. Now, if she's dilated clearly, there is the timing of the steroid becomes important. If somebody is having a short, threatened preterm labor, cervix length is there, I think opinion is maybe a little bit divided on when to time the steroid. Any comments on that? Giving it too early? John, do you want to comment?
Yeah, look, I think it's very important because there is recent work done where they've looked at steroids, and basically the comment has come that no good work has been done since Liggins did it, 40 years ago. And in fact, looking at the doses, betamethasone, it gives an amazing whack compared to DEXA, smaller dose spread out. And there was a very good presentation, a whole session recently in Melbourne from experts all over the world who've done the animal work at Western Australia. You know, they've done a lot of work there. This guy's now, I think, in Singapore. And really saying, guys, we got to look at it again. This business of liberal use of steroids is not in. And the business that if you, let's say, gave one dose, we used to, what we're doing is we thought if things are progressing, within 12 hours, they give another. And they have actually now showing they think that does harm in the long term, the long term. And that the one dose is so big that adding another one, it's, you know, like your receptors are saturated. It's not going to add anything, but it's another big whack. So that work is very current. And I think in the years to come, we're going to see definitely people being a lot more conservative with steroids. Whereas the infertility group, I mean, I worked with an infertility guy, 20 years ago, and he was giving his multiple infertility people steroids like almost every week if their cervix was shortening, and he was putting stitches in. So who knows what that group looks like now neurodevelopmentally.
Yes.
Can I make a comment?
Yes, John. Thank you.
Madam, the betamethasone we are getting in India is mainly phosphate. and not the acetate. The phosphate is supposed to be very soluble and it is getting excreted early. So the cumulative effect is less because unless we get the acetate, so recently we are changed to Dexone. Sorry.
Yes. So
Any comment about that, madam?
Yes. So yes, the betamethasone that we get in India is a different molecule. We don't know how it works, how it peaks and what happens. But there is a good amount of recent work, as John mentioned, about the negative impact of using steroids, about how that single dose gives a very high, high amount of steroid in the blood. And we don't know whether that's going to do harm. And there is a recent review of even the RCOG guidance on antenatal steroid use, where they are far more cautious and where they are also questioning the use of steroids for late preterm. So these are, this is a space that we need to watch. And yes, there's a lot of steroid abuse where, when somebody has a queried short cervix, potential IVF pregnancy, many units give weekly steroids here once they cross a certain point in time. And that's certainly likely to do more harm than good, because the harm we are talking about is neurological impact, which is going to have long-term implications for this baby. So I just want a quick response from all the three obstetricians before I get to Dr. Naveen. Would you, in this kind of situation, use antibiotics at all? Is there any value? She hasn't ruptured membranes. This is threatened preterm labor. In your protocols, do you include an antibiotic? Dr.
No, madam. We don't recommend antibiotic for.
We are not giving.
No. Okay. John?
Yeah, I agree. I'm a conservative, but I would have a look at inflammatory markers and depending how long she had exposed membranes.
Okay, fair enough. Dr. Naveen, if you look at the guidances and you look for early onset sepsis in neonates, one of the risks that they mention is preterm labor and, of course, PPROM, but even preterm labor, again, because of membrane exposure. And, in general, we tend not to give antibiotics in these kind of situations. Would you be happy to receive a baby without any antibiotic cover? And would you prefer that we use antibiotic?
Although preterm labor is the risk factor, when we look at our own data over the last 15 years, the early onset sepsis of a confirmed nature, which is culture positive sepsis, the preterm labor was only 1.1 as a risk factor. Whereas there were other risk factors like a baby being born symptomatic at birth and the overt infections like urinary tract infection, high maternal fever, or a foul discharge, which we may not see in a developed part like in Australia or even in KIMS or even in your practice. It might possibly be more where mothers present late. We rarely see foul smelling like this, but these would be situations, or if you're too conservative in obstetrician and neonatology unit, I would go with Dr. John that you have a very high inflammatory marker. I mean, very high. You should not depend on borderline numbers, which could happen in any situation of stress. So maternal fever has been one of the most important parameter in the EONS scoring systems that have been recently developed. And a baby who's asymptomatic at birth, which obstetrician wouldn't know, of course, and maternal fever and GBS screen, which we don't do routinely, it's not the problem for India, possibly. So therefore, maternal fever, in the absence of maternal fever, more than 100 Fahrenheit or 39.5, possibly we would not be too worried, and I would leave the judgment to the obstetrician.
Okay, all right. So let us finish magnesium sulfate as well, and then we'll come back to other aspects of counseling of this preterm baby. At what point in this lady's progress should we be giving magnesium sulfate? I think there is certainly it's something that has come into our algorithm for the management of as an intervention in preterm labor. This is a 30-weeker. So at what point would we initiate it? John, do you want to take that?
Yeah, look, only if I think it's going to deliver, because you can, you can give it really late. So you shouldn't give it just too early, like she comes in, like with your steroids. Yeah. Definitely not. But if you had evidence that dilatation is continuing and you expect delivery in the next 12, 24 hours, yeah, up to 32 weeks, not beyond.
Okay, fair enough. So it's not something that you initiate when you have somebody querying or you're not sure whether she's going to respond to tocolysis. When you are sure that she's going to, she's dilating and she's actually going to deliver, that is when you would initiate. Okay, yeah. So yeah, thank you. I think we have, and the rationale for magnesium sulfate is there. The dose is similar to what we would give for preeclampsia prevention, and getting the timing right is what is important. So she progresses in labor, and Dr. Naveen, the couple is in the labor ward, they're being monitored, and the obstetric team has called you and said, this couple need to talk to you. And what are the factors that you would go through with them quickly? And what should, if you're an obstetrician, let me put it another way also, if you're an obstetrician in a unit where there isn't a tertiary NICU and there isn't a full-time neonatologist, very often we are counseling them first off and then they get shifted. Sometimes they hear a very different message from the obstetrician and then from the neonatologist, especially in terms of the duration of care and long-term outcomes. So could you just walk us through what we should be counseling these couples?
Uma, first, am I clear? Because Vidya just passed a message that there was some lack of audio clarity.
No, you're perfectly fine.
Fine. So we have all senior clinicians in the group, and comforting a antenatal mother would be the first step. The family should be assured that they are in for a good mother and baby outcome either way around. Whether we deliver if it becomes imminent, or whether we try to continue the pregnancy with careful monitoring. So that would be the first thing. And we would use the word potential delivery only if the obstetrician is feeling that it is quite going to be. In terms of survival, if you take objective values that you need to give to the family, today in units which are having a good manpower and a busy neonatal unit, survival at 30 weeks is almost sure, more than 98 to 99%, leaving that 1% for uncertainty. Second thing is, we have now our own units outcome data also. They would probably have more than 94% babies are surviving without major morbidity at preschool entry at 3 years. So 6% would be possibly at risk. And I would rather not scare the family about the 6% risk, because 94 is a good survival. Possibly in a country like India where patients pay from pocket, one of the important things would be to give them an idea that they would have to be in hospital for about 6 weeks at least. But this 6 weeks, that is 30 to 36. And this would be different in Australia, where they would possibly have the liberty to hold the family a little longer till this baby is safer. But in India, we would be looking at discharging them at 36 weeks. This would then split the patient care into two categories is what I look at. If they are the kind who cannot continue the 6 weeks of intensive care, then we would like to have them spend 1 to 2 weeks of intensive care in a hospital, the first 1 or 2 weeks, where really it makes a difference by the right intensive care in terms of long-term survival and outcome, and then transit to a facility where step-down care can be offered and the costs can be reduced. But otherwise, 6 weeks of care for a middle-income family is quite possible. We need to encourage them. Most parents would be able to spend money for their child, and possibly because I'm a neonatologist, I always try to look at it this way, that maybe 3 lakh rupees spent for 70 years of good quality life is better than buying a stent for 3 lakh rupees for 5 years of an elderly gentleman. So this is what.
Okay. Thank you for that. I had a question for you as well, because I'm sure they would have all done it, but it just didn't come up in discussion. Would the weight of this baby matter at all? And would you want an ultrasound to know what the weight of this baby is?
The estimated fetal weights do determine survival chances, and if they are lower than what would be expected for the gestation, then they do increase the risk of morbidity as well as possibly even the plan of delivery for the obstetrician. So although we are aware that when you get down to lower gestations, then there can be limitations in accuracy of, if you depend only on the gestation numbers and weight numbers, you're probably looking at several other variables to establish poor fetal health.
Because also at 30 weeks, very often she wouldn't have had an ultrasound after 20. So while we are focusing and getting a cervical length, it's also important that we keep the weight of this baby in mind. Now, sometimes they come in preterm labor and they're 34 weeks. We as obstetricians are not so worried, and sometimes we don't really say too much to those mothers. We are sometimes very reassuring and we say, okay, you're 34, 35 weeks. You're going into labor. We may not even worry too much about buying time. And so while we are on the aspect of counseling, what are the 1 or 2 important points that we should communicate with a couple who's having a late preterm?
Uma, our reason for our business being low in KIMS is the feto-maternal team and obstetric team, which is sitting with me here. They don't allow late preterms to be delivered unless it is really necessary.
Spontaneous. I'm not talking about iatrogenic.
Yeah, but then we would prepare them if they are going to deliver, and if you are asking the information to be shared with the family, then we tell them that it would require at least a week to 2 for the baby to be in the hospital while they learn thermoregulation and would possibly would be learning to feed the baby. And if the question was on antenatal steroids, then our own data, which we generated over the last 2 years, by looking at the change in outcome after the perinatal unit, Shamla ma'am, Rafika ma'am, Dr. Roshni, Dr. Vidya, we all sat down together and looked at our data, and we felt the respiratory morbidity rate, which is severe enough to be in ICU, was quite low. And we, for the last year, we have not been giving antenatal steroids to this 34 to 36 category, and even the early term. And 350 pregnant diets before and after were looked at, and we found no difference in respiratory morbidity. We thought we would have lesser of hypoglycemia, but I think the sample was not large enough to look at that outcome.
Okay, thank you. The reason, as this I'm posed the question is, yes, their respiratory mobility is less, but recently I got caught out with one baby which actually needed ventilation, and it was and the couple told me that you did not mention that specifically that this could be a reason, but we would have if she was 30 weeks, but sometimes at 34 we do say baby will need neonatal care. We don't specifically say need for ventilation. So
can I ask, do
yes.
you steroids depending on the mode of delivery after between 34 late preterm? So vaginal delivery versus cesarean after in the late preterm. What have you found? Because obviously with the new steroid stuff, I would be, and let me tell you, 2 decades ago, we would always allow vaginal delivery over 34 weeks not to have steroids.
Yes.
Whereas the cesarean, definitely a change, and they were giving steroids. And I wonder now, with looking at the data and getting more data, how much of a difference there is in that. What does the neonatologist Naveen say? Come on, give us the latest.
We do not have, to be very honest, the comparison in the same group. It was too small a group to further break it into this, and I really agree with you that the concern about labor not being there might add the risk, but the total risk itself was small enough in the sense that in this 350 mothers died, only one required intubation. And others were managed with just high flow nasal cannula, which we feel is a reasons not enough to expose to antenatal steroids, which has increased the risk of hypoglycemia to the baby and neuromorbidity also. You would be very surprised when we look at the maternal data in this 350 mothers, the possibly drug-induced diabetes was very low in the group which did not receive these antenatal steroids. And I don't know how that will affect the way we address the pregnancy and also the neonatal outcomes. So our answer would be that we can look at this subset, but the morbidity rate is quite low already to be considering even in a cesarean section.
So we need a larger number to be able to say that. Okay, I think we need to watch the steroid space to, to decide what we are going to do going forward. Okay, so I now move on. I think we got some very clear messages on the management of a preterm labor. I now want to move on to three different situations. So the first is, she's a second gravida. She's booking with you at 8 weeks. She's had a previous preterm birth at 30 weeks. Rafika, how will you address her concerns about another preterm birth?
She had a previous preterm birth at 30 weeks, no ma'am?
Yeah, spontaneous preterm birth.
Yes, a previous history of spontaneous preterm birth is definitely a high risk factor for recurrence of preterm birth in the current pregnancy.
Mm-hmm. So she's sitting in front of you, she's worried, she's saying, Doc, what's my chance that I'm going to have another baby at 30 weeks? I really would like to avoid that if possible. Is there anything you can do to help me? What will you tell her?
For this case, we need much details about the previous pregnancy. What was the cause for preterm labor? Was it a spontaneous?
She came in spontaneous labor like the lady we just discussed. She progressed and she delivered. She didn't have any other risk factors.
Any other risk factors. Even then, she has a high risk for getting into labor, preterm labor, this pregnancy. So she needs monitoring. Monitoring in the sense, cervical assessment is the most single predictive factor for detection of preterm labor. So cervical assessment from serial cervical assessment by endovaginal sonography from 14 to 24 weeks. Sorry, 16 to 24 weeks.
All right.
Once in 2 weeks.
So you want to assess her cervix, and if her cervix length is, let's say you do it at 16 weeks and it's 3 centimeters, you're happy to just watch every 2 weeks. That's what you're saying.
Yes, but we can offer her progesterone also, because progesterone reduces the risk of preterm labor.
Yeah, so that is precisely my question. Would you measure her cervix and then decide, or are you just going to give her progesterone? What is your practice?
Basically, I need to do a cervical assessment at 16 weeks. And if it is below 2.5 centimeters,
then you would consider progesterone. If it's 3 centimeters, you're not going to give her progesterone.
No, madam, we can have progesterone because progesterone definitely improves the outcome. We used to give. In our clinical practice, we used to start progesterone also.
Okay, fine. John, I mean, if we're going to give her progesterone anyway, then why are we measuring her cervix?
In addition, cervical encirclage also, if required, like if the cervical length is even if she is on progesterone, if the cervix is shortening below 1.5 to 1 centimeter, maybe we can consider with widening of the pores.
All right, fine. So that's a different scenario. I'm just asking for the initial decision. Is there, somebody who's delivered at 30 weeks for a singleton, there's good enough data on progesterone for us to say, you just start on vaginal progesterone from 16 weeks for everyone?
Yes.
John? Thanks, Rafika.
Look, I mean, the work that originally came out supported it, and doctors love treating people. And as you know, one preterm delivery before, 1 in 6 or something, 1 in 7, 15%, whatever people have quoted. So progesterone was pretty simple. So they did it. And it happens a lot where I am that they will do it. But having said that, it has been challenged by other work. And people are saying, who are we treating, whatever. We would also, in our practice personally, since it's 30 weeks, she'd get, if she's really worried, she can have, with her early scan, she can have her cervix done as well with the screening at 12 weeks. An anomaly scan that now will check the cervix as well. And depending on that is what frequency would you do it thereafter. But definitely maybe from 25, 26, I'd like to know what it was. Is it going to begin to short? Give us some warning, and more warning that we could get steroids maybe involved, talking about steroids, if she's going to repeat what she did before. Forewarned is forearmed. So that sort of thing.
Fair enough. So I think the message that is coming here is progesterone is effective in preventing preterm labor. And generally, if you're going to use it, you can initiate it from 16 weeks. You can measure the cervix, or you could say, I will look at the cervix at 16 weeks. If it's long, I'm not going to initiate the steroid. The progesterone, I will look at it at the time of the target scan. And if they're shortening, then at that point, I will initiate progesterone. So there are two schools of thought. But the other point is that you then want to know whether the cervix is further shortening, because that will then give us some heads up as to whether she's going in the direction of preterm labor to decide what our next intervention is. Okay, thank you for that. The next question I have, Dr. Shamla Devi, you have a woman who's had a previous IUFD at 24 weeks and then a vaginal delivery. Subsequent workup showed a septum for which she had a hysteroscopic resection. She's now pregnant and at 12 weeks.
Any more details about the first IUFD, madam? Because septum
the first IUFD has been completely worked up. They couldn't identify a cause. All tests, she's had her APLA screen, she had an autopsy, placental biopsy, she's seen a genetic team, everything drew a blank.
It's unlikely that septum will give rise to IUFD.
Yeah, so she's had No, I'm asking from the point of view, are you worried that she could have a preterm birth, and are you going to do anything about it?
Septal resection actually doesn't want prophylactic circulage this time. We have to find what is the cause of IUFD. If nothing is available, we cannot do anything. Just close follow-up of this patient. If he is target scan, all other investigations to be done.
Thank you. No, the reason I asked that is
septal resection doesn't want cervical encephalitis. That is what Madam wants to convey.
Yeah, thank you. Okay, so then we have another woman. She's had a previous twin pregnancy at 32 weeks, and now she's pregnant with a singleton pregnancy. And she's asking you, what is my chance that I'm going to have a preterm birth? Dr. Shamla?
Twins also, there is no place for encephalitis. It will precipitate preterm labor, actually, if you go and do encephalitis for a twin pregnancy. But progesterone is also not recommended, man. I think so. But you can have close follow-up of these patients, cervical measurement because of the previous history. And there is no harm if you give progesterone for this, twin pregnancy with the previous preterm labor, but definitely no circulars.
Okay. So basically, the previous preterm labor does increase the recurrence risk, and that's the range of risk based on 1, 2, or 3 preterm births. So after 1 preterm birth, it's about 16 to 19% chance. So there's about 80% of them are not going to have a repeat preterm labor, and that's the reason for the 2 schools of thought. Now, obviously, if they deliver before 28 weeks, there's a 3-fold increase. And if they've had a previous preterm birth in twins and subsequently singleton, their preterm birth rate does not increase. And if they've had, so only 10% of women, 10% of preterm births happen in women who've had a past history of preterm births. And if they've had surgery on the cervix, then they are at increased risk, but uterine surgery, there's no data that they need a suture or progesterone or anything at all. Okay, now we come to the issue of universal screening, and then what are the numbers and when do we react? So this is somebody who's had a previous section for breech at 38 weeks. She has a target scan now, and the cervical length is 2.3 centimeters, os is closed. John, your response?
So this is at the 18-week scan?
Yeah, 18 to 20, yes.
Yeah, look, she got to 38 weeks. I have easy access to transvaginal scanning, so I would talk to her about that. I wouldn't even throw in, I wouldn't give progesterone. I don't like giving medications that I don't think I need to. And it's a matter of, I would do offer her cervical surveillance and see what it's doing. So I might do it frequently initially to make sure it's not shortening very quickly. And if it's not, then open up the intervals.
Yes, fair enough. Okay. So I think also even if you are looking at the routine screening, in a couple of studies, they're looking at under 2 centimeters to say that it is actually short in a low risk woman. So it's fair to just watch her. Suppose she's had a previous delivery and now it's 15 millimeters at the 18 to 20 week scan, but there's no funneling. Dr. Shamla?
I think we recommend progesterone.
Progesterone.
Because it is 1.5 centimeter and close follow-up of the patient.
Okay. John, at 15, what would be your response?
So I would be very cautious with this woman. I definitely give the progesterone, but I would see her, if first time it's 15 millimeters and she's had a full term, that's a positive, but I want to know it's going to stay 15. And 15's quite short already. So I would, some people say, oh, I might do it in a week, I might do it in 2 weeks. I actually would do it in a few days, split the week. I just want to know it's going to stay there. And then if it stays there, I get more confident and I would release the frequency, because obviously I don't want to be putting in a rescue if I could have avoided it and got in one when it was closed, membranes not exposed. So that's my worry. And basically we don't know exactly what frequency, but I think more like you heard I was an engineer. I like data. I want more points on the curve to know what's happening. So I'm into serial.
Yeah. Okay. So the reason I'm putting this is we are getting routine cervical lengths measured at the time of the target scan. And sometimes you see 24, 25 underlined in red and circled, and the woman is given a lot of grief about her risk of preterm labor, and they're quite worried when they come for another opinion. But when it is 15, you are worried. Of course, you need to check that you're assuming it's appropriately measured. And the importance here is, besides progesterone, this lady may need a suture if she starts to dilate, or she may need counseling and preparation if she's going to deliver much, much earlier. So you will watch her more frequently. We had an interesting situation where this lady actually declined progesterone. She said, I've had a previous full-term normal birth and nobody measured my cervix then. So I don't want to take the progesterone. How would you handle this situation?
I wouldn't have a problem with it at all, because I think that it's something that we're thinking about anyway. But I would want the surveillance. I talked to her about the surveillance. Most of them understand the common sense of it, assuming they can. And that information is giving them also reinforcement that hopefully they can behave normally. And as we know, every biological model is not necessarily a normal curve, Gaussian, but there'll be the shorts and they're the longs and there's in between. So have I seen someone with a short cervix in the history like this that stays like that? Of course not. Yeah.
Yes. So I think that's another very important message, that Every woman who has a short cervix on her target scan is not going to have a preterm baby. So it's important that we have the discussion. And if the woman understands and chooses to decline a progesterone which we offer, I think it's appropriate to make sure she's understood and then still offer the follow-up, because she may have the opportunity to change her mind at the next review. And we may also change our mind if there isn't any worsening of the length of the cervix. So that becomes important.
How often to follow up cervical length, madam? 1.5, 15 millimeter. How often we have to follow up that cervical length?
I mean, personally, I would call her back in a week, but as John said, he wanted to call her back in a few days just to make sure that it isn't starting to open. In which case you may want to then put in a stitch. So, but certainly you would see her soon and then maybe stagger it if there isn't a change. I don't think there's a one rule that fits all. We'll have to individualize and see what is happening. We also have the situation not very uncommon when somebody comes for a second opinion and there's only a transabdominal ultrasound done. And I'm sure everybody here will say that that's not good enough, but I'm just putting it out there because it is not an uncommon practice that we see in India, and therefore it's very important that you then do a vaginal scan. And if you find that the length is quite normal at the vaginal scan, then you can reassure the woman that nothing needs to be done at that point in time.
At this point, I would like to make one more comment, madam. Along with this scan, when you measure the cervical length, can we look for the uterocervical angle? Whereas somewhere it is the uterocervical angle is the first thing that changes. If it is more than 95 degrees, there is more chance of preterm labor. So these patients are more likely to go in for preterm labor. So uterocervical angle more than 95 is definitely going to have a chance of preterm labor.
Okay, John, you have a view on that? It's not something that we measure.
Okay.
No, we don't measure, but one thing worries me a little bit about the transabdominal scan is that, as you know, if the fuller the bladder, the longer people will be making the cervix. And sometimes, it's not the cervix that measure, it's the lower part of the uterus being squashed by a full bladder. So as you know, now if someone gets a good view with a bladder like what you can see in your image, then I think transabdominally you can accept it. And some people will put values, if it's over 3.5, they think they say you don't need a transvaginal. But you've just got to be careful that are they measuring the cervix and not with one of these massively dilated bladders, someone's waiting and her time has gone on and on because of the person before that. So I think you've got to correct for that.
Yeah. Okay, that's an important point. So if you see this image in somebody where they're and this is a primate pet target, are you more concerned or less concerned? What are we seeing here? That is.
Here the film shows total cervical length looks normal, but the internal os and the upper 2/3 of the cervical canal is dilated, but the lower 1/3 is closed, and some debris is seen within the membrane.
Yeah.
So this is the transabdominal scan. I think so. This is a transabdominal scan, and you can have a transvaginal also to confirm the finding.
Yeah, so this is a transvaginal scan. And as you said, this portion of the cervix is the length, and this whole, there you can see the funneling, but you can also see some sludge here, and that probably increases the chances that there is some already ongoing inflammation. Therefore, in these women, if you take a cerclage, you need to be a little bit careful in terms, because if there's already an inflammatory process that's happening, even if you take a cerclage, there is a high chance that she may still either rupture membranes or go into labor because the inflammatory pathology is already active.
Could I just comment on that?
Sure, please.
One thing I would definitely, as a sonographer, want to look at is that can you see the shouldering on the posterior part? Is
Yes.
that the sign already of increased uterine activity, that you're actually starting to get some almost beaking, what we call a dynamic cervix? You've got the sludge. Now, you know, I've seen lots of cervices, obviously not looking like this, and sludge is not that uncommon. And I know Romero put it on the map, you know, was it 2 decades ago at least, where he was, you know, into this preterm labor, which was great. And he's done so much, he's had so much money to do these proteomics and genomics and who knows what. But I quite liked his principle of, in looking at preterm labor, the business of inflammation, infection, and sort of tocolysis type things, trying to separate them out, almost though they can all end up with the same endpoint. And as you know, his approach therefore would be, you know, antibacterial, anti-inflammatory, you know, these sort of, that concept. So I think from a scientific point of view, it's interesting. But sludge alone, I must say, you know, yeah, maybe, but I've seen it a lot in pretty benign cervices. Aware.
Okay. All right. Thank you.
And just one thing I can add, some people are being quite aggressive now. If they think there's inflammation there, if they're thinking of putting in stitches, of obviously doing an amnioflum, if they have the inflammatory markers, you know, they've got a lab that are going to do them for the, some people do extensive ones, some do more simple ones. And some are saying they feel that's a small risk to take when you're going to put it in especially rescues in patients. So that's coming in a bit more, but you need a good lab. Yes. You know, the lab have to be interested in doing it, and then you've got to audit it rather than, well, look, we'll give you what you like, but, you know, it's just another specimen.
Yeah. And the lab also, I mean, you also need a good microbiology lab when you're sending swabs. Very often when we send vaginal swabs, we really don't get back anything that's of great help. So it defeats. I think we're coming to the end of the time allotted to us, and I just wanted a quick comment on prevention for interventions, in how any of these interventions that we've discussed work in multiple pregnancies, because we know that they are at the higher risk for preterm labor, but unfortunately, none of the interventions seem to work as well in multiples, I mean in twins, as they do in singletons. However, it's pretty common practice here to see both a suture being put in automatically and progesterone being prescribed automatically. So can I have a quick comment on that from from all of you on what is your practice? And then
ma'am, usually for twin pregnancy, there is no role for a routine cervical assessment and no role for progesterone, because twins itself carries the risk. No interventions to reduce the risk.
All right.
What can do is we can correct the modifiable risk factors like drug abuse, cocaine practice, long-standing working hours. Only the modifiable high-risk factors we can look into for this patient. No progesterone, nothing.
So, I mean, I mean, depends on which study you look at. There is some data, controversial maybe, that in women with a twin pregnancy who have a cervix that's shorter than 15 mm, progesterone seems to have some benefit. John, can I have your views on that? And then
you're talking on just a scenario of 15 millimeters and progesterone or whatever. Is that what you said?
Yeah, I mean, unselected.
Or twins in general?
Twins in general, we said there isn't any intervention that's shown to be effective. But if we find a cervix that is short in a twin, would you be inclined to give progesterone or not?
Again, my answer would be the same as before. I don't think the progesterone alone is a powerful. It's supposed to just relax the uterus, and if 15 is normal, you'll get away with it. What I would be more interested in the change is how did that get there? Is it going to continue? And what are you going to do? Now, I just want to raise something that Ben Mole raised. He's raised it over the years. And he's questioned the old adage, well, first of all, obviously an elective suture in twins, no, I'm not into. And I think that that actually started being extrapolated, that a suture will never work in twins. The twins that we actually do suture are the ones that we are shown is shortening. And we're sitting there saying, well, we're going to have preterm or pre-viable deliveries. Is there anything we can do? And progesterone is definitely not the answer when you've got serial shortening. So we do stitches for those. In my monochorionic twins, in our area, all the monochorionic twins, because they're not that many versus the dichorionic, we offer 2 weekly surveillance for all the reasons you heard earlier. And we do that, in fact, for practical means. We're not saying it's got to be just, we want to be forewarned is forearmed. We get people with preterm labor from all over. And in New South Wales, if your nursery is full, you can end up miles away at some other nursery for false preterm labor. So we use the cervix to decide two things: whether you give steroids if they come in query preterm labor from these peripheral hospitals, and whether we would transfer them out of our tertiary hospital, even if they're packed full. And they've always got a cervical length from 2 weeks before, less than 2 weeks. So we say you don't get transferred anywhere. You come in, we measure your cervix. If it's the same, we think it's preterm labor, and we can watch no steroids, no think of mag sulfate, none of no tocolysis at all. So we use it in a practical sense.
Yes, I think that's a very important message. And as was mentioned, routine cerclage, actually there are a couple of studies where actually routine cerclage was shown to increase the chance of preterm birth in twins. But there is a subgroup of women with twins in whom cerclage will be beneficial, and that's the point that John has emphasized. So routine intervention in unselected twins is not shown to be beneficial, but we need to follow them up. And very definitely, when it is ART induced, I think prevention is better than any kind of intervention and treatment. And we should push for a single embryo transfer and to minimize the chance of multiple pregnancy. I think that is primary prevention, which is very, very, very important. So I think we are up to the 1 hour, and I just put this here to say that many of the interventions are not actually shown to be beneficial, but clearly there are the interventions that are useful, are the tocolysis primarily to ensure that we have time for steroid cover. Caution with the use of steroids, even though we know that it is beneficial for the neonate. We probably are looking at watch this space kind of situation with regard to the dosing, and clearly and to try and use it as close to the delivery as possible, because we know that it works best in that 1 week period of time. Avoid multiple doses and multiple courses. Magnesium sulfate, once you know that it's a preterm baby under 32 weeks that's likely to deliver. And I think the other strong message we got was the use of cervical length, both for identifying the woman who's at risk and how we use that to monitor her, to decide when she needs the intervention and when she needs transfer, and the value of screening for using the cervical length for screening. I didn't dwell on fibronectin simply because it's not available here, it would not make sense for the Indian audience to know about fibronectin. And we got some very, very good, clean messages about how we need to counsel these mothers and what the neonatal course is likely to be, and some strong data of what is the success possible in a good tertiary neonatal unit. So thank you all very much for being a wonderful panel and for all those clear messages. Thank you very much. And thank you, Vidya, once again. I hope we, delivered what you wanted us to. Thank you.
Thanks, Zuma. I thought very well chaired. Thank you.
Thank you. Thank you, ma'am. Thank you.
Thank you.
No words. You again proved yourself to the best moderator I have ever met.
There's one quick question in the chat box. Maybe one of you can take it. Maybe Naveen, if he is not yet left. what about the role of repeating magnesium sulfate if somebody threatens preterm labor and then doesn't deliver and comes back again? Is there any harm?
I think you already answered that, Uma, that most of these interventions may be done when you think that delivery is really imminent, and therefore this opportunity would be unusual, where you really gave a magnesium sulfate and then weeks have passed when a delivery wouldn't happen. Magnesium sulfate seems to be protective, but at the lowest gestations, maybe 30 weeks and below, that's where I think the World Health Organization recommendation stands. Some people are talking at 32 also, like you just mentioned. But I guess if you are monitoring carefully, the situation would be unusual. I think I'll ask Shamla ma'am, because if we're really in the obstetricians domain.
I think timing is everything, and we have very few interventions, and we need to hold our horses till we are very, very sure that that baby is going to need it. Okay, thank you very much. Over back to you.
Thank you.
The organizers.
Thank you, Doctor, and all the panelists. Sinu, you can take over. Share. Am
I audible? Thank you, Dr. Uma and esteemed panelists for the wonderful panel discussion. The few pearls which I've learned from this panel discussion that routine use of clutch for uncomplicated twins is not necessary. Nifedipine remains the first line of tocolysis. Cautious use of steroids in late preterm, and transvaginal scan is but most important for diagnosis of preterm labor. Moving on to the further in the session. Next talk is on intrauterine fetal demise evaluation and counseling by Dr. Vidya Lakshmi. As we all know, intrauterine fetal demise is a tragic and heartbreaking event. It remains the area in obstetrics in which further improvements are to be made. So for this session, I would like to invite Dr. Vidya Lakshmi. Dr. Vidya Lakshmi is working as a senior consultant in high-risk pregnancy and fetal medicine. She started the perinatal medicine unit in KIMS in 2009. She is a member of FRCOG, POGC, ISCOG, and SFM. She has many publications to her credit, and her areas of interest are maternal medical disorders. Over to you, ma'am.
Thank you, Sinu, for the kind words. Let me share my screen. Is my screen visible? Sinu, is my screen visible? Hello? Am I audible, Sinu?
Yeah, yes, ma'am. We can see you.
Okay, thank you. So good afternoon, everybody. And after this excellent session on panel on preterm labor, I'm really finding it difficult to take my talk, which is the death of the fetus. Though this is a reality, sometimes we have to accept and go ahead. These babies are born when the family has got lots of hopes in taking home a healthy fetus or a healthy baby. Sometimes we have to really break the bad news and take it further. So next 15-20 minutes, I'm going to take you through the journey of how best we can tackle the situation more emotionally and with care, so that the family grieve less and they come back to you next time. So stillbirth rate in India, as we all know, is lots of progress in the last decades. It has declined to 13 stillbirths per 1,000 live birth in 2019 from 29 in 2000. So you can see there's almost a 50% reduction in the number. So globally also the reduction has happened, but we'll still have a long way to go, because when you see the US and the UK data, it's about 3, but still we are hanging somewhere around 13 to 14. And Kerala being the best literacy rated women, and we now have reached a point when we have only 6 stillbirths per 1,000 live births. But the country being the, is my slide moving? Sorry. So just for the postgraduates, how do you calculate the stillbirth rate? It's the number of stillbirths during a year divided by the number of live births and stillbirths during the particular year in the 1000. So that is how you rate stillbirth. And there are a few ways you classify and how to analyze stillbirths. There are lots of classification, but of those, when I looked at this record classification was one of those which was reasonably good because it leaves less number of unclassified or unknown causes for IUFT because the rest of them had lots number of when you don't have a cause identified. So basically we all now are keen to use a record classification, which we all use in our institution too. How does that go? Oh, sorry. There is some problem in my, okay. That is how it goes. It takes the fetal, the cord, the placental, the liquor, the uterus, the mother, the intrapartum, the traumatic and unclassified things, and then you classify them accordingly from A, B, C, D, E, F, G, H, and I. I'm not going to go into the details of that. And definitely, as we mentioned in the last session, there are risk factors in every obstetric complication like that. You have risk factors for IUFD also, like when you look at the race, the non-Hispanic Black race, they have a higher risk, and nulliparity, advanced maternal age, and of course in young women also, morbidly obese women, pre-existing diabetes, those undetected or unknown type 1, type 2 diabetic women, chronic hypertension, which are not which are usually not treated well, where they have an end organ damage, especially smoking, drug abuse, alcohol, especially we think in our country we are safe, but not really. Assisted reproductive technology, because it increases the number of usage transferred, and sometimes we really don't know how many of them really do well. Unmarried status, you can ask why, maybe the emotional, the social aspects, past obstetric history, of course, multifetal gestation, and male sex. I was just pondering over the last night why male sex should be more. And I concluded and I gave an answer to myself saying that maybe the female has got more strength and they have to leave life to show what they can. Maybe that is why the males succumb earlier. Sorry for my male colleagues. And the current pregnancy, the risk can be of maternal age, as I already mentioned, the extremes of age, gestational age at stillbirth, the medical conditions which are complicating pregnancy, and obstetric cholestasis, which is really a passion for me because most of the time in our older college days, we were not really mentioning about cholestasis in pregnancy. But though it is a less number, if the bile acids are very high, we really don't know what is happening. The intrauterine fetal demise just happens, and we really don't know unless we do the particular markers to identify why this has happened. And the pregnancy weight gain and body mass index, and Dr. Nusrat is going to talk on how body mass index and all those things are going to affect adverse pregnancy outcome. Complications of multifetal gestation like twin-to-twin transmission. I'm not going to talk about specific disorders. Abruption placenta, preterm labor, gestational age at the onset of prenatal care, abnormalities which are seen in ultrasound, and infections of chorionic. These are all the other risk factors which are associated with intrauterine fetal demise. I need the help. I really don't know why my slides are moving. Just give me a second. I'm sorry for this. Okay. I'm really sorry for this. And fetal causes also, they are all they're updated in the list. They're congenital malformation, fetal hyperglycemia, hyperinsulinemia, cardiomyopathies, polycythemia, villus edemas. We used to talk in the earlier days about uncontrolled diabetes, growth restricted babies, macrosomic fetuses, prematurity, and antenatal intrapartum problems, and birth asphyxia, and what else. So all these things are in theory. What are we going to do when we really face this in the practical scenario? Very, very difficult. As an obstetrician, as a high-risk pregnancy specialist, I have faced this as a most challenging situation. When to tell the family that they have come with all hopes and that they are not going to do it well. So the whole concept of breaking this bad news to the family is very traumatic to us also. When we do a scan, we have done a scan 2 weeks back. She was at 28 weeks. She has come for a routine growth scan at 32 to 34 weeks just because somebody thought the abdomen is small or she had perceived less fetal movements. You put on the probe and see there's no cardiac activity. What do you do next? Very difficult. Sometimes the whole thing changes when the woman comes on her own. Sometimes there's a whole family with her finding to know what is going to happen next. So breaking the news is very, very important. And first of all, what we have to be is very empathetic and sympathetic. Here, I will use the term empathy. Usually, I don't use empathy in medicine because you have to be sympathetic, but not really empathetic, I tell. But this is one area where I really stress upon to being empathetic. And sometimes or always, I always get my colleague to come and check the fetal heart again, because even I'm shocked when I'm seeing that there is no fetal heart. So rather than just stepping up and saying that I'm not seeing the fetal heart there, you just tell the family that I'm seeing something different. Can I have my colleague to have another look? So one more person stepping in actually reassures the family that what you have said is right. And it gives more time for them to think that there's something going wrong. So it's really building up the scenario. So one more colleague seeing that there is no fetal heart, and we put the color Doppler and we have confirmed there's a fetal demise. So now we have to break the bad news. So how do you go about? And what we do in practice is what we have seen our teachers, what I've learned through my MRCOG exams and all my college days, where we were told how systematic you can approach the patient. So first of all, what you try to see is she's given the adequate support, that you don't throw the news to her on the couch, and you can get the partner or whoever has accompanied her to be with her to take the steps further. So I have done a second opinion. Now I know that there is an IUFT. So what next is I'm going to do? Ideally, you should have a proper setting. The woman should have this Spikes theory. I have borrowed from Uma Madam because I've heard her talking about the Spikes theory strategy long back. And the Spike strategy is usually used in the oncology setting when they break a bad news, but that can be used in settings of IUFD also. What does that mean? It's a setting. Setting is what? It should be very private. You cannot just divulge this news in front of everybody. There will be lots of women sitting in the antenatal OPD. You cannot just call and say that the fetal heart I'm not seeing. No, very, very sensitive. So it should be in a very personalized, private setting where you have to be very emotional with the family, just with them, the really close people whom the mother wants to be. The woman has a right to choose who's all going to be with her when you're going to break the news. And you can ask her, is there anything she wants to tell you that she has perceived less moments on the last 48 hours, but don't blame her for whatever she sees. And understand, try to find out what she knows about the loss of fetal heartbeat, and be empathetic. And but to her, just summarize, but tell her frank. At the end of the day, don't tell her that I'm not seeing the heartbeat well. Finally, you have to break the bad news that the fetus is not alive. So don't make it in a roundabout fashion. Be very factual, but be very sympathetic and empathetic when you talk to the family that the fetal heart is not seen there. And then comes the whole set of questions which you are going to ask us. Why did this happen? There are lots of things which we have in the literature. This is only for the postgraduates to just to brush up their theory. The family history of previous miscarriages, venous thromboembolism, congenital anomalies, hereditary and other syndromes, developmental delay, consanguinity, previous history of venous thromboembolism, diabetes type 1, type 2, chronic hypertension, thrombophilias, SLE, epilepsy, anemia, heart disease, everything under sun. Obstetric history, recurrent miscarriages, previous child with anomalies, previous gestational diabetes, hypertension, abruption, previous fetal demise. All those things can be in your checklist in the mind, but I'm not going to put those things to her at that point of time when she's sitting with me, holding my hand to say, what am I going to do next? So some maternal investigations which we can think about is a complete blood count, do a blood group and an antibody screen. Definitely a glycosylated hemoglobin if she is diabetic, because you can just honor your thoughts for the next pregnancy. Thyroid function, of course, but a reasonably controlled thyroid function of TSH of 8 and 9. Don't blame her or the thyroid for the IUFT because it's very, very rare. And Kleihor-Bethke test, of course, it's mandatory. And serology for TORC panel is definitely helpful, especially when you see the hydropic changes in the IUFT fetus. And the Role lab antibody, which definitely is part of the game. And the rest of the investigations, I'll just take with caution: karyotyping of parents, hemoglobin electrophoresis, and toxicology. All those things are based on the clinical situation of what happens to this particular case. Not through all the investigations which are aware to a particular woman, but you have to compartmentalize to see which woman deserves what all tests in the priority list. So this is all the RCOG, SEOG, SOGC gives. Toxicology is screen, but bile acids definitely I'm a little passionate to do because there is one cause of unexplained IUFT which we have seen. So bile acid definitely deserves mention in the list. Maternal bacteriology cultures, maybe a midstream urine and a vaginal swab, and that finishes the first line of investigations for me. And then fetal is very, very important. Why? Because most of the time what happens is when we tell them that the fetus is not there, then the call goes as what next, how to deliver, and that finishes. Because in a grieving mother, in a grieving situation, we are also afraid to tell them that we also feel that there is something wrong which has happened from our side. Have we done a less monitoring to this mother? Did something go wrong from the obstetrician side? We are also worried about the blame from the family, that usually they say everything was well until the last obstetric visit. The last scan was perfectly fine. So when we also counsel, we are also worried that when we talk about more investigation, the family is not going to be benefited, or they are going to get more angry. But when you put it in the proper frame, these 3 tests, of course, I'll put it the first 2, placental examination, the autopsy definitely deserves lots of merit in cases of IUFD, because they are the only 2 investigations which might throw light for us to take care of this woman in the subsequent pregnancy. Because even a bare placental examination can give us lots of added information compared to not doing any of these tests. And it is very difficult for us to put the word autopsy to a grieving mother. I do agree with you, but it should be a stepwise pattern, not like an exam where you put all the points together in the 13 minutes, but you have to go stepwise, make the mother feel that sometimes detailed examination can help. But I always hold the word postmortem or autopsy. I always say that the detailed examination can sometimes help, and wait for them to ask me what is the detailed test. Then I might give them the point, because it's very difficult for a grieving family to just take the word postmortem or autopsy, because for them, it is a very, very last resort for any human being. So very gently, you can put all these tests to the family. And ICT definitely we will do, and the glucose screening test, maybe interval, toxicology screen and sepsis screen as per the guidelines. And fetal karyotype definitely is, because when you use the fetal sample post-abortus, sometimes the catch-up rate to diagnose is very less, because the dead cells, they don't grow well. Some people think about doing an amniocentesis prior to expulsion, so that gives a better yield. But all those things have to be, said very, very politely to the family, because you're going to do another traumatic procedure to a mother, which is a needle, over and above the IUFD. So sometimes they may not be agreeing with that, but a detailed counseling always discuss with the primary obstetrician. So it should be a joint discussion with the primary obstetrician, the sonologist or the fetal medicine specialist, the family, if you want a social care supporter or whoever it is, and the team together, if you can put it. And step by step, you can add the investigations of the family, and they will also come to a point where they want to know. Until then, don't divulge all the scientific information which you have, which is not really the need of the hour for the family. So basically, this is the evaluation which I have told. The genetic testing goes up, antiphospholipid screening, and maternal parental karyotype goes after the delivery. So look for any suspected fetal anomaly after the baby is born, and look for fetomaterial hemorrhage. The pre-for birth care test definitely stands up there. And all the tests which I am mentioning here goes much beyond the list after the patient has been delivered and taken care of. So autopsy and placental study definitely should be offered. It provides information directly, and histological tests, if they decline autopsy, at least do histology of the placenta so that we have some clue. And restricted autopsy, of course, is, or a minimally invasive autopsy. And that can be discussed with the family, because sometimes they're worried about mutilating their own baby. And one more thing which I always want to tell the juniors, that never use the term IUFD mother. When you call the labor ward and ask what has happened to the particular patient, you should never ignore and say that IUFD mother. No, she is not an IUFD mother. She has got to label her own name. And the IUFD is not something which she wanted, which is thrown upon her by fate. So be very, very gentle, keep dignity on her, and never mention that the IUD baby or the fetus. And this patient should receive all the care which you give to another laboring mother in the labor ward. So she is going through a very traumatic time, and we have to acknowledge that. And I have always seen even our postgraduate days, and even now, when we ask them what happened, when did you feel the last baby moving, she will say 2 days back. Immediately in front of the mother-in-law, somebody will jump up and say, oh, exactly, that was the reason. We have told you several times to report immediately when you have less moments. So that kills the whole morale, and the family really bursts on her. Believe me, no mother in this world would like to kill her baby in the utero. So if she has not pursued, she has not pursued. So this is not the time to blame her, saying that If you had come last night, no fetus was saved because somebody has come the night before, because that was supposed to happen, and that would have happened already, and she would have just perceived the movement of the fetus which is going through the amniotic fluid, not the real fetal movement. So this is not the time to make sure that you are winning over her, to make clear that you are medico-legally safe. No, this is not the right time to do that. That is definitely needed in a subsequent time. And when you are very honest with her, she will take all your calls. Be with her, make her feel that you're also worried about what has happened to her. So then we'll come up and ask what can be done for the next pregnancy. Then you can put her the factual points and start counseling her. Karyotype, I have already told. Amniocentesis before delivery increases the yield, which is about 85 versus 30%, but sometimes it is very difficult. What will you do? Microarray is definitely the best test of choice because it can be grown in the cultured cells, even if it is not you don't need dividing cells, but it is very costly. And most of the time you have heard Sujata madam that microarray is not the first line of test. You may even have to do a conventional karyotype. So what we do in our institute is we do a detailed maternal history, check the fetal weight, height, and all those things. And when you are concerned with the sex, when you are not clear about the sex, please make sure that you don't jump up and say male or female, because some families have trauma on that also. They were expecting a male child and the male child has gone. So unless you're sure about the sex, so don't divulge that. And photographs of the fetus and the placenta, which I will keep as a background thing, because this is one thing which most of our women in India, they don't ask for, but definitely I've seen this happening in Australia, where they really want the memento of the baby. They want the footprints, the handprints, the photographs, and the clothes used, and all those things they cherish as memory. They even keep albums for this bereavement period. And but in India, whatever I think is possible is, if there is a consent from the family, we can at least have a photograph to be stored, because she might come back and ask you in a later date that, can I see my baby? Because when the baby is born, most of the time what happens is the mother-in-law will say, don't show her the baby. I don't want her to see, and get upset, the mother will say. And she is never given the opportunity of even seeing her baby who's being, not being with her. So at least if the family consents, you can keep a photograph for her. If she comes back and asks, can I see my baby, you can show that and document all the findings and autopsy as per consent. So a fetal death that cannot be attributed to whatever big list I have given you before, a fetal, placental, maternal, obstetric etiology, and that can be classified as unexplained or still unexplained stillbirth. And that is a major chunk of stillbirth. If you look at it, it's come to about 25 to 50%. So that puts us in deep trouble when she comes back next time about what to do next. Bereavement care, which I thought I'll put 2-3 slides here, because this is some area which we really neglect in our country, because we assume that is taken care of by the family, but not always. Even if you're writing your college exams, you need to know more about this bereavement care. And definitely, I don't think it is only for your college exams. As a good human being, as a good doctor, this is part of your obstetric management. A demise of a fetus is a highly distressing event. It is like losing a family member. It's not just like you have not seen that baby, you can just leave it there. No, it is just like you're losing a family member. It affects your life from all parts: mental, physical, social, financial, all those things. Healing with care, compassion, and commitment is at most important, because we cannot play a blame game here saying that, as I already mentioned, please refer every pregnancy as a baby. Don't say, because don't say that that unborn fetus. And sometimes we have really seen incidences when the babies were put in the bucket and then shown to the couple. These are the most disrespectful things which we can see. The baby should be dressed up like a normal newborn baby, and then only you think that family can visualize the baby. And it's really, really traumatic, and we cannot add on to her trauma by mentioning such things. And especially when you're monitoring the same baby, same mother in the labor ward, where you're having the other mothers who are having normal fetuses. Sometimes what happens is there's some new person can join. I have seen this during my postgraduate days, when the new batch comes up, the over was not complete. They just come and try to auscultate, and then they say, I'm not hearing the fetal. Then the mother has to tell her that, no, it's not there. I've lost my baby inside the uterus. So a proper counseling and a proper handover. We do hours of handover about preeclampsia in the labor ward, but a little more time should be spent on counseling and handing over these mothers to the next carer, because we can inadvertently hurt her several times before she leaves the labor ward. So she goes through a cycle of acceptance, Then comes the anger, like any other family loss. Then she will shout, scream at you, why did this happen? Actually, she will ask you why this happened, and I have done everything possible in life. I have come to you all the visits, whatever you told me, doctor, I have done. You told me 100 investigations, you told me 100 scans, I have gone through that. Then in spite of that, why did this happen? If you don't have an answer, be polite, tell her that I really don't know an answer at this point of time. I am also really worried like you, but let us try sort it out. We can only hold her hand and wait for the time to give us an answer. And the denial is the next step. She says, no, it is not there. I felt the baby moving. Can I have another scan? Please don't retort saying that I have done this. I'm the biggest person in the country. I know how to scan. Tell her that I'm really sorry. I'll just do it again. Let me have my colleague on board to see it again and document. And then she goes in the real phase of depression and grief, where God alone knows when she comes back to life. So we have to be very, very careful in dealing with it. And this is one thing which I'll just skip through. This is thermometer, breathing thermometer. I just wanted to show. So then you have to plan delivery. Now she will ask, okay, doc, LM, all is over. I know my fate is like this. What next? So don't jump on saying that I want to admit you today. I want to deliver you. Just tell her that it's up to you. Nothing is lost. You're not going to get injured unless the woman has got your visible signs of infection like chorioamnionitis, severe preeclampsia, abruptio placenta, or a membrane which is formed. We don't have to really rush through. We don't have to really rush through delivering her. So tell her that it is up to you. If you want to go home, come back. We are okay for that, and we can wait. But our choice will be to give you a vaginal delivery, because giving you another scar doesn't help us. But sometimes they tell you that I don't want to go through the trauma of laboring again. But still, don't stress on that moment. You just give her some more time. Tell her that even with that, maybe you can have a good vaginal delivery. We can give you pain relief, because she doesn't want to go through that trauma of pain again to deliver. So we can tell her that we can give you adequate pain relief. We can take care of you in a different fashion, but don't take your call then. And do we do all the investigations again? No. If she's going to wait, maybe we'll do a coagulation profile and see, because immediately on the next day or the third day, she's not going to go in for coagulopathy, which we all know. So definitely vaginal route is recommended. So this woman has now gone home. When she is discharged, another thing which I want to tell everybody, and especially postgraduates, that be very clear in the discharge summary. Sometimes even whatever I'm saying is, I have seen with my own experiences, when the patient just comes the next time, somebody has just scribbled FTND with RMLE. It's just a casual thing which we all are used to do. And this woman comes to the OP and somebody reads out FTND on such and such date. Then again, she says that no, it was not a normal delivery. I didn't have a normal delivery. Somewhere in the discharge summary down the line, you would have written that the baby was born dead and all. But make sure that when you make the discharge summary, it's signed and by a senior consultant, and somebody has owned the responsibility of that summary, because it takes a long way for the family to accept. And even medico-legally, all the words which you put in the summary makes a lot of difference. So when you make a discharge summary, and you don't have to put everything in the discharge summary, but in the EMR or whatever file you have, you should have mentioned what is the plan which you're making for her. So, discharge her, lactation suppression, yes or no, there's a tick mark. You don't want her to come back with a breast engorgement and then sit on your OP to cry on that. So lactation suppression, did I talk to her? What is the next thing when you want to see her again? Do you want to see her in your routine postnatal clinic when the mothers are walking with babies, which is very traumatic? So you can really schedule your appointment with her in a reasonably time frame, and you are also little free to talk with her, because in a routine OP when she walks in, again, it doesn't make any sense. So pre-pregnancy, if you get her, definitely detailed medical evaluation, and then you work up for the APLA and all those things. And genetic counseling, if at all you need anything, systematic, you have to look at her thrombophilia screening and all those. Hemoglobin A1C, early booking in the first trimester, ultrasonography, of course, yes. First trimester is universal now. You look for the uterine artery Dopplers and your first trimester screening. And always, always, and all visits reassure her that she can do it, she can do it, and she can do it. And second trimester, as any other patient, but definitely she should have a targeted scan at 18-20 weeks. If there's a genetic screening, then you have to do it again. And support and reassurance, again, I have put it in all the slides, because it is, I always feel that mantra of all the high-risk women who meet me every day for the last 13 years. The first visit, when they have lost even 8 babies, I'm only going to be a tool. If I am successful doing, and the mantra is that you can do it. If anybody in the world can do, you can do it. And the mantra is she can do it. So support her and don't say that I'm going to take care of you well. No, she can do it well. So that reassurance will take her a long way through that pregnancy. And sonographic screening for growth restriction from 28 weeks. And a more tight antepartum surveillance from 32 weeks, definitely. And maybe weekly I will see them, but not scan. If there is growth restriction, maybe every 2 weeks or so, but definitely weekly she can come up. That's for a more emotional aspect for the mother, that things are being taken care of. Delivery planned at 39 weeks. I don't leave her past date because that is distressing for us also. If it is severe for patient anxiety, she says that I don't want to touch my 40 weeks or 39 weeks. Around about 38 plus is reasonable. When you have a recurrent stillbirth risk, and such decisions are to be taken up along the whole team, especially when I have a woman who had a previous intrahepatic cholestasis and had succumbed the baby. Definitely this time, if she has cholestasis of pregnancy, I'll definitely think about delivering at 37. And so on, it is individualized actually. So it's a very emotional area, and I'm a very emotional fetal specialist. So I thought I will choose this area to talk before you, how a mother who has lost everything in pregnancy is her baby to be taken care of it. Thank you.
Thank you, ma'am, for your amazing presentation and clearing your doubts on a sensitive issue. Things which I've learned are always break the news with spike strategy. Investigation should be targeted as per the medical situation. Autopsy and placental study should be offered to all, and bereavement care should be practiced by all. Thank you, ma'am. So moving on, next talk on our session is maternal obesity and adverse pregnancy outcome. As we all know, maternal obesity can result in unfavorable outcomes for the mother and the fetus. So for this, we welcome Dr. Nusrat. Sorry, ma'am, we have to wait. We outshooted the time. So over to you, ma'am. Can we have ma'am CV? Dr. Nusrat, it's my honor to welcome Dr. Nusrat for this session. She is consultant in Fernandez Hospital, Hyderabad, and Vice President of Silver Society of India. She has numerous publications and awards to her credit. She is member of many renowned committees, and she is currently working on projects like COVID protocols, Prevent Study Gap Project, Customized Fetal Growth Charts, and so on. Over to you, ma'am.
A big thank you, and a very good afternoon to each one of you. Thank you so much for the invitation, Dr. Vidya and Nina. It is a privilege to be a part of you. I don't know where my screen, I have to redo it again, I suppose. Okay. All right, so over the next few minutes, Vidya has given me the topic maternal obesity and adverse pregnancy outcomes. And I thought I will attach a word morbid obesity because 30 BMI looks very slim these days. So the problem starts with 40 BMI and onwards. Why do we need to talk about it? It is a silent pandemic. We need to have specific points in the antenatal care. There are adverse outcomes. We need to optimize our hospital setup, and we need to plan and make it much more safer for this woman who conceive with difficulty and go through pregnancy with difficulty. The first prenatal visit, height and weight, is used to calculate the body mass index, and this is used as an index for the recommendation that we would follow throughout the pregnancy. And I am going to refer a lot to the latest ACOG practice guideline that has come in June 2021, and in addition to the RCOG1. What is the incidence of obesity that we have right now? At Fernandez Hospital, 2021 data, we are 21.4%. But if you take a look at morbid obesity more than 40, we have 1%, and we had 4 women with BMI 40. Just taking you back 10 years ago, we had published this paper where we wanted to use the revised guidelines for Asian Indians. They said 25 and above BMI should be used to categorize as obesity. And if we use that, we would suddenly be categorizing 43% of our population when the percentage was 11% about 10 years ago. So very different categorization would result. What has happened to obesity over the last 10 years? We were seeing about 1,300 women, and now we're seeing more than 20,000 women, or 2,000. I'm using the poster that was presented by one of our consultant colleagues, Dr. Shailaja, and super obesity, BMI 50 and more, and the data set was 22,000, and the max BMI was 80 that we have had till now. She was looked after by a consultant colleague of ours, but I was given the privilege to operate for her. And this was the woman. She was 33 years of age. Booking weight was 168 and 79 with multiple pre-existing medical disorders. How would we manage such a woman? And here comes the concept of Healthy Mothers Clinic. I was privileged to be a part or attend the clinic that was run by Professor Justin Conji in Leicester. And at some point, as these numbers increase, we too would really benefit from having one clinic a week, which would cater to, let's say, BMI 40 and above. They would be so much comfortable to have people of similar kind around them. Now, I'm going to use this data set to keep visiting the numbers or the incidences of the disorders. Medical diseases, if you take a look, 1.2% diabetes moving over to 5.7 to 13% as we go from one weight category to the other. And so also chronic hypertension. How do we help when we find multiple problems in a single woman? Okay, list out your risk factors, put a template for each disorder or the common disorders you have, not more than 10 or 15 you would have, and put them one below the other and start checking out. And it will also help your team to make sure that they don't mess it up. The first thought that comes in is what kind of a weight gain we should have. And the concept of restricted weight gain comes from the IOM guidelines, 5 to 9 kgs. It has been shown to have benefits on cesarean section rates, on the LGA rates, as well as on the postpartum, that is extra weight that she has. Decrease in weight during pregnancy has been found to be associated with SGA, but less weight gain, that is not up to the recommendation, was not found to have any adverse outcomes. What's very important for all of us to remember is screen for these conditions: obstructive sleep apnea, cardiac dysfunction, mental health issues, and also VTE scoring. It's also very important that we get the anesthesia and the critical care teams very early because they have a high incidence of hypoxia and sudden death, maternal morbidity, and mortality. Now, moving across to putting up a plan for antenatal screening, is it different? Almost every screening plan has BMI as a variable in it, whether it's a GDM or low-dose aspirin prophylaxis or vitamin D supplementation or VTE risk factor. Anesthesia review is mandatory if the BMI is more than 40, or it might be an SGA screening, unreliable symphysis fundal height. At this point, we need to counsel about aneuploidy as well as anomalies, that it is difficult for anomalies, and for NIPT, you have a higher failure rate. Now, going across from here to pregnancy complications, we found that the incidence of preeclampsia and gestational diabetes increases. If you take a look, 6 to 25% to 40% in the super obese. Gestational diabetes is also similar. Preterm birth was also found to be higher, but ICU admissions, because these numbers are very small, maybe 22,000 data set only, and that's why. But the literature tells you that there is a higher incidence. Now, moving from there across to the fetal outcomes, higher rates of miscarriages, higher rates of recurrent miscarriages, anomalies are known to be high. But we have to tell them and counsel that there are limitations of ultrasound. I'm sure all of us who have worked with these women, we find it extremely difficult sometimes to even hear the heartbeat in the antenatal OP. Then you take them again and again to the ultrasound to check the fetal heart, and you find that the depth of the abdominal wall is so huge that you have to search for the fetal heart sometimes. So I really admire the fetal medicine colleagues who are able to do an anomaly scan. The other fetal outcomes that are very often coexisting with obesity is LGA. These, they have large babies, and 7.3 to 20% and across the spectrum. And ICU admissions was found to be higher. We did not find low APGAR rates and neonatal deaths and stillbirths to be higher because, again, the numbers were smaller. But if we take a look at the literature, the hazard ratio for the stillbirth was found to increase from 1 to 2, 2.4, and 3.1. But very important for all of us clinicians is to know that as super obese come to 40 weeks, the increase is 8 times chances of stillbirth. When they come to 41 weeks, is 13-fold increase. So it is suggested that we don't cross 40 weeks for these women. Now, the recommendations for antepartum fetal surveillance did not come from any other guideline, but for the first time have been put up over here. For BMI 40 and above, weekly antepartum fetal surveillance after 34 weeks. For BMI 35 to 40, then after 37 weeks. Now, we all use fetal growth surveillance every 3 to 4 weeks for detecting SGA or LGA or fetal growth disorders. We have been using the customized percentiles, and we are at present dealing with extremes of weight. This woman, she was always LGA, but if we just change her weight and maintaining the height is the same and put it up, the centiles are very different for this woman when compared to another person with a normal weight. Is labor different? Of course it is. Labor is different. You want to induce these labors, it doesn't work. When they come in spontaneous labor, they don't progress. For some reason, you find it very difficult, and they have a very high C-section rate. What was the incidence of C-section in our series? 22% for the normal population, 46 for 40 BMI to 50, and 75% for 50 BMI and above. Anal sphincter injury is less because of less vaginal deliveries. PPH in our series, we did not find it, but literature tells you that it has a higher incidence, especially in a vaginal birth. Surgical site infections, we found 0.5% in the normal weight category, 5 times more to 2.5%, but 10 times more when we come to super obesity. Now, this is a nice mnemonic, taking it from the Critical Care Obstetrics by Michael Foley. It's for the postgraduates. Obesity is the mnemonic, and you can put it up and write down a plan, especially when you are admitting her and want to have kind of an algorithm. The intrapartum care is very important because you have special needs. Especially just check what is the weight bearing capacity of the bed that is there in the labor ward. The stirrups are also very important. And doing a vaginal examination, Foley's catheter assisted vaginal delivery is very difficult sometimes. So early IV access, early epidural, BP cuff, sometimes you'll find it difficult. Sometimes the NST belts are not enough for you, and fetal monitoring cannot be done without a scalp electrode. External probes are just not optimal for these women. Sometimes you wonder when you are trying for a vaginal birth, should I have done a planned elective cesarean section? It has been found to be of no help for reducing morbidity and mortality. Now, if we talk about a cesarean section, 2 important things that we need to remember is the weight bearing capacity of the table. One of the tables collapsed and started oozing out all the oil in it. So you can combine 2 tables together, and also make sure that positioning of the woman is important, and it takes time. So doing a crash cesarean section in these obese women for bradycardia is extremely dicey. I remember doing a 45 BMI lady with a ruptured uterus, and just went in without looking at what I was doing, and very dangerous for the mother, even though we are trying to salvage the baby. Now, where does the difficulty come in? The difficulty comes in because of the panis, and it comes in when it is grade 3, 4, and 5. The apron covering the upper thigh, middle thigh, and almost the entire thigh. What happens is when the panis enlarges, it drags the umbilicus position to the level of the symphysis pubis. And this is the one which we should always keep it in mind, make them stand erect and see where is the anterior superior iliac spine, where the level of the umbilicus is, and then plan your incision. Always examine under the panis, because we have found ulcerated lesions under the panis, infection over there, very difficult to operate in an infected way. Traditionally, we have been using ways to pull up the panis, and sometimes asking our assistants, and their hands hurt most of the times when we are using their the strength to pull up the panis. And the Montgomery strap can be used, but whatever said, pulling up the panis, we found in our series to have a very high incidence of scar dehiscence, and a lot of time, maybe months together. Remember one lady staying with us for a month till granulation tissue came in because of the depth of the wound that we have. The main problem with panis retraction is the pressure necrosis and the hypoxic necrosis that occurs. This is a woman who took about 2 months for us, had multiple surgeries and ultimately went home. How do we overcome this is by leaving the panis in place and taking an incision above the pannus. Now, if you this is one absolutely brilliant images that they have given. They are showing you where the position of the pelvis and the baby is, and in the lateral side, you can see umbilicus and the symphysis pubis. So one time we went in from below and couldn't deliver the baby for a 60 BMI and delivered an asphyxiated baby just because we were not able to get it out. Cephalic presentation. So if we go this way and then reach it over there, our ability to retract, your hand goes in right up till the elbows. Yes, I agree, I'm a short person, but still it is very difficult to get the baby out. Now, what they are showing here is after the incision is closed, the level of the incision is at the level of the anterior superior iliac spine and the abdominal binder. Make sure that you get the abdominal binder beforehand to offer support. Our preference has been sub or supraumbilical transverse incision for BMI 45 and above, and not always, but depending on the pannus. And how do you differentiate? Look at the level of the umbilicus and then go through. Another important aspect that you should remember is having a self-retaining retractor. Alex's retractor is one essential instrument. I think I would find it very difficult if this is not there. Currently, it's not available. We are using Surgisleeve. Not as good as this, but an absolutely brilliant innovation. Whoever designed it, and nothing, just a plastic kind of a film between two rings, one softer ring and one firm ring, and somebody should devise it. Maybe a reusable kind of a retractor should be there. It's a little costly, but allows access to the lower uterine segment and very comfortably. People have asked, is it possible for you to do the delivery of the baby through a small opening like this? It's not small. It's just evenly distribution of retraction, and that's why it's looking like that. And if you just stretch it side by side, you would find that it would open up to the level of the incision. So I'm just, many people have told me the curiosity, can you apply a forceps to this and do a delivery? I'm just going to wait till the baby is delivered. But it doesn't retract the abdominal contents, but brilliant for the abdominal wall retraction. And if the demand increases, I'm sure they would supply it back to India. Maybe a promotional kind of a video also over here. I love the Alex's retractor, and people should try to get it back to India and make sure that we have it. The rest of the steps is the same as that of the other. The use of this retractor for the lower flap is not necessary, but sometimes if the lower uterine segment is, you are having difficulty in seeing it, and then you can use it the same way as you use it for a cesarean section. And I am just sucking it out, because when you do a QBL or blood loss estimation by weight, this amniotic fluid adds in and gives you a very wrong estimation of blood loss. So it's always better to suck it out completely before going in and having a baby delivery. Also minimizes the amount of mess that you have, on the floor or on your feet and so on. So very easy to apply and very easy to deliver the baby with forceps, not difficult at all. It stretches and allows the baby to come out, and no problems, absolutely. So use it and see, it is indeed very comfortable to do that. How do you remove it? You just catch hold of the inner ring, which is there, and pull it out. So not difficult as far as application and removal is concerned. The rectus closer, a very secure way of suturing would be a Smith-Jones suture. It's nothing but your similar way, but except that the first one is 1 centimeter away, outside, and then to make the edges come together, we are doing an inside at 0.5 centimeters, a very comfortable way of suturing. Prevention of infection is a major issue over here. So if the weight is more than 120 kgs, cefazolin 3 grams IV stat, or if you're using any other drug, you have to account for the extra weight. Minimize tissue trauma, closure of the subcutaneous space, skin with interrupted sutures. Drains have no benefit, and I have a different take personally on this. Sometimes when you enter into this, the oozing is so much that you have to mop that extra fluid that keeps coming out of that edematous panis that I prefer to put in a drain and remove it once the drain. 50 ml of serous or serum of formation would be less. Very good results. You send her home on day 3 or day 4 and call her back on day 10 to have, this does not require a lot of abdominal wall support. Now, moving across to the post-operative time period, antibiotics, analgesics, etc. But VTE thromboprophylaxis, the current guideline states that instead of having a class 3 and class 4 and so on, it's better to have BMI 40 to 60 as enoxaparin, 40 milligram twice daily, and BMI 60 and above. And 60 BMI would definitely mean 150 kgs and 60 milligram twice daily. Dressing removed after 24 hours and suture removal on 10th post-op day. Now, what happened to the lady? She had a cesarean section, 3.75 kg. Even though she's 4'9", no post-op complications, went home very comfortable. It would be incomplete if we left this woman at this point of time. We have to look after her post-delivery management, and we have to keep reminding ourselves as well as our colleagues that the only parameter or the most important factor that is responsible for changing pregnancy outcome is weight. If you have a normal weight, then your outcomes are so much better. If you are able to reduce your weight and prevent pregnancy, that would be the best thing that you can do. And obesity is becoming a pandemic, and each one of us has an obligation because it is something that occurs day to day on a home basis, on every interaction. We have to stop this pandemic of obesity. Thank you so much, Dr. Vidya, once again, and I hope I did justice to the time that was given to me. Thank you.
Thank you so much, Dr. Nosat. You did a lot more than what we expected as you term justice, because it was amazing to hear you for the last 20 minutes, which I will agree with any delegate here will agree upon that. Simply beautiful.
Thank you.
You can take the questions in the chat box if you have. I have one question to you, Dr. Nosat. Do you routinely recommend low-dose aspirin for these women when they come for the walk-in visit?
The risk categorization or scoring for low-dose aspirin, more than 35 is a moderate risk factor, more than 40 is a high risk factor. So depending on that, we would be writing it down. So we follow the RCOG guideline or the NICE guideline.
Okay. And do you think delivering them slightly early to term helps reduce the risk of IUFTs? Or
most of them will have medical disorders which will make you deliver early. I don't think you will have a woman who does not develop hypertension, diabetes, or does not have pre-existing. Most of them, you won't go to beyond 40 weeks, but the recommendation is 40 weeks, not beyond 40 weeks.
Thank you.
That's
Vidyalakshmi ma'am, there are two questions for you. First question is, unexplained intrauterine pituitary is ruled out all identifiable causes. How to monitor next pregnancy?
I think I have addressed that. The next pregnancy, before you classify, see, most of the time when we say unexplained, we really are not justifying ourselves. When you go by the proper pathway, most of the time you'll be able to get from the history, the labs or whatever has gone wrong. You can get a little more than what you call as unexplained. So try to get those extra information before you label her as unexplained. If finally, if every cause is ruled out, definitely she goes through the universal screening for any other high-risk pregnancy. Cessation of smoking, starting folic acid pre-pregnancy, optimizing her body weight, as Dr. Nosat has already mentioned, titrate her sugars if she is diabetic, and then take her pregnancy as any other high-risk pregnancy, do a screening, first trimester combined screening with the uterine artery Doppler, and add echosprin if is needed, and a detailed targeted scan at 18 to 20 weeks. And definitely, I do one more step ahead. I do a fetal echo at 22 weeks, which was previously unexplained, and there is no autopsy to prove that there's a cardiac disease. So then serial growth scans to look for the Leica Doppler and reassuring the mother, and deliver her at around 30 to 39 weeks. That's what we follow.
Okay, ma'am. One more question, ma'am. How to monitor development of coagulopathy if a mother opts to wait for spontaneous expulsion?
Yes, good question. See, we can't push her to the process of delivery. It's more, the coagulopathy is more often theoretical than practical, which we know. because this fetus is not going to induce, but definitely immediately when you diagnose UFT, we do a coagulation profile. And there is no harm in waiting because most often they get into spontaneous labor. If not, I will try to bring her back every 3rd to 4th day to reassess her clinically and definitely monitor the coagulation profile weekly, at least weekly.
Thank you, ma'am. Next question is to Nusrat ma'am. Do you advise abdominoplasty during cesarean section in morbid obesity?
No, should not be done because it's a different abdominal wall she would be having. And let me tell you, the morbidity of doing an abdominoplasty with so much of edema, so much of gestational weight gain, haven't seen a woman coming out of it without infection. So I would hold it on, wait for her to settle down, and maybe if she wants to consider bariatric surgery would be much more better when we talk about morbidly obese of this category.
And postnatal thromboprophylaxis, can you just touch upon that? Do you routinely want them to?
Right, we usually give it 7 days, and 7 to 10 days is our recommendation. And like I said, weight-based, because when we come to this weight of BMI 50, then the weight ultimately, will be 120, 130, 140, 150. So instead of using 60 milligram once daily, which wouldn't be sufficient for it, you will have to go for these weight-based thromboprophylaxis or enoxaparin. Would you give them prior to the cesarean section if they are admitted in the hospital? But otherwise, we won't give them as a routine. But mechanical compression stockings and so on, getting them as early as possible is something that what we would do. But depending on low molecular weight apparent would be our main prong. Continuing it for 10 days would be our prong. That's.
We don't have any further questions, so we'll move further. Thank you, Nusrat ma'am, for extremely informative and interesting presentation. And thank you, Vidya ma'am, for a presentation. So moving further, next part of the CME is a talk on fetal origin of adult diseases based on COAD hypothesis, which holds that events during early development have a prolonged impact on one's risk for development of future adult disease. So for this presentation, I'll invite Dr. Jayashree Gopal. Can we have CV of Dr. Jayashree? She is Director of Diabetes India, Chennai. She is Senior Consultant, Apollo Hospital, Associate Dean of MV Diabetes Center. She is recipient of Vocational Excellence Award and Dr. Sam GP Moses Oration. Over to you, ma'am.
Thank you very much. I'm just going to start sharing my. Can you see my slide? Sorry, I don't know if I've shared the right screen. One minute. Yeah, can you see my presentation?
Yeah.
Okay, thank you. Let's put it up on the slide. Yeah, is it full screen now?
Yeah.
Okay, thank you. Thank you very much. And like was mentioned, I'll be talking today about the fetal origins of adult disease. I'm an endocrinologist. My interest or my take in it is obviously predominantly to do with sort of metabolic diseases, but as I shall show you, what the studies and the bulk of the literature so far has shown, it is not only metabolic, but a lot of the diseases of adulthood can be linked to events that occur in and around the time of development of the fetus. So the basic background is that the events that occur during early fetal development have a significant impact upon adult health. And very many studies have shown, and I'll share some of these studies, have shown that there is a definite link between intrauterine fetal stressors and the development of adult diseases. And these fetal stressors include not only the maternal nutritional status. We had an excellent talk on maternal obesity previously. So both maternal under and overnutrition, but also hypoxia, things like exposure to alcohol and smoking during pregnancy, even exposure to maternal trauma, violence. So if the mother is exposed to violence and stress during pregnancy, all this also plays a role in impacting upon the baby's future health. So one of the ways it's supposed to, for example, act, this is a very simplistic view of the whole thing, but one of the theories is that when there is maternal undernutrition, the fetus gets prepared for scarcity after birth. So that the fetus is programmed to think that it is going to be exposed to the similar amount of undernutrition even after birth. However, if it is exposed to excess, abundance, it will develop obesity and diabetes. And this is the so-called thrifty hypothesis, where it is believed that certain genes that help us survive during thrifty times, we do not do so well when we are exposed to abundance after birth, abundant nutrition after birth. So this is one of the theories of developmental programming. A lot of this theory around developmental programming and fetal origins of adult disease can go back to this original paper by Dr. Barker from the UK. This was published in 1995. And what he showed was that the lower the birth weight in children, the higher the risk of developing diabetes or impaired glucose tolerance 60 years later. So this was a cohort that was followed up for a long period of time, and they correlated the events that occurred at the age of 60 years with their birth weight. And what you can see here is that the lower the birth weight. So in this, the birth weight, they used a birth weight of above around 4 as the baseline, 4.3 grams as the baseline. And if they kept the risk of diabetes for that, and we would consider this as a high birth weight for our sort of milieu. But in the UK, this is considered, this was kept as 1. And compared to that, a child that was born with a birth weight of less than 2.5 grams, 2.5 kilograms, had a 6-fold higher risk of developing diabetes or impaired glucose tolerance. And it was a gradated increase. So every sort of reduction in gram and birth weight was associated with a much higher risk of developing diabetes later on in life. The same paper also showed that not only is being born underweight a problem, but also if the weight gain, so the weight at the end of 1 year, also predicted the risk of dying from a heart attack later on in life. So the failure of infant growth is also highly predictive of coronary artery disease in men. Again, if they looked at the weight at the end of 1 year, if you had gained sufficient amount of weight, so the ones that were born well and gained a sufficient amount of weight had a much lower risk of dying from coronary artery disease as an adult. Whereas the children that remained low birth weight, they were born low birth weight, but also failed to gain weight during the first year of life, had a higher chance of dying from coronary disease, though this association was not as strong as was seen for the diabetes and impaired glucose tolerance. So this was the origin of all of this developmental programming. A more recent study, which was published in the US, was the so-called EPOC study. And this has been referenced several times in the literature, where they compared 42 IUGR children compared with 400, roughly about 450 normal growth children. And infants born IUGR in this group actually had catch-up growth in the first year of life. So after the first year of life, there was actually no difference between the two groups of children. There was no difference in terms of their growth rates or their birth weights. However, the children that had been born IUGR at the age of 6 years and older in adolescence were shown to have higher waist circumference, higher insulin, and higher markers of insulin resistance, including a lower adiponectin level. So all of this was correlated with being born IUGR, even though after 1 year they had good catch-up growth and they continued to grow well. That period of exposure to IUGR seemed to have an impact upon their health as an adolescent, independent of other childhood and other maternal nutritional risk factors. So this was another sort of corroborating evidence. Another huge piece of data that is again referenced quite often is what is called the Dutch data. So this was a large group of Dutch adults who were exposed to a significant amount of famine for 7 months during World War II. And at this point in time, for the 7 months, these adults only consume 25% of their recommended caloric intake. And what they showed was that the pregnant women among these, the offspring of the pregnant women who are exposed to the significant famine, those offspring had a much higher incidence of cardiovascular disease, diabetes, and also other mood and personality disorders as adults. And it also seemed to make a difference as to when these pregnant women were exposed to the caloric restriction. If it happened in mid-gestation, interestingly, there was a higher incidence of bronchitis, renal disease, and hypertension. So exposure to maternal undernutrition in mid-gestation seems to be associated with lesser number of nephrons developing and later higher development of hypertension. So this was another sort of big piece of data that further adds the evidence to this developmental programming origins. Like I mentioned earlier, it is not only about maternal nutrition that it may impact. There are other intrauterine stressors. Of course, the severe undernutrition in pregnancy, the Dutch data, it is believed that what happens is there is preferential growth of the brain and the heart, the more important organs, and at the expense of growth of the liver, kidney, pancreas, and muscle. So as we can imagine, if there is reduction in the kidney size, for example, it is associated with later onset of hypertension. Reduction in the pancreatic development. So pancreatic size is being shown to correlate with significant maternal undernutrition. And this is believed to be associated with later onset of development of diabetes because of a reduction in the beta cells that we are born with, similar to muscle. So again, sarcopenia at birth, it is associated with later onset development of diabetes and other insulin resistance parameters. So severe undernutrition definitely plays a role, but also gestational diabetes. And it is believed that gestational diabetes leads to impacts upon future health because of accumulation of reactive oxygen species, because of a reduction in the length of telomeres, because of these reduction of in the developing fetus, because of this reactive oxygen species. Not just GDM, any amount of hyperglycemia in the placenta itself is believed to lead to an increased release of pro-inflammatory factors, which then causes vasoconstriction and reduction in the blood flow. So the placenta also plays a key role here. If the placental size and functioning itself is affected because of the presence of hyperglycemia and ROS, again, that impacts upon fetal growth and development. Excess glucocorticoids have also been shown to be associated with excessive high blood sugars, but also reduced nephrons, and it also affects the ACE gene efficiency. All of these sets up the future development of hypertension in later adult life. Low protein intake in pregnancy. There is a lot of work done related to low protein intake in pregnancy. This has been associated with epigenetic modifications of both the ACE2 gene and therefore hypertension later on in life, but also reduction in the beta cell mass in the pancreas. Probably it senses it as a way of starvation, and it thinks that it should not, it does not need that much of a beta cell mass to begin with. And obviously this leads to later onset of development of diabetes. And reduced beta cell mass predominantly is associated with later onset of type 2 diabetes, not necessarily type 1 diabetes, but type 2 diabetes, because in type 2 diabetes, not only is there insulin resistance, say, related to the sarcopenia or reduction in liver size, but also there's a relative insulin deficiency because of this reduction in the development of the beta cells. Some other nutrients which have also been shown to play a role include low beta B12 and zinc levels in the sera of pregnant women, which has been associated with insulin resistance in offspring. High folic acid, which is associated with the increased risk of adiposity and diabetes, so the opposite. So excessive amount of too much of a good thing also. And low iron is associated with low birth weight and hypertension in later life and offspring. This data, which came from Pune, the Pune maternal nutrition study from Dr. Yagnik's group, has shown that maternal low B12 at 18 weeks and high folate at 28 weeks of gestation. So this cohort here is the one that is associated with the highest chance of insulin resistance at the age of 6 years in offspring. And why would B12 be associated with insulin resistance? So one of the ways it is believed that vitamin B12 is a key factor that is needed for synthesis of methionine, which is a key methyl donor. I'll be talking a little bit later on about DNA methylation. But for this DNA methylation to occur, you need this amino acid methionine, and for the synthesis of that, you need B12. When there is B12 deficiency, there is differential methylation of key critical genes, particularly in adipocytes, and that is associated with development of insulin resistance later on in life. So there is a good plausibility as to why, say, deficiency of vitamin B12 can cause directly insulin resistance later on in life. So not only is it about the various nutrients and protein and, say, carbohydrate and caloric exposure, but also prenatal exposure to organic pollutants, what are called persistent organic pollutants, particularly the DDE and hexachlorobenzene, the polychlorinated biphenyls, which is what we are exposed to if we are exposed to plastics and other things in our environment, other plastic things. These can also affect the fetal growth and development. These are associated with rapid growth and with the offspring being obese. So this is another factor we need to keep in mind, exposure to these pollutants in pregnancy. How does the fetus sense to all of these various sort of stressors that it is exposed to and thereby respond, causing problems later on in life? One is, of course, epigenetic processes. So epigenetic processes are the processes that occur after the sort of the fertilization has occurred. So it is nothing related to the actual genetic makeup of the fetus, but the factors that affect the surrounding of the genes, the epigenetic process. So these would include factors that affect the DNA methylation, factors that affect the histone protein, and factors that affect non-coding RNA. There is a lot of work being done on all of this. I just want to spend a couple of minutes talking about DNA methylation, in which most of the work has been done. So DNA methylation just refers to methyl groups being added predominantly to the DNA-based cytosine. And why this is important is that when DNA at the promoter site of genes get methylated, that particular gene gets turned off, it gets silenced. However, when you remove the methyl group, so when that base gets unmethylated, hypomethylated, then the DNA transcription turns on. So this methylation is sort of a on-off switch. So as we can imagine, if there is a change in this methylation for the various genes, the ability of the gene to transcribe and make proteins gets significantly affected. In the fetus, soon after fertilization, before sort of the blastocyst stage, there is an active paternal demethylation of the whole genome. So whole of the paternal genome gets demethylated. The maternal genome also gets demethylated. And after the blastocyst stage, there is a remethylation process that occurs. Now, if at this point, between the first sort of few days of the development of the zygote of the embryo, this gets exposed to fetal stressors, this demethylation and remethylation process gets affected, and various genes get affected in this, laying the blueprint for future development of adult diseases. So for example, tying it back to the nutritional status, studies done around the world have shown in Gambia, for example, infants that get conceived in the rainy season, when you have access to more nutrients, have hypermethylation of certain genes as compared to infants that are conceived during the dry season. So some of the genes respond differently depending on when the conception occurs. Similarly, studies done on women who were exposed to the Bangladesh famine showed that they had hypomethylation of several alleles as adults. And similar studies in China, when pregnant women are exposed to famine, in utero famine studies, as adults, they had higher total and LDL cholesterol. And obviously, this is linked to higher risk of cardiovascular disease. So exposure in utero to nutritional, either abundance or scarcity, is associated to differential methylation of various genes, laying the blueprint, like I said, for future risk of diseases. Sorry, let me just talk about this. So I mentioned violence during pregnancy. Violence during pregnancy has been shown to change methylation sites in the circulatory system genes. This is associated with increased risk of hypertension and cardiovascular disease in the offspring. Maternal obesity, again, linking back to the previous talk, has also been shown to be associated with alteration in the methylation patterns, increasing the risk of obesity in the offspring. Interestingly, exposure to paternal cold. So paternal cold exposure protects against diet-induced obesity in the offspring. So these are all various studies that have been done looking at methylation status per se and various fetal stressors and how it may impact on future health. Apart from the epigenetic mechanisms, the placenta also plays a very important role. The placenta is not just a passive bystander. We know that the placenta has a number of active transporters that are involved in transport of glucose, amino acids, and of course the fatty acids. So these sort of the production or the sort of transporters either get turned up or turned down in response to the stressors both on the fetal circulation and on the maternal circulation. Again, placental weight also, there seems to be a sort of a Goldilocks zone. So placental weight as a ratio of the birth weight is associated with the risk of dying from coronary heart disease later on in life. So the lower this placental weight or higher the placental weight, both are associated with higher risk of coronary disease later on in life, suggesting that the placenta also responds to this fetal stress and plays a role in determining the amount of nutrients and other factors that gets delivered to the fetus. So the placenta also plays a role. There are structural changes that have been noted in the placenta in response to stress in response to the maternal phenotype, in response to poor maternal diet. And these placental structural changes and oxidative stress within the placenta programs the fetus to develop diseases later on in life. And if you get a second hit, what is called this may be the first hit, second hit is, a poor sort of childhood nutrition, less activity during the growing years. All of these things then cause the second hit and lead to problems as young adults itself. So putting it all together, there is preconception health is very important. Poor nutritional status and obesity, stress, drug or medication use causes both epigenetic and placental changes in the mother. And this can affect the size of the baby at birth, both UGR and large for gestational age infants, and how they grow after birth. So in childhood, whether they continue to grow poorly or they have significant catch-up growth and then grow the other way. So this tends to happen more often in our country, where they are born very small and then they have significantly higher catch-up growth. And, we like to see chubby babies, so they tend to sort of overgrow as children. All of this impacts upon the non-communicable or other chronic diseases that we develop as adults, not just cardiovascular disease, diabetes, but also fatty liver disease, dyslipidemia, and as I mentioned earlier, also mood disorders. There's a significant amount of work done in diseases like depression and schizophrenia, and linking it back to maternal nutrition, which I did not share today because of paucity of time. But there are even other diseases that occur because of these fetal stressors. Now, knowing a little bit about what we do, what is a preventive strategy that we can practically take away from all of this knowledge? I think one is understanding the need for optimal health of both mother and father at the time that the child is conceived. So this is important. Of course, we counsel our mothers upon making sure their BMI is good and making sure that their blood sugar and their blood pressure and everything is in the proper range. Thyroid is good, for example, everything is good at the time of conception. During pregnancy also, we need to ensure that they maintain a healthy diet with a metabolic and nutrient balance. So not over or under exposing them, but the most important nutrients that have been studied so far include, like I said, iron, folic acid, vitamin B12, zinc, probably other things would include iodine, all of the things that we commonly think about, trying and ensuring that these are all in the optimal levels for the mother. And I think this is most important. Avoid overfeeding after birth, ensuring that the children eat according to their hunger so that they grow normally, not force feeding the child so that they attain a certain sort of arbitrary weight. And of course, regular physical activity always remains a must so that we can reduce the impact upon this exposure to fetal stressors later on in adult life. So that was my last slide. I'm going to stop here. And I hope that I was able to convey a little bit about this new and fast developing field. Thank you very much. You're on mute.
Hello, Sinu. Sinu, we can't hear you. Please unmute.
Yeah, yes, ma'am. Can you hear, ma'am?
Yes.
Yeah, now we can.
Thank you, ma'am, for the informative presentation and making an interesting presentation on a subjective topic. What we learned from this talk is the importance of diet before conception and healthy diet at the time of conception, and to avoid overfeeding the children if they are born IUGR. And also the importance of placental weight and birth weight ratio, which is a determinant of coronary artery disease. Thank you, ma'am, once again for the beautiful presentation.
Thank you.
And thank you from my side, Dr. Jayashree, for that
thank you, madam.
Towards me for because I gave you a very short notice, and you really that shows your commitment to the profession.
Thank you so much, ma'am. Thank you.
Have a good day.
Moving ahead, next talk, which is the last talk of today's session, is maternal collapse management algorithm. Outcome for mother and baby after collapse depends on the cause of collapse, gestational age, and access to emergency care. So to talk on this, it's a pleasure to welcome Dr. Madhavi for this session. Can we have CV of Dr. Madhavi? Dr. Madhavi is consultant in Stepping Hill Hospital, Stockport, NHS Foundation Trust. She's lead for fetal medicine, SGA audit lead, and regional SGA group member. She's educational supervisor and faculty. Over to you, ma'am, for the presentation. Can you share your screen, ma'am?
Mine is a recorded presentation.
Okay, okay.
Able to play it. Good afternoon, everybody.
2 minutes, ma'am.
Thank you.
Thank you, Madhavi, for joining us from the UK. And I know it's early afternoon for you, and we are keeping you awake on a Sunday morning.
No, that is absolutely fine. It was wonderful listening to the last two talks, which I could join in. And unfortunately, because of the time difference, I couldn't listen to the others, but I'm looking forward to watching them later. And thank you for the wonderful organization.
Thank you so much for your kind words.
I think.
Ma'am, it will take 2 minutes. Sorry for making you wait.
Yeah, that is
a technical
fine.
error, ma'am.
I sent in the video thinking that would be more foolproof.
It will be ready in 2 minutes, ma'am.
I'm sure. Thanks. For me, talking about this vast topic in 20 minutes is one, and of course, keeping your attention after a long day, and I'll try my best to do both. So let us start off with looking at the definition and recognizing the at-risk woman and how we adopt a structured and systematic approach in managing the collapsed woman. So the Royal College has recently published an article on maternal collapse, and the definition is it's defined as an acute event involving the cardiorespiratory and or central nervous systems resulting in reduced or absent conscious level and potentially cardiac arrest and death at any stage in pregnancy and up to 6 weeks after birth. So who is this woman at risk? We all recognize all these complications in maternity, obstetric emergencies as we know them, and any woman is at risk of any of these at any time. So how do we recognize this? So in the UK, we use what is called a track and trigger scores, which essentially means we record the blood pressure, the pulse, the respiratory rate, the urine output, oxygen saturations, and the conscious level and pain scores for each woman continuously on a chart, which then gives a score. Early warning score is used for the non-pregnant, and a modified version of it called modified early warning score chart is used for the pregnant women. So it identifies early patient deterioration, which then makes us escalate it to more senior personnel. So these charts, the modified early warning score charts we use look a bit like this. There are different versions in the different hospitals, but the theme is the same. So it is color-coded, and each of those rows represent one vital sign. For instance, pulse rate or heart rate, systolic blood pressure, diastolic blood pressure, and etc. and etc. So if there is a vital sign which is scoring in the red zone or 2 in the amber zone, it gives a higher score, and that prompts immediate medical review. So this again was published, this algorithm was published by the RCOG, and this is what it looks like. And it can look quite daunting with its various components, and especially for an obstetrician who doesn't deal with acutely ill women day in and day out. But I will try and break these various components down and talk about each of them, so we are all more comfortable when it comes to managing a collapsed woman. So the first and foremost thing to remember is when you are faced with a collapsed woman is to talk to her and check that she's okay. So saying, hello, are you okay? And eliciting a response at the beginning is the most important step here to then understand which pathway we follow. So if you do get a response from the woman, you know she is alive, she's not in cardiac arrest, and you follow the pathway on the right-hand side where you call for help, you assess her breathing, her airway, her circulation, and look for the underlying cause for her collapse and direct treatment. One of the most important things that you need to remember in any pregnant woman is ensuring to put her in left lateral position or manual uterine displacement. If the woman does not respond to your stimulation, the next thing you do is call for help and call for the right help, the cardiac arrest team. You then focus on the airway by opening the airway, doing airway maneuvers, and look for chest movements and breathing. Assess for breathing for up to 10 minutes. And if there is breathing, you once again make sure you follow airway, breathing, circulation, the algorithm, the simple algorithm, and assess the cause for the collapse and direct treatment accordingly. Now, if the woman is not breathing, you should immediately start CPR with 30 chest compressions to 2 ventilatory breaths at a rate of 100 per minute, depressing the chest wall to 5 to 6 centimeters in the center of the chest. Of course, in a pregnant and gravid uterus, you may have to move slightly higher. You also attach a defibrillator as soon as it's available and assess the rhythm. When you assess the rhythm, you then see if it is a shockable rhythm, which takes you to the left-hand side of the algorithm, which is ventricular fibrillation or pulseless VT. Most modern AED machines give the diagnosis and the instructions. You shock the woman and continue with the CPR after assessing if she's responded. The CPR then carries on at 30 to 2 and intermittently you shock the woman and check for response. If the rhythm on the machine tells us it's asystole, which is a flat line, or PEA, which is pulseless electrical activity, where there is electrical activity, sometimes looks almost normal. However, there is no cardiac output, in which case you immediately start CPR at 30 to 2 for 2 minutes, reassessing every couple of minutes. You may want to give adrenaline early in this category, and adrenaline is given after 3 cycles in this category on the left-hand side. During CPR, as you work as a team, you follow the structured approach and delegating your team members each of these components like airway, breathing, circulation. You allot somebody to do the IV accesses, IV fluids, taking bloods. All this happens simultaneously, not necessarily one after the other, but the most important thing is airway. You look, listen, and feel with each of these components. Let me talk a bit more about each of them. The general principles are you call for help early and you call for the right kind of help. You want the most senior obstetrician, midwife, anesthetist, pediatrician. Sometimes you may need to involve a hematologist and most often an intensivist. Remember the tilt. It's either a manual displacement of the uterus or a left lateral tilt at a 15 to 30 degree angle to relieve iotocaval compression. And you check for response after each of these interventions to see if you have succeeded. And all along, you will be looking for the cause of the collapse, because unless you manage to treat that, you have to carry on doing CPR. So what are the physiological changes that affect the airway in a pregnant woman? We all know the airway is more edematous in a pregnant woman, especially with increased secretions, especially in conditions like preeclampsia. And the woman is at a higher risk of aspiration, bronchospasm, and a difficult intubation. Of course, the drugs that we use in labor for pain relief, opioids, or if you're using magnesium sulfate in the management of preeclampsia or eclampsia, all pose additional risks. So how do you manage airway? So you basically look, listen, and feel. So you're looking for any obstruction in the airway itself, like swelling, secretions. You suction to suck the secretions. Look for seesawing movements, which is a paradoxical movement of the chest and the abdomen, which happens due to obstruction in the airway. What color is the woman? Is she cyanosed? Can she speak? Are there any additional noises which indicate obstruction? It's often the tongue that blocks the airway when the woman is unconscious. Feel for the patient's breath at the mouth or the nose using the back of your hand, which is the most sensitive part of your hand. And ensure airway is patent by using these maneuvers like chin lift and jaw thrust, using suction and using adjuncts like Gödel airway, and you check for response. So these are the two maneuvers which are very simple to do. With the chin lift maneuver, you're using your fingers under the chin and tilting the head backwards. And with the jaw thrust maneuver, you're using both hands under both mandibles and lifting the chin up and bringing the jaw forward. So adjuncts like Gödel airway look like that. They come in different sizes, come in different colors. Be familiar with which one is used for most women, and that's how you measure for the correct size from the mid-incisor level to the angle of the mandible. So oxygen supplement is vital once you have cleared the airway. Use high concentration, 100% oxygen at a rate of 15 liters per minute through a mask with a reservoir bag. And the target saturations to be achieved is 94 to 98%. We occasionally may come across a woman with COPD, in which case a target saturation that needs to be achieved should be less than that, going to a maximum of 92% even. You check for response after this intervention and move on to breathing. What are the physiological changes that can affect breathing in a pregnant woman? Pregnant women need more oxygen due to the increased demand from the placental, uteroplacental unit itself. There is decreased thoracic capacity mechanically because of the gravid uterus. Hypertrophied breasts, which can impede with successful or effective CPR. Increased gastric secretions, which put women at increased risk of aspiration. So the conditions as listed that can affect a pregnant woman, the most common ones are infection, pulmonary edema from preeclampsia, or embolisms. Pain itself can reduce the depth of respirations, and drugs like opiates, which we use, that can cause CNS depression, and magnesium sulfate, of course, can do the same. How do you assess? You once again look, listen, and feel. You look for the respiratory rate, the depth of respiration, the symmetrical movements of the chest. Is the woman using accessory muscles which indicate labored breathing? What color is the woman? Is she cyanosed? What are the saturations? You also listen. Is she speaking? Is she speaking in full sentences? Are there any additional sounds indicative of obstruction? And silent chest, of course, tells us the airway is completely blocked. It is an ominous sign. You also feel for symmetrical movements using your thumbs on the back of the chest. Percussion to rule out pneumothorax and hemothorax, which are unusual in a labor room setting. However, they are more common in a trauma setting. You position the woman accordingly. You may want to sit her up if she's conscious and give high flow oxygen with bag and valve mask, and consider chest physio and nebulizers which come later on. Again, you check for a response. If the woman is not breathing, remember the left-hand side of the algorithm. If the woman is not responding, there's no cardiac output, you start the CPR immediately at 30:2 ratio of compressions to ventilatory breaths. You connect the defibrillator and assess the rhythm, like we discussed briefly before. You're looking for shockable rhythms, and you deliver shock at 200 joules and continue with the CPR. You only stop CPR when you deliver the shock. You ask your team to stand clear of the bed when you apply the shock, and you check for response. If it is a non-shockable rhythm, you continue with the CPR at the same ratio, and CPR is delivered exactly like in a non-pregnant woman at the lower part of the sternum, going down 5-6 centimeters in depth. Effective CPR is the only management for non-shockable rhythms like PEA and asystole, and you make sure you correct the cause. Most often it's due to hypoxia, hypotension, and a massive PE. Circulatory problems, physiological changes that happen in pregnancy are an increased circulating volume and hemodilution, which makes a woman more anemic, pregnant women tend to be anemic. Their blood is more viscous, resulting in embolisms. And of course, the itocaval compression we talked about. And all these conditions on the left-hand side, conditions that affect preload, conditions which affect the cardiac muscle itself, like cardiac disease, electrolyte imbalance, and afterload, conditions that affect afterload like sepsis, drugs. All these aggravate the circulatory problems. So again, you look, listen, feel. What are you looking for? The color, the urine output. Is it decreased? What are the signs of infection? Is she looking flushed? Is she hypertensive? Has she got adequate IV access? You do manual blood pressure. You're looking for the Korotkoff sounds. That is more reliable than automated machines. And remember, our pregnant population are young and fit. They tend to compensate for much longer, and hypotension is a late sign. So a tachycardic woman who's maintaining her blood pressure is good, but however, she may crash anytime. Check the temperature, check capillary refill time, which tends to be shorter when there is sepsis because of vasodilatation and longer when there is hypotension. How do you manage circulation? We are very familiar with this. Manual uterine replacement if we're considering CPR, or left lateral tilt if the woman is conscious. IV access in the form of 2 large bore cannulae, and do all the bloods, including lactate and cultures. Remember, these are very important in the management of sepsis. Fluid bolus, as we discussed, hypotension is one of the major causes for PEA, and giving boluses of 250 mils of crystalloid every 10 minutes, at the same time keeping an eye on the fluid balance, because you do not want to overload these women with pulmonary edema in a woman with preeclampsia, for instance. You watch the urine output by catheterizing these women, and you involve the surgical team, the anesthetist, early enough in the case of abruption or postpartum hemorrhage. And remember to use tranexamic acid, which is known to reduce the blood loss significantly. And check for response. You then move on to disability. This is AVPU score, which is a modified version of Glasgow Coma Scale. As you're all aware, GCS is more elaborate, and this is more easy to remember. Use this to assess how conscious the woman is, and protect the airway and correct hypoglycemia, correct seizures, for instance, status epilepticus. And it's always difficult to differentiate between that and eclamptic fit if the woman has just presented. However, you work your way through and manage seizures and manage pain. Sometimes concealed abruption can cause a disproportionate amount of pain. Again, identifying that early and acting is important. and also check for response once again, see if the cardiac output's back. E for exposure. This includes a head-to-toe examination of the front and back of the patient, specifically looking for things like a rash, bleeding, and signs of infection, especially if there is an abdominal wound following a cesarean. Is it infected? These are the clues you're looking for. And you manage the abnormal findings accordingly. And you, once again, check for response. No talk on maternal collapse is complete without talking about perimortem cesarean section. Most of us have not been, luckily not been in that situation. It's also called resuscitative hysterotomy by the non-obstetricians. What it basically means is you do a cesarean section for the benefit of the mother and not for the benefit of the baby. You consider performing perimortem cesarean section after 3 to 4 minutes into effective CPR if there is no response, especially if the mother is 20 weeks or greater. Doing it for under 20 weeks has not shown any benefit because there is not enough aorta cable compression. It can be done in any setting. This could include emergency department. Do not transfer the woman anywhere else and do it where you are, including when you are in the labor room. You do not transfer the woman to theater. You do it in the labor room. All you need is a scalpel and a couple of clamps. So you can use any incision. It could be a transverse incision or a midline incision in the skin and on the uterus. Whatever you are comfortable with, whatever you can achieve a quick delivery with. The maternal survival rate is quoted to be around 50%, and neonatal survival rate is quoted to be 38%. This is UCOS data, which is in the EMBRACE report. So once you've dealt with the emergency, you have to make a management plan going forward. You have to look at these charts, the Muse chart, the input-output chart, the documentation, and the plan going forward. You not only liaise with your own colleagues, you also talk to other specialties, the intensivist, the radiologist, for instance, if the woman needs further imaging, for example, intracranial hemorrhage in the case of eclampsia. The most important thing, or even as important as the algorithm, is debriefing the couple and debriefing the staff involved, because this can cause trauma in the form of post-traumatic stress disorder. So that brings us back once again to the algorithm, which we touched upon earlier on. And I hope this makes a lot more sense now that we've gone through the various components of it. And I really hope that you do not need to use this very often, but in all probability, we all will be using it time and again in our specialty. And I really hope that this little talk helps you remember the algorithm, the various important steps that you need to take to revive the collapsed mother. The references that I have used are mainly from the Resuscitation Council of the UK, where there are beautiful algorithms and specifically talking about the pregnant woman, and the RCOG Green Top guideline, which published the algorithm, and also the reports, EMBRACE, the UCOS reports, and our own material from our courses that we conduct in a hospital. Thank you very much for your attention.
Thank you, ma'am.
Thank you so much, Madhavi. I was not sure how we are going to cover this in 20 minutes when I gave you this topic, honestly speaking. But you did perfect.
Thank you.
You did perfect.
Thank you. I'm glad I met your brief. When Vidya, you gave me a choice of 4 topics, and I didn't know what the other speakers were going to speak on because I didn't have the program at the time, and I went for the most difficult one of the lot, in the sense putting together a presentation, and I'm glad I was able to do justice to that, I hope.
Perfect justice, I will say, not justice alone.
Thank you, Madhu ma'am, for the excellent talk. You made it clear all the important aspects of collapse. What you learned from the talk is the importance of modified early warning score. And even in any event of collapse, it should be teamwork with a structured approach. And the importance of physiological changes in pregnancy should always be given importance in managing a collapse. Moving on to the question and answer session. And first question is to you. What is the importance of debriefing in an event of collapse?
So it is very vital, as I said, not only for the couple themselves, they have survived a very major incident in their lives. The best time to debrief, possibly a brief debrief soon after the event. And in the UK, the partners are usually present in the labor room, in theater as well. So a member of staff is usually looking after the partner as well. Often, they would like a little bit of an update, especially when, you're doing things to the wife. So we are very conscious of that. Whilst there is ongoing debrief for the partner, once a woman is revived, we do a debrief for both the couple. And going forward, we also bring them back. They're once again seen before discharge for another debrief. And we see them back in about 6 weeks' time, for a full debrief of the events. Yeah, it is to answer more directly to your question, it's as important as the management of collapse itself is.
I fully agree with you, Madhavi. Like Sinu asked, this is one area which we practice less in our country. I have to agree with you. We do lots of maternity care, but when you sit down, talk to the family, sometimes it's not fully conveyed. That is where this set of practice should also come into our picture.
Absolutely. And the best person to do the debrief would be the person who was present at the time, and perhaps the person who led the team, because it is important you identify a leader and who has a helicopter view of everything that's going on. And that usually is the senior most obstetrician at the time. So it is important we arrange the debrief for, going back to this person and talking. That would be the right person to do that.
One more question, ma'am. In any event of collapse, what is the role of multidisciplinary team?
Very, very important, very crucial. And it's not only for collapse, for all medical emergencies, for all obstetric emergencies, we always work as an MDT. We shouldn't forget the role of every single member. That could be your junior most colleague or your senior most consultant. So every person's opinion is honored. At the same time, like I said, there should be an identified leader who has an overview approach as well. So like I said during my talk, we do involve our anesthetists, the hematologists, the neonatologists, because we may have to deliver the mother and pass on a very preterm baby to the pediatricians and the intensive care doctors.
Thank you, ma'am. And if you don't have any further questions, can you move further?
I just I spotted an error in the algorithm. When I was talking, I said 10 minutes, it's 10 seconds.
Okay.
Thank you very much for the opportunity, Dr. Vidya.
Thank you, ma'am.
Madhavi, keep in touch. Definitely, we'll catch up later.
Absolutely. Thank you.
Thank you for a valuable time and excellent session.
Thank you.
So bringing us to the end of the session, I would like to thank all the national and international speakers, delegates, and the panelists who logged in today for today's session and making our session a really interesting one. Before we wind up, a few announcements. At the end of the session, feedback forms will be issued to you, which you have to fill and send in the link provided so that we can issue participation certificates for those who have logged in. And those who could not log in through the login links, they have to log in through the YouTube link, which will be playing live along with the live sessions, which will be live tomorrow also. And we have been showing 10 spotters in between, which the participants have to fill and send into the mail ID, which is given along with the spotters. You have to mention your phone number and your name also along with that. So bringing us to the end of the session, a gentle reminder, we will be live again tomorrow at 8:45 a.m. sharp. Sessions will begin as scheduled, so please log in on time. Good day to all.
Thank you so much, Sinu, and it was a very well conducted day. I thank all the delegates, all my speakers, and faculties who were quick on time, and they were all from different parts of the world, and thank everyone. And my team who were there throughout to support the audiovisual, the SOCOMA and the IT, Shyam and Manoj, and Dr. Tasin for the morning sessions and Sinu for the afternoon sessions, Dr. Sajid, Vijay Lakshmi, and the whole crew. And let us gear up, come back after a night's sleep for another academic feast tomorrow from morning 8:45. Thank you all. Have a good day.